I think by now you would have got the list of what are the cases there. So
Okay.
first cases.
You've started taking the graft, sir?
Yeah. So case presentation will be done now.
Okay, the patient is under local or GA, sir?
Local.
Local anesthesia. So the case is being done under local anesthesia.
Yeah. We have anesthetist Dr. Rupesh, ENT cum anesthetist.
Okay.
These are local.
What are the medication that is being given for local anesthesia?
1 minute.
We have an expert in local anesthesia also. Aguila Sami is here. Sir, anesthetist, sir, enna kudukreenga?
Sir, we have given pre-medication, sir, with glyco and midazolam 1 milligram.
So you're not audible, sir.
Sir, we have given
not clear, rather.
Sir. Hello, can you hear
Hello?
me, sir? Hello, can you hear me?
Yes.
We have given pre-medication, sir, glycopyrrolate and midazolam 1 milligram.
Okay.
And then this is lignocaine 2% with adrenaline infiltration, sir.
It's pre-mixed mixture or
fresh one, sir. Then we
that's what is it, pre-mixed or you add adrenaline to 2% xylocaine?
No, sir, it is pre-mixed, sir.
Pre-mixed, okay.
Yes. And then we have given fentanyl opioid, which is 50 microgram.
Okay.
And then a little bit of ketamine, sir, which is 50 milligrams, sir.
Okay.
Hello.
Yeah, tell me, sir.
For what purpose you are giving glycopyrrolate? Because the glycopyrrolate will increase the pulse rate, thereby it will cause more bleeding.
Yeah, it's correct, sir. But ketamine has got produces more secretion, sir.
Okay.
So it will cause a lot of frothiness in the mouth. So if in case we need to, in emergency, need to intubate, we'll be in a problem, sir. So we'll give glycopyrrolate always, sir, to keep the mouth dry, sir. And tachycardia will settle by after some time, sir. Now the pulse rate is around 100 only, sir.
And also we are dealing with the external auditory canal which supplied by the vagus.
Yes, sir.
Dissociated anesthesia. Madam, you give ketamine for all local head and neck procedures or only for ear?
So not all cases, sir. Ketamine is not preferred.
Okay.
Most of the cases we don't prefer.
Antibiotic
So what is the general?
Generally, we don't give them. Generally, it's not there. Just fentanyl and midazolam is enough.
Why not use desmethyltromin? Don't have tachycardia. You will have a normal
cardiodepressant action, sir. It is cardiodepressant action, sir. So it depresses the function of the heart. So you have both hypotension and tachycardia, bradycardia. So in indicated cases, we do use it, sir. If there's adrenaline-induced hypertension, then we do use it, sir. But it has got sedation for a long time. So you have to give.
Can somebody brief regarding the case, please? Hello. Hello.
Yeah, 1 minute, sir.
Sumita, can you please? Yeah,
Yes, sir. So,
people have started coming, so I think you can start the process of
okay, sir.
presenting.
Good morning, everybody. So, we from
Good morning.
City welcome all the delegates for our 7th edition of ENDO ORL Surgical Workshop 2022. So, now we are proceeding with the first case, sir. Dr. Pradeep has taken the graph. So, it's a 35-year-old female who presented with right ear pain and right ear block with a mucoid discharge for the past 25 days. She gave a history of trauma to the right ear around 2 months back. So on examination, the right ear had minimal mucosal discharge with a central perforation in the anterior quadrant, and the left ear was normal. Next. So TFT right was Rini was negative on the right and positive on the left, and Weber was lateralized to the right. ABP was not reduced on both sides. Next one. Q2 audiometry, as you can see, shows mild conductive hearing loss on the right with a PTA average of around 36, and the left ear is normal. Next. So this is the impedance, and as expected, we had a B-type curve on the right because of the perforation, and the left ear was the A-type curve. So our provisional diagnosis preoperatively is right COM with central perforation. And the plan now is right tympanoplasty under local, and the surgeon is Dr. Sundar Krishnan. Thank you.
Dr. Shankar, am I audible?
Yes, sir. You are very clearly
Okay.
audible.
Dr. Pradeep is taking the graft and is suturing. Very
Okay.
soon we'll be starting surgery. I
Okay,
hope the audience have come there.
Yes, sir. There are fairly.
Okay. I welcome all on behalf of Krishna India Hospital. As Sumita has mentioned, this is the 7th live surgical workshop, and I hope all of you will benefit from this workshop.
Definitely, sir.
Though it is done a short notice, we have managed to arrange a good audiovisual system and other things.
Yes, sir.
Hello?
Yes, sir.
We got here a striker camera set with monitor,
Yes,
digital
sir.
monitor.
Okay. Is a 3-chip?
Yeah, 3-chip. And we have this 4K endoscopes provided by Stryker.
Okay. The
Yes,
sir, the image is capturing your backs.
the image will be coming on soon. We'll be assembling this now. I'm about to start. Professor Rajaram is here. Yes.
Sir, good morning.
Good
Morning, everyone.
Tell.
Shankar. Hello, Shankar. How are you?
Sir, fine, sir. How are you, sir? Long time no see. Can I see your face? We all like to see your face.
Of course, unemployed.
The tallest man. Ah, yes, there he is. Sir,
VIP.
good morning. Nice to see you, the same person as I had seen some 20, 30 years back.
26 years.
அப்படியே இருக்கீங்க sir. With all humor.
The light cable. Were you practicing during Corona time? Everybody there?
Sir,
Who else is there? Dignitaries in the front row?
we have Dr. Aisha, Dr. Ahila Sami. We have Vivek. Sorry, we have Vikram. We have a lot of ENT surgeons, sir.
It's put on break. Suresh is there. Suresh, hello.
Suresh is there.
Suresh has not come.
Hello, Sami, how are you? Oh, Hello, Sami, really put on break.
Anybody?
Shankar, can you hear me?
Ah, now I can hear you, sir.
Oh, I said, how are you? To Suresh and he walked out.
Oh, we didn't hear you at all. We were hearing Professor Surakrishna's.
Are you getting the endoscopic picture?
Ah, yes, sir. We are able to see it.
Konja
We have to do a little bit of color balance, probably in.
color ஒரு மாதிரி இருக்கு.
Color is a bit darker. It's not giving the real. We are used to stores. I don't know what they call in Stryker.
Pardon?
In stores we call it chroma, clara, and all that, sir. But here in Stryker, I don't know what they call. The color balance should. Now it is okay, sir. Just sir, Professor Siddharth Raj from Karpa Vinayaga has come, sir. Hello. 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 Hello.
Can you hear now?
Now we can hear, sir.
We had
Sir, Dr. Siddharth Raj, professor of ENT in Karpavinaya Medical College, just come, sir.
Who's from? Siddharth.
Dr. Siddharth Raj. Hello, good morning, Dr. Sundar.
Good morning, Dr.
So
Siddharth.
wonderful to see you.
I think first time we are seeing
Remove your
you.
mask a little more so that you-
Very nice to see you.
Ah,
I think we remember the good old days when they were assistants in Madras Medical College.
hello. Siddharth, can you hear me? Shankar, can you hear?
Hello, Dr. Rajanam, sir.
Ah, very good.
Oh.
No, I'm just taking out the mic,
Ah.
because we have a problem with the mic. One mic. They really the one with certain problem.
Sir, your voice is a bit. I think you can remove the mask and then speak. Maybe it will be clearer. But GSK sir's voice is clear.
Can you hear me now?
There is a little echoing when you speak.
Because I'm going too close to the mic. Is it
Cotton
okay
ball.
now?
Cotton ball.
Cotton ball. Is it okay now?
Yes, it is clear, sir.
Okay.
Can we have a look at the endoscope, sir?
Pardon?
Endoscopic picture.
Yeah, we are not getting endoscopic picture.
We are not getting the endoscopic picture.
Cotton ball.
Who is doing the mixing? Endoscopic picture, please.
Yeah, we'll just looking into it. 1 minute.
Audio visual. Hello. Who is doing the audio visual?
Yeah, we're getting it started out.
Sir, they are showing the general picture, theater picture. We want the endoscopic picture.
Yeah, we're just getting it done.
Process.
Okay. Anybody doing anything?
Are you getting the picture now?
No, sir.
என்ன பாருங்க?
We are getting Professor Rajaram's picture only.
You can't miss my picture. So big.
Endoscopy, please. Mixing Arba.
No problem. So meanwhile,
Got it? Got it?
are you able to see endoscope?
Yes, sir. We are
Okay.
able to see the endoscopic picture.
So I think I don't need to tell the advantage of endoscope. Maybe most of you are doing it and know about it. But anyway, I'll just explain a few points. Why endoscope? I'm using endoscope as a microscope. You can see the panoramic view which we are getting with the endoscope. So this, you can see the entire aortic canal one picture and the tympanic membrane also. So this is a good advantage in making incisions. So all you have to do is move the endoscope closer to the eardrum, you get a good focus. As you can see, the middle ear through the perforation, the round window niche, the incrustable joint, the stapedial tendon. So this is a very good advantage by using the endoscope.
Yes, sir.
Having said that, you can nowadays the cameras are so good, like so good that the picture quality is very good.
Yes, sir.
What
What are the places where you have infiltrated, sir?
In the 4 quadrants, one is here, 4 quadrant injection. Here, one is here, superiorly, here, anteriorly, and inferiorly.
And how much do you infiltrate?
I usually infiltrate more, maybe 3/4 of ml or 1 ml also sometimes. So it gives a good elevation.
What have you used, sir?
What is it?
Xylocaine or something else?
Xylocaine is adrenaline. I usually use 3 ml of xylocaine with 5 drops of adrenaline and 5 drops of distilled water. So this perforation edges, this is actually a traumatic perforation.
Okay.
Got repeatedly infected and then he developed a large perforation. So I'm just brushing the edges using a sickle knife.
Sundar Krishnan sir,
Yes.
do you infiltrate post-orally?
I don't.
Only canal.
Only canal.
Okay, okay. No post-oral. Okay.
Why do you use? Do you inject post-orally?
No, if you, for cholesteatoma cases, when you are doing
Even cholesteatoma, I don't use. Only ENDO
ENDO, but infiltration also only ENDO.
Yes.
Okay.
Suppose I take some graft, concave graft, I inject.
Okay.
That play region alone. But now normally it is in my thing it is not sickle like really. Very good. So in my experience, I feel that it is not necessary.
Okay, okay, sir. For stapes also only
Yes.
ENDO. Okay.
ENDO.
Okay.
So you can see how the edges are being removed. So why we are removing the edges is to freshen it and the ingrown epithelium, which prevents the tympanic membrane to heal by itself, can be nullified by this removing the edges process. Argos. Alligator. Any students have come?
Yes, sir.
Yes, sir. A lot of students.
Please encourage them to ask questions. Whatever it is there, right answer.
You can keep a mic in the center of the.
Sir, you are using Savlon as antifog. Am I correct, sir?
Yeah, Savlon.
For stapes also Savlon or something saline?
No, the Savlon only use because that's only is available.
Okay, okay. Because some people say that for stapes it is toxic and everything.
See, some people when I started doing skull-base surgery or Savlon, no, you should not use.
Yes, yes.
I used for skull-base surgery itself. Then why not for this?
Yes, sir. Yes, sir. That's a CADA?
Yeah, that's right.
2 minutes current மாட்டிக்கிறேன் endoscopy போவோம் காட்டன் வெச்சுக்கோங்க நான்
Is it Ahila Swami there?
Yes, sir.
I want a question. I'm asking you a question. Sundar Krishnan just said this is a post-traumatic case. Yeah.
Hello, Vikram.
Yes, madam.
2 minutes, there'll be an interruption. We are shifting from generator back to electricity. Huh? So meantime, Rajaram sir will be talking. Just 2 minutes. We'll,
Noted, madam. Okay, madam.
Yeah, endoscopic picture.
Okay, now, Sundar Krishnan just said this is a post-traumatic perforation. And after all, and then he also said recurrent infection. How do you make out a difference between a traumatic perforation and an infective perforation? Here you have a history of both. Is there any idea you can give? Yeah, I may make a guess. Anybody can make a guess.
Sir, your question was not clear.
What was the question again? Traumatic
You
perforation.
take your time. Just think. So it just occurred to me. Traumatic perforation appears in a certain way, whereas an infective perforation has a very clear boundary and border. You saw both of that here in this case. a clear boundary as well as a little tatters. There were tatters indicating subsequently it was infected. I wonder if you agree with that. We're just trying to get everything organized. Meanwhile, somebody can answer that question. Suresh is there.
Suresh இல்ல.
Can you hear me?
Sir, we are able to hear you, but it's
On
not
பண்ணி
Can you hear me?
clarity. No, sir, we are not able to hear you clearly.
உங்க தெரியுமா?
And your voice is breaking. Hello?
Hello?
Sir, your
Yes, sir.
voice is clear.
Shankar?
But, sir, your voice is
Illa.
clear, but
No audibility.
Dr. Rajaram's voice is
Shankar,
not.
can you hear me?
Now I can hear you. Hello?
நான் மியூட்ல போட்டுருக்கேன் சார்.
எந்த வரலையா இங்க?
Hello, hello, sir, can you hear me, sir? Shankar,
Yes,
sir?
ma. Yes, yes.
இப்போ என்ன ஆச்சுன்னு கேள்வி.
பேசுறேன்.
Two things. One is
Captain, just raise your hands if you can hear. Because we can't hear you.
ஆரோப்பா அது ஸ்டேபிள் யூஸ் பண்ணலாம். நம்ம அப்பா இதை ஷிஃப்ட் பண்ணுவா. இதை யூஸ் பண்ணி பார்ப்போம். நான் கூட சொல்லு. சரவணன் இன்சிஷன் ஆர்எஃப் இருக்குது. இந்த ப்ரோப்
they are shifting from the backup to the permanent supply, electricity supply. So that is why they are taking time.
ஹலோ
Yes, sir.
ஹலோ
Hello.
வரல. இது என்ன பிளேடு? அந்த பிளேடு இல்லையா? அது மோனோ பிளேடு. நீடில் 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 நீடில். ஹலோ
Hello.
ஹலோ
Hello.
Shankar.
Hello. Anybody there in the theater?
ஹலோ
Yes, sir. We are able to
Ah.
hear you. But we are not getting the
Shankar,
picture.
can you hear me?
ஹலோ
Yes, sir. A lot of voices. There seems
the you are able to hear now?
we are able to hear you, sir.
Getting the picture?
No, sir.
Endoscopic picture?
No, no, no.
But please see to that what is happening.
We are getting the program alone.
Endoscope picture.
No endoscopic picture. And we are hearing multiple voices. Sumita,
என்ன பாருமா?
Sumita.
Yes, sir, so you're not.
நிறைய பேர் பேசுறாங்கம்மா.
அது
பேசுன மாதிரி பாருங்க. ஒரே echoing.
இல்ல சார், அது பேசுறது கேட்காதனால ஒரு கன்ஃபியூஷன் ஆயிடுச்சு சார். சார் இப்போ எண்டோஸ்கோப் பிக்சர் கிடைக்குதா சார் அங்க?
இல்லம்மா. Now only we have got it. We have got it.
Okay, so and சாரோட வாய்ஸ் கிளியரா இருக்கா சார்?
Yeah, that alone is clear. And now
Okay,
we are getting the.
Can I
proceed with that alone, sir?
can I start proceed?
Yes, sir, definitely.
Okay. Now I remove the edges.
Okay, sir.
You can see beautifully the incudostipral joint, the stapedial tendon with the pyramid, and particulars is there, a ridge.
Yes, sir.
And that is the sinus tympani.
Color is a bit darker, sir. It is very reddish.
Just
The color can be reduced.
I'm getting a good picture here. Can you
Dr.
adjust audio visual people?
Dr. Sundar,
Yes,
this is Siddharth.
yes, tell me, Siddharth.
Yes, you don't do the freshening of edges.
I have done just now.
Okay, okay.
I'm just going to make the undersurface raw.
Yes, yes.
Meanwhile, I think the picture is not so clear. We'll try to adjust that.
Regarding the traumatic perforation, sir, it's
Yeah.
already torn. I mean, should we freshen the edges or
See, it is not a non-healing perforation, so it is better to
okay.
Do the pressuring.
Okay. And what about freshening the undersurface, sir? There's a lot of
That's what I'm doing now.
you routinely do the freshening in all the cases or only this case?
All the cases.
Okay.
So that's way to make sure that the graft sticks to it, to the remnant of the tympanic membrane. Now I'm going to make incision with the RF knife, monopolar. So you see, you can make, as you get the endoscope inside, you can see the reddish wound which is being created in the undersurface.
Yes, sir.
This underlines the significance of the endoscope. So just by going inside. So this, I'll just show you the landmark. This is the short lateral process, the malleus handle here,
Yes, sir.
tapees, incrustable joint, pyramid, and the stapler tendon. The facial canal you can see there. So, and the ponticulus, the sinus tympani is here, subiculum is here.
Yes, sir.
Okay. Now I'll make the incision with the RF knife.
So Dr. Madanagopal has come, sir.
Welcome, Dr. Madan.
Good morning, sir.
Good morning. Yeah.
Sir, what is the advantage of the RF knife, sir?
Less bleeding. If you have the luxury, you can do it, but it is not necessary you have to do it. So I'm making pinpoint cauterization and follow the incision with the regular knife or the Rosen's or Plester, whatever. So my incision is going to be from around a little bit before the 1 o'clock.
What is the advantage
Of
using this
the
monopolar?
bleeding will be less.
Monopolar, yes.
Bleeding will be less.
Radio frequency.
So just is because there I'm using it. I'm also
It's mainly to reduce the bleeding, no?
yes, Rosen's.
You don't make a continuous incision with this.
I feel it is better not to because it can cause collateral damage. So my incision is carried on up to the skin here so that the flap doesn't tear. So it is thicker here.
Yeah.
So you can see that almost there is no bleeding there. So whatever minimum blood loss will be there, which can hinder your vision, it is not there when I'm using this RF. So this is the first time I'm using it. So this incision has to be made through the periosteum and it should be elevated along with the periosteum so that there won't be any tear.
This seems to be a 300 technique, sir. Somebody is holding the.
Yeah,
suction.
suction is Pradeep is holding suction.
Okay. So there seems to be another hand also to it.
Yes, cotton ball.
And you raise the flap laterally, sir, because generally microscopic surgeons, they raise it posterior, I mean laterally also.
Yeah. I just include a bit of skin in this region.
Okay, sir.
So that the graft doesn't tear.
Okay.
Apart from that, it is not cotton ball. It is not necessary to come too laterally. So meticulously you can dissect and elevate the temporometal flap,
Yes, sir.
reach the annulus. Is the picture clear now?
Sundar,
Yes.
you don't do the vertical
Vertical sense.
at 12 o'clock and 6 o'clock position.
This is
Olden days we used to put vertical, only circular incision here.
yes. This is from 1 o'clock almost and 6 o'clock. Yeah.
Okay, nice.
Suction. So you can see a suction is being introduced by the assistant who's seeing the same picture,
Yes, sir.
the assisting nurse. So it's easy to follow the steps and accordingly
See
assist.
the external picture, sir, as to how you are able to hold the endoscope.
Yeah, please show the external picture.
There should be picture in picture.
Yeah, picture.
Just to show as to how three, probe-like things are getting into the small ear.
So you can see the annulus, which I am raising above away from the notch of the revenous.
Yes, sir.
You can see the medullary mucosa through that.
Yes. There seems to be some periostitis there.
Yes. You can see the medullary mucosa from the annulus distinctly. I'm just doing it slow so that everybody can follow.
No, sir, it's better to be slow.
Yeah, normally I would have finished by now.
But still, I feel the color of the picture can be reduced.
Tell the audio visual people, please. The picture here actually is good.
Okay.
Second line. Just see, I'm just incising the medullary mucosa.
We are able to see, sir.
Okay, this I like to do it here in this junction because there's no important structures there.
Yes, sir.
Okay, unless you have a high jugular bulb, there won't be any injury. So I've entered the middle here,
Yes, sir.
lifting up the annulus. So this is a chorda here, it's very thin. Dr. Agilasamy? Dr. Agilasamy?
Sir,
Any suggestions how you will do? I think you have done plenty of cases of endoscopic surgeries and presented worldwide.
one thing, I use the diathermy knife for the incision, which I have named as the Ahila's diathermy knife. Many people are using it for the whole incision. I use it. Only thing is the healing is a bit slow. There may be a granulation post-operatively.
Yeah, that's what.
Yes, but On the second week, when they come with the granulation, I put some steroid ointment over it, it goes off. But it during procedure, surgery, it makes life very easy.
That is true. That's why I hesitate to use this.
Yes,
But,
that's the one point I want to add.
RF, I think it's got less
Yes.
collateral damage.
Yes.
So I'm using plasters and elevating here.
Yes.
So that is the lateral process, malleus lateral process. Forceps, alligator. You can see a little bit of granulations there.
Yes, sir.
So my idea is just to put the graft over the malleus.
One more point, sir. How did you prepare the ear canal, sir?
No preparation or anything.
Hair, that means the hair. You don't remove it.
No. Cotton ball.
Why you use this? Why you use this instrument?
Plasters.
Now that you said that you're going to put it over the malleus, are
Yeah.
you going to freshen the malleus completely, or
Yeah, I'm going to skeletonize it.
skeletonize? Okay.
Sickle. Can see the handle of malleus there.
Yes, sir.
Yes. இங்க ஏதாவது ஆல்டர் பண்ண முடியுமாப்பா?
கொஞ்சம் பிரைட்னஸ் பாருங்க.
இங்க ரெட் ஆயிடுச்சு.
இன்னும் டார்க் ஆகுது.
It's a bit darker, sir. So you can.
Yeah, it is dark here also. They're trying to make some adjustment. No, adjustment.
Sir, you can give some wash.
Yeah,
take
right.
out the blood.
Is the picture okay there?
Yeah, wash, it will take out the blood. It will take out the blood. Yes. Now the field is nice.
Is this?
Now it is better, sir.
Okay, good.
இந்த லைட் இன்க்ரீஸ் பண்ணுங்க. லைட் சோர்ஸ்.
Okay, you can see the malleus now handled properly.
Yes, sir. Very clearly we can see.
Sickle. I orientate myself by the way I do it in the microscope. That is, you can see everything horizontally here, the malleus, the incrustable joint, etc.
Yes, sir.
Okay. Now you in endoscopic sinus surgery, ear surgery, the pathway, ventilation pathway can be addressed very nicely. You
Yes.
see the incision tube orifice there.
Yes, sir.
Okay, this is the primary ventilation pathway here between the malleus or annulus malleus and the incus.
Along the Prusac space.
A secondary is here, the tensor fold here.
Yes.
If it is present, you have to, or partially absent, then you have to open it.
The tensor tempering fold plays an important role in the ventilation of the.
Yes. So, Shankar is very expert in endoscopy anatomy. So we'll be releasing a book today, which Shankar has written a chapter. You can
Yes, sir.
see. You can
Yes,
see
sir. It is available here, sir.
Yes. You can see the stapes, posterior cura, anterior cura, the
Yes,
facial
sir.
canal. That is the adductus there section. Grafted.
Now it is clear, sir.
Yeah. So I just put a 30-degree endoscope and show you other structures. So the carotid canal will be here. Internal
sir.
carotid.
Have you ever seen exposed carotid canal in
Yeah, when I did this.
exposed carotid decent?
When I did this, what is Peter-Stevens cholesterol granuloma,
Yes, sir.
we were able to see the pulsations. So that is the
Oh,
cochlear-formous process.
okay.
Understood. After opening the Peter's apex, in that case is very does not well pneumatized Peter's apex. So we are very close to the carotid at that time.
Okay.
After removing opening it, we could see the pulsations. Am I audible? You have to raise my voice. Am I audible?
Yes, sir.
Okay. So in that case, we encountered the carotid. Luckily, we didn't damage it.
Hmm.
So now I'm just using a 30-degree endoscope.
Okay, so you can identify the structures, sir.
Yeah, you can see the interstitial joint.
Yes, sir. You can use a pointer or something so that we can,
Crowd pick.
the
Yeah.
students can identify.
Definitely. How is the crowd there?
Yes, sir.
Okay, this is the malleus which have been skeletized.
Yes, sir.
This is the bar face. The interstitial joint, the long process incus. The septal.
Stapedius and pyramidal process,
Yes.
promontory, round window.
Scura. Cochlear-formous.
Yes, sir.
Just
Process is cochlear.
Process cochlear.
the adductus, you can see it is patent.
Yes, sir.
No need to curate or open the mastoid in this case, 0.
Yes, sir. There's no discharge.
So I'm just proceeding with putting a graft.
Yes, sir.
Meanwhile, under case ஆரம்பிக்க now.
Sir, did you check the mobility?
I'll do it, 0.
Mobility.
Yeah, it's an important point you raised, Dr. Ragla.
Yes, sir.
Must always do it to see every secondary atherosclerosis is there.
Okay.
So, the intermittent person.
So you can give another wash, sir. We'll be
Yeah,
able.
sure.
Little camera tilt is there, sir.
I'm just trying to focus it. Is it okay now?
Yes,
yes,
yes.
sir.
Wash. In this case, I think the anatomy is fairly good for you to understand.
Yes, sir.
Oh. Cotton ball. So in the afternoon, we will be having a revision staphylectomy
Okay, sir.
where patient has been operated in the US.
Oh,
Put the fish processes got displaced. I think even during the surgery itself, after surgery, patient is not able to hear. So it will be, I think, a good, interesting case.
oh, wonderful, sir.
Graft.
When do you prefer cartilage, sir, for myrioplasty?
Cartilage, you feel the
Myrioplasty.
tympano, I mean, the tympanic membrane is thinned out, very atelectatic, then I would prefer to do it. In large subtotal perforation also, I've done which cases where initially the hearing, everything is good. But after some time, the graft becomes medialized and the hearing reduces. In those cases, I think it's better we do cartilage. Is the anatomy clear now?
Yes, sir. Mobility.
Yes. Thanks for reminding. Pickle. Pickle. So I'm just moving the antler malleus.
Yes, sir.
Moving. Round window reflex here.
We are able to see the reflex, sir.
Yes. Oh.
Wonderful.
Hmm.
Although it seems to be some 36 decibel hearing loss.
Yeah.
So with the granulation and also the adhesion removal,
Yes.
patient will be hearing better.
Any other queries there? Everybody?
Anybody who wants to ask questions can. No questions.
Hmm?
You can.
Hello.
Yes.
Sir, good morning, sir. Dr. Nirmal here, sir.
Nimal.
Sir, which cartilage you will prefer, sir? Suppose if you are doing cartilage tympanoplasty, whether you will take concal or tragal, sir? Or
I am used to taking concal, but I think tragal will be, the concavity will be less. It will be ideally better than concal, I feel. But I prefer to take the, what is a concal cartilage.
Concal, okay. Sir. Thank you, sir.
Yeah. So I'm just inserting the graft and it is going to over the malleus.
Okay, sir. Dr. M.K. Rajshekhar has come, sir.
Good morning, Professor. M.K. Rajshekhar.
Thank you, Sundar. You are doing a wonderful job.
I'm very happy that you can make it. Your response when I called you was very heartening for me.
Always, Sundar Krishnan.
Yes.
Sir, you always use the dry graft?
Yeah, dry graft, yes. It is easier. I'm just tucking it over the malleus.
Okay.
Anteriorly. So
Do you any opening or a sector of, incision to place it as a cuff around the malleus, or just like that you can place it over the malleus?
You can, like you said, you make incision so that it will go and like what you say, enveloping the malleus.
Yes, sir. Enveloping
you can do that also, no problem.
Okay. There's a lot of controversy regarding gel foam, sir. Gel foam. What is your
I usually use gel foam for tympanoplasty,
yes, sir.
not in stapedectomy. I'm against that in stapedectomy because we store sometimes the gel foam in formalin, which can be very toxic for the inner ear, especially when
Okay.
you open the labyrinth.
Okay.
But for the tympanoplasty, I usually use gel foam.
When I was in KKR Institute, I
Hmm.
used to see Professor K.K. Ramalingam always uses a small piece of gel foam between the piston and the drum.
Piston and the drum, okay.
Drum.
To prevent adhesions. Or,
Yes, maybe. One piece he keeps, or small piece.
Generally, any inanimate structure should not be in touch with the external skin or the tympanic brain. Otherwise, it will start protruding.
Yes. You got extruded also. The piston might get extruded.
Exactly, sir. That probably is a reason.
Orange.
Sir, we are not getting the picture, sir.
Not MMC.
Picture only.
Illa, sir.
Private practitioner.
Picture, please.
Picture. Sir, we are not getting the picture, sir.
Yeah, we are looking into it.
Advertisement for Malar.
Welcome to all the delegates. I'm Dr. Kantamani,
Madam, good morning.
Secretary. Okay.
Good morning, madam.
I'm very happy to introduce Professor Dr. M.N. Shankar, Senior Consultant in Fortis Malar Hospital, Chennai. His expertise is known in extended endonasal endoscopic surgeries of the skull base, implantation surgeries of ear. He has co-authored by contributing a special chapter on endoscopic ear implantation in Handbook of Endoscopic Surgery, Ear Surgery by Professor Sundar Krishnan. This book is available in the stalls at this venue. Please give a round of applause to Dr. M.N. Shankar.
Thank you, madam. I don't think I
We are very
deserve
proud of you, sir. He has also given us a wonderful foreword in the book, and it's all about cochlear implant endoscopically. Congratulations, sir.
Thank you, madam.
I would now like to welcome Dr. Ahila Sami. I think he needs no introduction. He's internationally renowned surgeon and is very popular on social media, particularly for surgeries performance under local anesthesia. Welcome, Dr. Ahila Sami.
Thank you, ma'am. Thank you.
Proud of you.
Are you able to get the picture now?
Yes, sir. It's clear, sir.
Okay. I just finished putting the graft. You can
Yes,
see
sir.
you can see the graft there, nicely tucked there.
I don't know my mistakes.
I think you can go to the next case.
Yes, sir.
Sir,
We
you
have
have
not placed
placed
gel
gel foam in the middle ear?
Yeah, I'm going to do that now. In between, a lot of interruptions. Gel foam. I think we can shift it to the other theater since this is over. Is it okay? Excuse me? Hello?
Yes, sir.
I think we can shift to the other theater.
Sure, sir. Sure, sir.
Gel foam.
So no gel foam is placed in the middle ear.
I'm doing it now.
Oh, you're going to do it. Okay, sir. So placing gel foam rarely produces granulation, but most of the time it acts as a scaffold for preventing the medialization of the graft.
That is true.
So, and also creates a space in the middle ear.
Yes. I am very skeptical in using this in staphylectomy, like I told you.
Yes, sir.
Open graft, I either use a fascia or graft, packed graft.
Yes, sir.
No, no.
Sir, you are using a 4 mm telescope.
Yeah.
You don't use 3 mm?
See, 4 mm has got its own advantage. The magnification is good. The working, the light, the light is transformation is good. Whereas 3
Better.
mm better, yes. The picture
Better,
clarity is better.
But one advantage with the 3 mm is when you are visualizing the middle layer structures, you don't require a 30-degree telescope. With this itself, you can visualize better with a 3 mm. You can go very close in the middle layer.
Yeah, I have tried it several times, but I am happy with 4 mm.
Okay, sir. Okay, sir.
Actually, the 3 mm scope, the illumination is a bit lesser when.
Yeah, that's true.
Illumination is better. The
And,
thicker the endoscope, better the illumination. So you'll be able to see things clearly. So
also, the 3 mm endoscope will come with a shorter length.
stores is good. Sir?
Shorter length. Okay. So that when you're doing maneuvers with the instruments, there is some difficulty. Whereas this 4 mm with the ideal length is
Yes, sir.
better suited one for endoscopic surgery. And also, if you don't have to buy another endoscope for.
Exactly, sir. You can use for both nose and the.
Use. Okay, I think we can shift it to the alternate theater there for the next case.
Very nice, sir. I think
you.
the hall definitely will be grateful to him. We can give an applause for Professor Sundar Krishnan.
Well, thank you very much, Shankar, for chairing the session and the others present there.
So, Shankar sir, am I audible, sir?
Gel form.
Yes, Sumita.
Sir,
We're going to the next case.
Yes, sir. So, this is a 31-year-old male who presented with nose block both sides with snoring and throat irritation and cough for the past 1 year, sir. On local examination, there was septal deviation to the left with right inferior turbinate hypertrophy, and there was postnasal discharge. Diagnostic nasal endoscopy showed a septal deviation to the left with congestion of the nasal mucosa, and OMC osteometal complex crowding was there on both sides with minimal mucoid discharge in the middle meatus, sir. Next. Sir, this I will just skip off, sir. The surgeon will explain the scan picture.
Okay. Before that, I would like to introduce a chairperson for this session, Professor M.K. Rajshekhar, the workhorse of ENT for the past 30 years in MMC. Now he has gone to Balaji Medical College. And Professor Tirunavkarsu. So they will be doing the, they will proceed with the case.
Okay, sir.
You can continue.
Yeah. Welcome, sir. Dr. Rajshekhar, sir, and Tirunavkarsu, sir. So we'll proceed with the findings. Next.
So who is the surgeon, Sumita?
Sir, Dr. Siddiq, sir.
Yeah. You introduce.
1 minute, sir. Next.
Siddiq.
So the pre-op diagnosis is chronic rhinosinusitis with septal deviation. And the plan now is faced with septoplasty under GA, sir. And the surgeon is Mohammed. And sir will talk about the scan first, sir. Then we'll give an intro about the faculty surgeon that I think Dr. Kantamani madam will do, sir.
Welcome, Professor M.K. Rajshekhar. As you all know, he is the head of the department of ENT in Sri Balaji Medical College, Chennai. And he has specialized in sinus endoscopic surgeries and surgeries for OSA. Welcome, sir.
Thank you, madam. Thank you.
Kantamani?
Yes, sir.
Vasudevan, Pondicherry.
Hi, sir. Thank you.
Good morning.
Welcome.
Dr. Siddiq will explain the CT scan.
Yeah.
Siddiq.
1 minute, may I explain? I introduce Dr. Tirunavkarsu also. Can I? Welcome, Dr. Tirunavkarsu as chairperson. Is professor at SRMC, Chennai. He has completed a course in skull-based surgery at the Mayo Clinic, Phoenix, Arizona, and a course in advanced endonasal skull base and pituitary surgery at the Cranial Base Center, University of Pittsburgh, USA. A very warm welcome to you, Dr. Tilnakar, sir, from Krishna Indian Hospitals and all the organizers. Siddiq, surgical faculty.
Good morning, sir.
Good morning, Siddiq. How are you?
Sir, fine, sir. Thank you, sir.
Very good.
I'm very much happy to perform in front of my teachers and colleagues and my students, sir. I thank Professor Sundar Krishnan, sir, is giving this opportunity. So now, normal CT scan reading of paranasal sinus and septum and in and around the relation. This basic classes for the students. I'm audible, sir?
Yes, Siddiq. Very good.
Yes, sir.
Continue.
Yes, sir. So now we see the start from our coronal section, frontal sinus to sinus, frontal to sphenoid sinus. So first cut, your first cut by probe. Sir?
Siddiq, tell me.
Sir. So this is the start from the
Yeah, you are hearing. Tell me.
upper incisor teeth. This is the columnar of the nasal septum. Then second picture, frontal sinus, you can bone and nasal septum.
Siddiq, your voice is not clear.
Yes, sir.
Breaking.
It's okay?
Now okay.
Yes, sir. Now, sir?
Yes, okay.
Yeah.
Continue.
So second picture, you can see the bones on front sinus here. This is the cartilage nasal septum. Then this is anterior nasal spine. Start from the perimaxillary crest of nasal spine.
Okay.
Then second picture, these are the multiple frontal sinus you can see here. These are the frontal process of maxilla.
Okay.
The nasal bone, we have frontal process of the maxilla. Then nasal septum is there. Anterior end of the inferior terminus start to appear.
Yes. Right.
Now, both sides you can see inferior terminate. This is the septum. This is the frontal process of the maxilla. Frontal sinus with the intrasinus septums.
Okay, right.
Sir, the orbit, it is start to
going to appear. Yeah, going to appear, right.
Again, you can see the frontal sinus with floor of the frontal sinus. That is called frontal peak.
Okay.
So till here, it is frontal sinus.
Okay.
After this, if you see anything, these are the frontal recess without the floor. Then these are the inferior terminate. These are the nasal frontal process of the maxilla. What the air soda is appear just below the or floor of the frontal sinus is agar nasae.
Yeah.
Our lateral to the agar nasae is always lacrimal apparatus, sir. These two. Can you follow, sir?
Yes, sir. We are following you.
These are the lacrimal apparatus.
Okay.
Lateral to the agar nasae. The cell which appear in front of the presenting of the upper end of the cell is called agar nasae.
Agar nasae, right. Good.
If you sell more cell above the frontal cell, the frontal cell, according to the Kunz classification, they will divide into 4 types of cells. So you remember AFRS. First A means agar nasae. That is. Second is frontal cell. We have 4 types of cell according to the Kunz classification of frontal sinus and frontal recess. The third cell is frontal bulbar cell. The fourth cell is suprabulbar cell. The last cell is intrasinus septal cells. So these are the classification which misguide the frontal sinus entry while during the surgery. So when I am going to perform the surgery, I will show each cell orientation and relation with the roof of the frontal sinus. So this picture is frontal sinus still because floor of the frontal sinus. These are the inferior terminate. Our lacrimal apparatus still is there. These are the orbital. Now, agar nasae you can see nicely. Then middle terminate it is seen. This is the anterior third of the middle terminate, the both the side. These are the inferior terminate. This is the maxillary sinuses appear. Then our flora is, so you see the frontal recess. There is difference between frontal recess and frontal cell. So three difference I will show during my surgery. So in this level, you can see still agarnesis cells. So after which the our ethmoid cell will come.
Left la andari, right la varla.
This is the middle terminate. You can see that's my left
Right la.
peripherosa.
Yeah. So show me the uncinate processes.
No. So this is the uncinate process. You can see from the
Yeah.
inferior terminate coming like this, and going up to the skull.
Okay,
So
good.
upper end of the uncinate can be three side attachment. It's to the middle terminate or to the skull base or to the uncinate. If it is go from here to the uncinate means there is a recess that is called recess terminology. If we have the double terminate, as Hooperman said, double terminate is medialis of uncinate. If you see any cell here, infraorbital cell, that is called halar cell, which is not present here. So this is called bulla, this wall. Can you see?
Yes, yeah.
This is anterior of the bulla. This is called semilunaris. This is lamina peperosa. This is uncinate. This is anterior wall of bulla. Between three space is called ethmoidal infundibulum. The distance between the uncinate and the lamina, according to the Stamberger, it is 1.5 millimeter to 5 millimeter. So if the distance or treat the, so you better spend 10 to 15 minutes before doing the surgery. It is and lamina. So the space between uncinate and middle, you can see the middle. This bulla is status semilunaris. Space between the bulla and lamina and the uncinate is ethmoidal infundibulum. These are basics to understand. During surgery also you can see those things. So left side you can see the anterior ethmoid cell. Little bit it is extended to the infraorbital cells. So this may be the halar cells. See, all bullosa or bulla or front of bulla cell all may block. Our aim of surgery is what is the face, you know? Hello, I'm audible.
Yes, Siddiq sir, it's just on and off.
Breaking.
It's breaking.
Hello.
Yeah, now you're clear, but the transmission is breaking on and off.
Oh, sorry.
Yeah. You are going on about the aims of the surgery.
Aim of surgery is it is to facilitate normal mucociliary pattern towards the natural ostium by widening the osteomeatal complex area. That means the osteomeatal complex, the areas blocked with the halar cell or concha bullosa or balloon out of the bulla ethmoides or suprapullar cell, so many things can block. So to facilitate the normal mucal ciliary pattern towards the natural ostia by widening the osteomeatal complex without altering the normal functions of nose and sinuses. This is the definition of face I used to tell my students so that they can understand very well why we are opening the disease. So 4 points to be remembered for the endoscopic sinus surgery: to limited mucosa resection. Almost you should not touch the mucosa. Second, clear the ethmoidal infundibulum. That is key area for the disease. You have to clear. Then re-establish the drainage of all the sinuses. The last is make the sinuses get ventilation through the natural ostium. So this is called nasoantral window or natural ostium. This is called natural ostium, nasoantral window. The nasal, the maxillary sinus ostium formed by 4 bones. Number 1 is inferior terminate. Number 2 is lacrimal bone. Number 3 is perpendicular plate of palatal bone. Number 4 is our uncinate bone. All 4 bone only will decide the opening of the maxillary sinus ostia. Then the next structure, you can see the bulla ethmoides is very big in size. This is inferior terminate. Then middle terminate get attached to the lateral lamella of the lamina criperosa. This is crista calle. So according to our Keras classification is the vertical height of lateral lamina. If it is less than 3 millimeters, 1. Type 2 means more than 3 to 7. If it is 7 to 11 means or 14 means it is type 3 Keras classification. So between crista calle and lateral lamina, that space is called olfactory fossa. Okay, which is 17 millimeter height from the floor of the frontal sinus. Then now you can see this is the medial rectus muscles, this is superior rectus muscle, this is inferior rectus muscle, this is superior oblique muscles. So between 2 muscles, if you draw the line, it is called anterior ethmoidal artery. Anterior ethmoidal, next picture you can see very well. Yeah, this is anterior ethmoidal artery foramen. So anterior ethmoidal artery is branch of ophthalmic artery, which is arranged in the orbital cavity. Then it is in the frontal recess, I mean fovea ethmoidalis. Then again it will enter into the intracranium at the level of the ethmoid sulcus. Ethmoid sulcus is nothing but the weakest point of lateral lamina criperosa. So if you see the frontal peak thickness is 0.5 millimeter. Fovea ethmoid is 0.2 millimeter thickness. But this ethmoid sulcus, where the anterior ethmoid arteries is enter in the cranium, is only 0.05 millimeter. Very, very danger area. So that's why CSF in trauma, the site of leak is this side is very, very common. So that place only our middle terminate is attached with that point only. So again, you to go to the intracranium, it supplied the phalanx cerebri by anterior falcine artery, then comes out between the nasal bone and the lateral of cartilage, give the anterior branch, posterior branch, anterior branch divided into medial, posterior, and lateral branches. So this is anterior ethmoidal artery. It has the orbital cavity, then fovea ethmoidalis, then intracranium, then extracranium to the nose. So now, after the anterior ethmoid cell, you can see the posterior ethmoid cell. If you see, the size of the orbis reduced from anterior to the posterior, so our cell also become very large. These are the posterior ethmoid cells. Superior terminate start to appear now. Superior terminate. Then middle terminate turn laterally to the attached to the perpendicular plate of palatal bone. That is called groin lamella, third lamella. So first lamella is a uncinate, second lamella is a bulla, third lamella is our groin lamella, grand lamella, class lamella, third lamella. The fourth is superior terminate, fifth is our superior terminate. So after the ethmoidal case, you will get the sphenoid sinus. So from here you will get, this is inferior orbital fissure in the posterior wall of maxilla and greater vengada sphenoid. This is called inferior orbital fissure, the dichomotic nerve and maxillary nerve, inferior orbital vessels all comes from here. This is inferior orbital fissure. So above, these are the lesser vena sphenoid because it's not attached to the pterium. So this part is a superior orbital fissure. That is between the lesser wing and greater vena sphenoid. This is called superior orbital fissure. These are the sphenoid sinus with the intrasinus septum. Then above, you can see the optic nerve. So in this here, halar cell is absent. The halar cell nothing but posterior extension of the posterior ethmoid cells, 1.5 centimeter posterior lateral to the anterior wall of the sphenoid. This is called
The 1OD cell, not Haller.
180, yes, sir, sorry. So these are optic now. These are the carotid artery. So carotid artery is connected. Can you see the two foramen here? The medial most is Vidian canal. Lateral most, like 45-degree lateral, it is a foramen rotundum. So this Vidian canal, which is communicated with the foramen lacerum in carotid sulcus. So there the carotid arteries come here. These are the superior orbital fissure. This is the carotid artery, and this one is optic nerve. So these are the medial pterygoid plate, lateral pterygoid plate. This call is choana. So choana boundaries laterally with the medial pterygoid plate. These are the parental signs. These are the crater sphenoid. You can see the foramen ovae. I think a case is started. Sir.
Sidik sir.
Yes, sir. Thank you.
No,
Tell
thank
me.
you. Question irukku.
சொல்லுங்க.
So you've gone through the CT now.
Yeah.
Considering, I think the working diagnosis is CRS with septal correction, with septal deviation.
This is the basic case for to demonstrate for the.
Sir.
Okay.
You're planning to do an FESS,
Yeah.
Yeah. So at this point of time, after going through the CT, are there any points of concern on the CT which you would like to address?
No, nothing. Only. Sir is asking me to show the basic anatomy of the CT scan and surgery. That's all. Yeah.
Sir. So you feel that there is nothing particularly concerning in the CT scan?
No, it is there. Our nasal valve is very narrow and terminatus is very high. Septum is deviated. When I put the endoscope, you can see a lot of obstruction inside. He has the breathing problem while exertion. So we thought of snoring also. We did the sleep study. Sleep study shows only age only 3.
Okay.
Not 20 or 25. All confirmed. So still he is telling that there is some blockage there. So Stamberger told the indication of stress is unpleasant postnasal trip. You can do it. Unknown headache. I mean, all investigation is normal also. If you remove the some cells, our nasal cavity. Why some people are getting the sinusitis, some people are not getting? We have 6 points to tell that. Amount of the secretion and composition of the secretion and condition of the cilia and patterns of the ostium and cleft of the our ethmoid infundibulum and mucosal resorption. These 6 points will differ from the patient to patient. That's why they are getting, some people are suffer from the sinusitis, unexplained pain in the between the orbit. So many things are they telling.
So
they are all improved.
What's your initial plan now? As a working plan, do you have a working plan? What do you plan?
Yeah, sir. Which I told, whatever here now, I'm going to perform with the surgery. All what is ansinotomy, what is ansinectomy, what is inflammatomy, what is ethmoid cell perforation. Something I'm going to perform.
So again, one more last one, purely on an academic question.
Yes.
How do you plan your CT? When do you plan your CT? At the first office visit of the patient, or do you? What is your usual protocol for planning for a
duration of the disease? If more than 3 weeks, the patient is every year it's coming, sir, during summer or this thing, we will plan the CT scan. But before CT scan, I would like to do the diagnostic nasal endoscope. We can pick up a lot of things from that.
Going on to introduction of Dr. Mohammed Siddiq. He's a senior assistant professor, Madras Medical College, very renowned, received many awards, gold medals for paper and video presentation at various national conferences. He has performed live surgical workshops at Bangalore and Chennai. Welcome, Dr. Siddiq. We are waiting to watch your surgery.
Professor Bharati Mohan has come, sir. Welcome.
We'll take it.
இது மைக் சரியில்லைங்கிறாங்க.
கவர்மெண்ட் பக்கத்துல
That was a good talk and சொல்லிருக்காங்க இல்லையா? What's with it? Oh, it should. It's not time. Very good talk.
Ladies and gentlemen, this is Dr. Rajaram. Finally, I got the mic. I welcome all of you. I can see somebody in red shirt. Red shirt. And that must be M.K. Rajshekar. Is that right? Raise your hands.
Rajaram,
Yes.
Rajaram.
Now, gentlemen, whatever M.K. Rajshekar says is untrue. Okay? Now I've got 5 minutes to keep you engaged till the next case starts. And so I thought I'll do some light talking. So I thought I would like to know Bharati Mohan, that handsome man next.
Yeah.
Yes,
Rajaram, before that, I want to say one formula.
Yes.
That formula you want to know now?
Formula.
Oh, yeah, your height.
Tell me,
Your-
I am a genius.
What's your height?
I know where he's coming to. No, gentlemen, he's going to say height is inversely proportional to the brain.
Development of brain.
Shankar, don't give the mic to him, please. Okay. Now that we all assembled, can I know how many people are there? Can somebody show me how many people? We have no idea. We have a feeling only 6 or 7 of them are here.
Rajaram, good morning. Vasudevan, Pondicherry.
Yes, Vasudevan. Where is he?
Arunadipan.
Where is Arunadipan? I can see them. I have to come close. Welcome Arunadipan. Vasu, my favorite. Yes. Vasu from Pondicherry. Yes. உங்களுக்கெல்லாம் வயசே ஆகாதா?
Are you sitting or standing?
Oh, that's nice. That's a nice joke. They're not taking me behind because in my pants have become, and it's short pants actually. அவங்களுக்கு long pants. I feel quite nude right down there.
3-4.
Now, I would like to know, I want a few questions from the audience so that they also take part. Do you see mucormycosis even now? Anybody can answer that question? Suresh, Siddharth is hiding there. Do you still see mucormycosis? Nobody is answering. Rajshekar?
No, I don't see.
Shankar?
Yes. Rajaram, still we are seeing mucormycosis.
Has it come down?
Maybe that got infected in the last corona period. Again coming with recurrence.
You are talking about old mucormycosis cases.
Yeah, coming with recurrence.
Fresh cases?
Yeah, maybe. That is also 1 out of 10.
There was a time when we saw mucormycosis once or twice a year.
But now every time, every day you see. And also those who are not treated with amphotericin are not coming now.
They are coming back now. Anyway, I think we are going to start the second case.
Yes, sir.
Can you
Yes, sir. Sir, am I audible, sir?
Yes, you are audible.
Thank you.
Siddiq,
Yes.
what is your plan?
Sir, now planning for basic tests, sir.
Okay.
Like middle metal androstomy and MMA.
Okay.
See, after the decongestion pack. So
No, what's your plan?
septoplasty with the terminoplasty, sir.
Okay.
See, according to scan, there is a space was there, but here there is no space at all this side. But it is now decongested.
But septum is in the straight. Septum looks straight.
Now we'll see, sir. This side also we'll see. The Professor Venugopal sir did the packing, so I didn't see the finding at all. Now
So as usual, Siddiq, Venugopal is always behind you, or you are always behind the Siddiq?
Yes, sir.
So here now also you are proving. Today also you are proving.
Only small spur is there, that's all. But okay.
That's bulging uncinate seen on right side.
Is it clear now?
Picture is clear, sir?
Yeah, very clear, Siddiq. Go on.
Oh, thank you, sir.
Good packing. Good packing done by Venugopal.
Yes, sir.
There is no trauma. There is no.
So first of all, any first case, I will tell some basic 5 points to be ready. First is preparation of the patients. So preparation, you do the give Visolone 30 mg per day for 5 days. On antibiotic also. This is the preparation for the patient. Second point is anesthesia. anesthesia, we want hypertension anesthesia, but nowadays they are telling don't tell hypertension anesthesia. We want heart rate only 60 to 70. PP doesn't matter because we are playing with the capillary, not with the big artery. So telling keep the pulse rate below 70. Further, they are asking to give ismalol, not like a nitroprusside. Then if the inhaler means they should not use halothin, it seems. So sevoflurane or isoflurane is a better choice to maintain the heartbeat. Third point is position of the patients. So head turn should be, you can see 30 to 40 degree elevation. It will reduce the 30% of blood flow in the head and neck area. Venous return will be increased to the heart. So arterial pressure will be reduced. Third point. The fourth point is you search for the place in the nasal cavity elevator. You have to orient yourself the patient anatomy. Like this is inferior terminate. It has got anterior end and posterior end. It has got two surface. It is medial surface. It is lateral surface. It has got superior border and inferior border.
Excuse me, sir. Can you
Yes.
make it little brighter and lighter? That is, it's too red. And secondly, it is dark inside.
They are telling that because of transmission problem, they will get a little low quality, sir, it seems. So now, sir,
Okay. Carry on.
so this is the anterior end of inferior terminate. This is lower border of the inferior terminate. This is upper border. Upper border, we have got three process. You remember MLE. That is maxillary process, lacrimal process. E is ethmoidal process. Our ethmoidal process for uncinate process, maxillary process for maxilla, and lacrimal process for
Lacrimal.
process of the lacrimal bone. So three process only there. Paul probe. Then second, you see the olfactory fossa. Very, very narrow here with high blood supply. Okay. Then you see the choana. So orient yourself anatomy before starting the case. Don't jump into do the tonsillectomy. So now here anatomy you can see upper part of the choana. This is the posterior end of the middle terminate. This is the eustachian tube. That is Taurus tubaris. This space is called fossa Rosenmiller. Then Paul probe. So I am starting the case in the right side. Uncinate. This is called uncinate. Uncinate. Okay. So there are three ways of uncinectomy. This is by Paul probe. Some people will perforate here. They will enter the maxillary sinus. This is the first they used to do. Then second way is using the backbiter in the junction Nichols angle. So you can see the ostium. It is a natural or accessory ostium. Mostly it is an accessory ostium only. Because natural ostium cannot be seen. Because ethmoid infundibulum we didn't open so far. Then the third method is swing door technique. Swing door means PG Perumal told you cut here with the blade and cut it at this level with the backbiter, remove the middle portion. So we have got three part of uncinate: upper part, middle part, and lower part. So lower part is attached to the perpendicular plate of palatal bone and ethmoidal process of the inferior terminate. Then middle part is attached to the frontal process of the maxilla and lacrimal bone. Upper part attached to the three level skull base or middle terminate or lateral lamina preparatio. So these are the three part. If you see the middle terminate, we have part anterior 1/3. It is a vertical sagittal part. Then this is posterior part. This is a horizontal part, which cover the roof of the middle meatus. This is the middle meatus, it cover. Then middle part turn into lamina peperacea. This is called corona lamella, where it's turned laterally to the lamina peperacea. This is called the third part, that is frontal or coronal part. So sagittal part, coronal part, and the horizontal part. Now, where the space between the uncinate and the middle terminate is called hiatus semilunaris. Hiatus semilunaris inferialis. If you go between the bulla and the middle terminate, this little shape area is called hiatus semilunaris superialis. The Grunwald told naming of after this. Right. So, give the back paper. So, this is the plexually backbiter. You open and engage the uncinate and turn like that. Then you can cut till the hard bone come. You can do 1 or 2 or 3 or cut you can do, because anteriorly you will get the lacrimal fossa. Till I am getting the softness only. Now I got the sound. Okay, Paul bro. Now you can see the ostium now. It is attached with the debrider. So this is the our horizontal part. You can divide like this. Merosul kettene. Merojel. Gel from there. Now you can remove the horizontal path with the micro debrider or using the Paul probe and remove the bone alone. So this is the accessory osteum and natural osteum. Both are connected now. What is the purpose of accessory osteum? Professor A.K. sir used to tell it is invade the infection to the sinus, it seems. So that is the accessory osteum function. So you should not keep that one.
Siddiq, you noticed one thing.
Yes, sir.
CT scan almost normal.
Yes, sir.
But in the DNA, we found out accessory osteum.
Yes, sir.
That means it shows chronic sinusitis.
Yes, sir. Thank you,
So
sir.
justified in doing middle meatal antrostomy in this case.
Yes, sir. Yes, sir.
So the DNA is very important, more than CT scan.
So debrider, it will only cut and suck the...
Correct, Aguilar Sami?
Irrigation is going to be...
Yes,
45.
yes, sir. Okay.
Debrider is getting ready now. So you can microfracture of the middle terminal little bit, so that you can plan spacing the place to operate. Okay. Ready, yeah? So now?
Hello, yes, sir, Siddiq, sir.
Yeah, yes.
Considering you're using a powered instrument.
Yes, sir.
I mean, there are a lot of junior delegates over here. Could you elaborate on some tips and pearls on using a powered instrument?
You should see the opening of the blade. Without seeing like this, you should not do. In in frontal sinus also, you use the 70° and do it. But without cutting seeing the tip of the instrument, we should not do. See, it will take out only the mucosa, it will not pull it. You can use the plicacy also. No ma, speed, no. Okay, 45. Paul probe. So this is our vertical part where I told attached with the lacrimal bone and frontal process in maxilla. This is the upper part of the bone. You have to mobilize till the loosening of the upper end. Yeah. Is 45? Yeah. Sir, good morning, sir. Welcome, sir.
Present போட்டுருச்சு பார்த்தேன்.
இல்ல வீக்கா போட்டு வந்திருக்கேன். சார் எப்படி சார் இருக்கு பிக்சர்?
இல்ல அது கொஞ்சம் டெப்த் இருக்கு.
I can feel that one also.
Siddiq.
Yes.
What about submucosal uncinectomy?
That you, sir, uncinate is a main culprit to form the disease in the maxilla, sir. So you should not keep the mucosa in that level, because same mucosa only overlaying over the lateral wall of the nose and medial wall of the nose. So it is not like a uncinate mucosa or something else like that. It's debrated. So bulla also a little bit to the opened now. 70°.
Do you always do the backbite resection or just elevate the mucosa, see the entire uncinate attachments of horizontal and ascending parts? After ascertaining all those attachments, then only you do, or you straight away go and take a bite?
I like that. If you are not removing the upper end, that is the main failure of the fist. Our distance between the uncinate and the lamina is around only 2 mm or 4 mm only.
I mean, in this case, it should not really matter. I mean,
it is.
I mean, whether you remove the upper part or not, because
that's correct.
Purely limited. So I think what the juniors also should understand is mostly FES is a very tailored operation. There is no one size fits all. And with regards to your antrostomy, I've seen it's a pretty large antrostomy. Is it for the purpose of demonstration you made a large antrostomy?
No, we have curve section. See, we have 4 type of middle meatus antrostomy. The type 1 is curved section. Type 1 is what we normally do here. Type 2 is if you are enlarging the perpendicular plate of palatine bone here. If you cut, that's type 2. Type 3 means if you cut the floor of the maxillary sinus still here. In case of the mucormycosis, some cases of AFRS. If you come till anterior like extended facial recess approach, this is for perilacrimal approaches or Tenger's approaches. So the theoretically they tell nitrous oxide will be less production in the large maxillary sinus ostium. It is the problem of getting invasion, debrator, more infection. So make the small ostium or large ostium. It's not a matter. Keep more than 1 into 1 centimeter size. That's enough. Scott Brown say you keep 1 into 1 centimeter. It's enough. But it is.
So 3 mm is enough, isn't it?
Yeah, that is normally is 4 mm, sir. A normal size of the ostium.
See, such a wide ostia is needed for a fungal or a tumor, something like that. You are doing for, you told you are doing for nasal stuffiness.
Yeah.
Then why are you doing such a very big ostia?
Yeah. See the posterior border of the axillary sinuses section. If you cut this, that will produce the stenosis. Now you can see the maxillary sinus.
One more, Siddiq. You
Yes, sir.
told you are doing first for nasal stuffiness.
Yeah.
Any textbook is mentioning for nose block first?
Yeah, Stamberger, page number 62. You can
Okay.
refer, sir. So this is the infraorbital nerve. This is infraorbital nerve. This is the posterior. Why we should expose the upper wall of the maxillary sinus means if you draw a line in the upper wall from the septum, so below this line only sphenoid sinus will be there always. To find out that, you have to expose the upper wall of the maxillary sinus. So imagine the line you draw from here till the septum. Below this line only you will see the sphenoid sinus. Now, 70-degree endoscope.
Can you hear me, Rajshekhar? Anybody can hear me?
Yes, sir. Yes, sir.
Yes, tell me, Rajaram.
The question that was asked is, why did you make such a large osteomyarthy complex? I mean, the opening.
Yes.
Siddiq very clearly said that this is for demonstration purpose.
Okay, right.
Now, I'm using the 70-degree, see the frontal area. All broke. Success. See, this is the unsnate, still some mucosa is there. I will remove it.
Yes. Okay, Siddiq, right.
This is bulla, upper end of the bulla.
And anterior wala bulla is the
Yes, sir.
anterior
Yeah,
wala bulla.
little bit cut. So now,
Between the anterior bulla and the uncinate, you can search for frontal sinus opening.
yeah, this is agar nese cell is going to come.
Okay.
Debrider.
All right.
The picture is not correct. So this is our MMA. You can see in 70-degree, you can see all the area. You can see the MMA area. You can see the our roof of the ethmoid and coin also. Yes, sir.
Siddiq,
Yes.
why
yes,
don't
sir.
you give a wash?
Yes, sir.
Hello?
Yes, sir. Yes, sir. That's
You give
good.
a wash because it is very dark. We can hardly appreciate whatever you are telling.
Yes, sir. I want a Nerosol pack in between also.
You keep some Nerosol or
Yes, sir.
keep
Yes,
doing
sir.
the white balance frequently.
Yeah, my white balance பண்ணுங்க. White balance. இருப்பா. Ascoli, எதுவுமே தெரியல. இருக்கிறீங்க செக்ஷன். கேட்கும். Debrider. So here high subtle deviation is there.
Siddiq sir.
Yes, yes, sir.
Would it be helpful to do a septoplasty before this? I mean, it's quite clear that the chambers are a bit narrow, pre-chambers.
Yes, sir. Yes, sir. I will do, sir. They given me 10 to 15 minutes now. So I will show one side face, and if time is there, I will do the septal correction.
I mean, just for the juniors.
Yes, sir.
For the juniors, I mean, you are a seasoned surgeon, so you will operate through the narrowed chamber.
Yes, sir.
But
yeah.
I think for the juniors, it'll be better if they do
septoplasty, jury. Yes, sir. I will do, sir.
do the septoplasty first and then do this side. I mean, quite obviously, we're talking about different levels of experience, so that's okay.
Side section.
No, there's still dark color.
Now, sir.
Okay, little better, but still more not.
Packing.
Okay. Still a lot of.
cut பண்ணுமா.
Yeah.
இல்ல வேணாம்.
ஒரு
enhancement குறைச்சிட்டு
ரிலீஸ் கொடுங்க.
Siddiq.
Yes, sir.
Can you tell what the camera you are using?
Take care.
The model.
Model, somebody can help
1432,
me.
like that, they will be having high definition.
See,
number
now
of the, number
you
of the
see
cache.
the magic of Merosol now. All blood will be sucked now. So you will see better quality. Suction. ஏமா இது வந்து too large ma. You have to cut it little bit also. So it is sucked now. So bulla wall is anterior there. So now I usually tell my PGs to open bulla anterior, inferior, medial. Not if you go laterally, you'll get the lamina. If you go superiorly, you'll get the fovea. So anterior, inferior, medially you open. This is bulla. You can see the bulla sign. So the debrider. So anterior ethmoid sinus is more in number and less in size. Because of so now this all garbage you can take it. You have to remove the every cell between the lamina and the middle terminate.
So many.
Now is clear, sir?
That's very clear, very clear.
Thank you, sir. Thank you, sir.
Is that Thirunavukarasu's voice?
No, sir, it was Bharati Mohan sir speaking. Currently, it is me.
Okay.
Any issue, sir?
Nothing.
Yes, we are a quarrel marriage.
So now you see multiple cells, side sections.
Yeah. Lot of hair cells. There's our hair cells, ethmoidal hair cells, Siddiq?
Yes,
All
sir. Yes, sir.
15 to 18 for postgraduates. 15 to 18 ethmoidal hair cells are there.
So this is called coronal lamella. This will terminate from here. It will tell. Yeah, Merosol.
Oh. So that's anterior ethmoidal curve also there. I'm going to see anterior ethmoidal artery curve.
ஏமா இது ரொம்ப பெருசுமா. Professor Sundar sir told me to demonstrate all basic anatomy, sir.
Okay. Continue. You are doing good job, Siddiq.
Thank you, sir. Thank you, sir.
Sir, you are selected.
Thanks, our professor, sir, and Madam Kandamani, Madam, and the Krishna Eye and ENT Hospital is giving this opportunity to operate in front of you and my colleagues, my friend, my students, sir. Thank you, sir. See the magic of all Merosol. Every blood will come out.
நான் கேட்டேன் அவங்க எடுத்துட்டு வரல நானும் கேட்டேன் ஆமா அதனால
மைக்க கொடுப்பா.
Am I audible?
Yeah. Siddiq.
Yes.
Will you debride only the partitions or you remove all the mucosa?
Yes, sir. I'm going to remove, sir.
All the mucosa?
Yes, sir. I want to show the coronal lamella as a in single picture, third lamella.
Well, to make it a functional surgery, all those mucosa should be preserved, lining mucosa.
Yes, sir. That's what I told during CT scan. Side section. Our aim of surgery is re-establish the drainage and make the ventilation through the natural ostium, and limited mucosal resection is allowed, sir, in the face. They will tell mucosa preserving. It is not at all possible because mucosa, if more than 5 millimeter gap also, it will grow. Like our tonsillectomy cases. And nothing will happen. If you take picture after 3 weeks, this all mucosa will become normal. I have taken the photo also. So this is the posterior ethmoidal cells. Now we are getting.
How to differentiate anterior ethmoid cells from the posterior ethmoid cells?
That is glomerulus. So glomerulus have the main our landmark between the curves in the section. So that is small cells are anterior ethmoid cell and more in number. With whatever cell get posterior to the coronal lamella. Posterior to the coronal lamella is a large cells and less in number.
Okay.
I think pulla is not up to the skull base, so that is called suprapular recess here.
Okay. Sadiq, can you show the anterior wall of the anterior bulla?
This is the anterior wall.
Which one?
This one.
Bulla.
This mucosa is still some bone is there anterior wall. See the bone.
Can you show us the frontal cells?
That is only I am going to. There is no spores here. So this is our middle terminal attached to lamina crepiriosa here. So I have to open the frontal sinus here. Covered section.
Is it now possible to see the anterior ethmoid artery?
No. After removing the agar nasae and you have to see the frontal recess. Then after frontal recess only, you will see the anterior ethmoid artery. Now only incidence is going up, upper end of.
At this juncture, in this kind of exposure, can we see the posterior ethmoid artery?
No. See, this is the agar nasae.
Okay.
You see, it is not frontal sinus. It is a agar nasae cell.
Okay.
Mirazol, chinnada kuduma.
You want to change the angle scope or still in?
Yeah. I'm asking to give this middle terminal mucosa should grow in the frontal recess. This is called frontal recess area now.
Okay.
So frontal recess boundary is laterally by the lamina and medially by the middle terminate and superiorly by the our fovea ethmoidalis and inferiorly by the suprapular recess. 70 degree.
Sarah.
70 degree.
ஒரு ஆங்கிள் மாத்திர பிறகு பேசு சார்.
Record section. When you use our 70 degree, endoscopy should be down. All other instrument can be above the.
You are into the frontal sinus.
Frontal sinus. So it is a small agar nasae, as we see in the CT scan.
Yeah, the CT didn't have a very impressive agar, a very small agar. So
yeah, that's why we ended now. Frontal sinus.
And fairly uncomplicated frontal recess.
Yeah.
And even the ethmoid artery should be safe, quite on the base.
Yeah, base. Yeah.
Can you show us the glow, frontal glow now?
See the cells. See. This is the posterior wall of frontal sinus. That is superior.
Fantastic,
So
Siddhi.
1, 2, 3 septations are there, sir. So if you go like this is 70 degree. So we can see like this.
Fantastic.
Ethmoidal artery is coming down only, down, not there.
Okay.
You have to remove this part. Thank you, sir. I think we won't harm the frontal sinus because it's very naturally there. If I remove this part, I will see the ethmoidal cells.
Okay.
So laterally by the lamina and medially by the middle terminate and superiorly by the fovea ethmoidalis, anteriorly by the frontal peak. See, this is frontal peak is coming from the like this and going floor of the canal. That is roof of the frontal recess. This is a peak. So till the bone you can feel. If you drill this bone from here to here, you can do the traft 2 or 3, something like that.
Okay.
So I'm going to do the septum now, or you want to see the sphenoid also?
Sphenoid.
Yes, sir. So only 5 minutes allowed, but septum we cannot teach, but we can perform. So sphenoid, now middle terminate stability is there. Stability is there. This is superior terminate. If we cut the lower part of the superior terminate, you can see the spheno ethmoid or recess. See, now for Damascus, to show the ostium level, this is called sphenoid ostium. Sphenoid ostium like slit like opening or round opening or oval shape opening or sometimes 2 opening also. This is sphenoid. It is healthy. I don't want to disturb.
Okay.
So, sir, for basic surgery, no need of to straight section. If Merosel. 2 minutes, I will show the.
Yeah. That time we show anti-ethmoidal artery bone, Siddiq.
Yes, sir.
It is seen here, but anyway, for the beginner, for PGs.
Yes, sir. Again, the color is very dark.
I think Dr. Siddiq, a bit of frequent washes might help in improving the.
Yeah, Dr. Venugopal. Sorry, Professor HOD is telling. Yeah, it's ready now. Yeah.
So
Thank you for Trunakras. Thank you. All the way you came here.
அவ்வளவு தூரம் இல்ல சார், ஒரு 6 கிலோமீட்டர் தான்.
No, you are in prestigious institute, boss. Ramachandra.
I think as far as I think the emphasis on anterethmoidal artery, just to add a few points. I think the fear mongering is more. Most of the time it goes on the base of the skull, so it's very hard to really damage it. And even if it hangs on a mesentery or in a base, as some of the patients can, even if you damage it, it's very easy to catch it by the bipolar. So
yeah, bipolar or surgical.
Yeah, I mean, it's very tough to damage it because it's quite high up. Number 2, even if you damage a mesentery, it's good. I mean, you can always catch it at the bipolar.
Only near to the exit, you should not cut with, because retroorbital bleeding will be there. That's only Stamberg is telling, but I have not seen like that cases, because most of the people are doing PGs now. Nothing will happen because 70% of people have the endodural only, no mesentery at all. Only 10 to 50% of people have the mesentery of anterioethmoid sinus.
So, but one good thing to do is like what Dr. Siddiq has done, open it widely and trace anterethmoidal arteries. Once you keep seeing it again and again, you lose fear of it. So it's not.
So this is
maybe you remove those cells, you can see it a bit more clear.
Yeah, this one, yeah. Either 45.
You can just punch through them, you can see much better.
Now I'll see.
Yeah.
So this is called full house press now. So I am going to remove these cells. Sorry for the clarity. Codes. Yes, sir. See, still our uncinate is coming.
There's a question for you.
Yes, sir.
And the question for everybody in the audience, all the seniors especially. Has anyone ever seen a hemorrhage into the orbit because of cutting of the anterior?
That's all,
ethmoid
no,
artery?
sir.
Yes, we have heard a lot about it, but have you ever seen?
Not really, sir. At least I've seen only with people who are presented at the conferences. I mean, it's not something which.
Section, account section.
Now, I asked this question to Sethi.
He
He said, I've seen about 2 cases, but in the vast number of operations that he has done, he has only seen 2 cases. And ultimately, I think a lot of fear being generated about the artery.
Yeah, exactly. That's what I said. It's more fear mongering than.
Yes.
I mean, it's good to know that it is there, but I would say actively search it out in every case. But the best way to avoid it is by knowing where it is. So I mean, I don't agree with the concept that you see something, you damage it or something like that. But I would say actively search for it or make it a point to have a note of it, and even in a normal case.
Yes,
So
absolutely.
tomorrow, exactly. So I mean, any extended approaches you want to do tomorrow, you have to find it out. You wouldn't want to struggle at that time. So I would say search out for these structures, and no ethmoidectomy should be done without noting where the orbit is, where the lamina is, where the anterethmoid artery is.
And today, nice point that you have come, Siddiq has said, and you also have said it. Your
count
statement
section.
was extremely good. Nobody fears. You need not fear the ethmoid artery as long as you can see it, and it's better to see it before you go proceed anywhere else.
Just
yeah, not seeing it is the worst part. The fear comes from not seeing it ever.
Yes, exactly. And Siddiq also said, as long as you cut it somewhere in the middle, there's no problem. I don't know whether you said it or Siddiq said it.
I said it, but it doesn't matter. You can easily use a bipolar.
Yes, absolutely.
Because you have a stock to catch.
Yes.
So this mucosa is lie down like this. This middle terminate also, it is lining. So debrider. So septum, I'm going to perform next. You give me the infiltration.
What about secretions? See, after post-operative, Siddhi?
Yes, sir.
Post-operatively, suppose the patient gets cold cough, general rhinitis.
Yes, sir.
How about the secretions in the sinuses?
After operation, sir?
No, after 2 or 3 months, 6 months, patient comes to you with the wide middle meatal antrostomy, bulla opened, sphenoid opened, frontal sinus opened, but he gets cold cough. That time he comes to you. If you do DNA, what is your finding that time?
So that is because of mainly where is working on the environment, sir. If it's going again to the carpenter work or tailoring work, no. The poor sinus drainage will be blocked. If you do proper fizz, full house fizz, the patient never get the symptoms, sir, but they will be having the secretion.
Secretion.
For that, you give some only saline wash.
Oh, yeah, because
Saline wash is enough.
a lot of damage to ciliary movements.
Yes, sir.
And Dr. Siddiq, I think it's also a well-known fact that FES is not really, effective in dealing with postnasal discharge and headaches. So I think if you're doing it for those 2 reasons, you might have a sad patient and a sad doctor.
Yeah.
Postnasal discharge and headaches are really resistant to FES actually. So, I mean, I can agree with nasal obstruction and frequent colds, but postnasal discharge is decently refractory. For like you said, you might have to deal with postnasal discharge in terms of giving steroids and nasal sprays and saline nasal sprays.
Yeah.
Doctor,
That's what all sinusitis depends upon the 6 factor. The amount of secretion, its mucosal resorption capacity, and condition of the cilia, and pattern of the ostium, and space in the cleft area, then content of the mucosa also secretion. These factors only will affect the patient, sir. So now septoplasty, I'm going to perform. I usually give only single point infiltration, not like 9 point or 3 point infiltration between the floor. This is a skin, that is vestibule. This is the mucous membrane. This junction you give
And of course, you have a subset of patients for whom postnasal discharge is mainly a result of mucosal contact areas, which is what you try to eliminate, mucosal contact areas.
Yeah.
Like a deviated septum or a middle turbinate which is lateralized. So there is discharge coming from that. So I think one of the aim of FIS is also to reduce these contact areas.
Yeah. If you prick like this and you turn the syringe in perpendicular, then you go again inside and give it. Don't see the or pricking point. See the behind. I'm audible.
One minute.
Yes, audible, Siddiq.
1 minute, Siddiq.
Yes, sir.
Regarding for headache, I disagree with the Turnak also. Because most of the cases which I operate come with headache. You have
Yes,
to
sir.
do good anatomical clearance and like you told, mucosal point contact should be removed.
Yes, sir.
Then the patient definitely has relief of headache. As far as postnasal discharge is concerned, I agree with you.
Yes, sir. So turn like this and give and see the planching. This is called hydrodissection. See till the end. Only one point. You can see the white. That's all. See? Enough. Plate. Success.
Siddiq,
Yes, sir.
one question from the first procedure.
Yes, sir.
The debrider you used.
Yes.
What's the debrider?
Sanma.
Sanmava.
Yes. Sunmark.
Sanmava is the debrider, huh?
Sanma.
Huh?
Yes, sir. Sorry. Your debrider also.
Is it
sir. Sanma.
Is it in the market or now only introduced?
Now only introduced, sir.
You only introduced, huh?
No. So we.
Show us the debrider. Show us the debrider. Console of the debrider.
It is mostly serval, I think.
Huh?
Serval.
Serval.
Sanma, sir.
Yeah.
பக்கத்துல போயிட்டு
எங்க இருக்கு டிபரேட்டர் எங்க இருக்கு? This is the debrider, sir.
Yeah.
Focus.
Focus பண்ணுப்பா.
Oh, it is. So you are allowing me time for get introduction to the. So yes, sir.
Commercial break.
Commercial break, sir.
The Sanma debrider with this kind of colorful displays.
Yes, sir.
In the focus.
Yes, sir. So now, for septal correction, we have 3 type of incision. We put between the vestibule and mucous membrane, that is called Hack's incision. If you hope from here 5 millimeters behind vertical incision, it is called clearance incision. If you come at the level of the columella here, if you put this incision is called Fourier's incision. Advantage of Fourier's incision is 4 points is told by the clients, that is avascular plane, number 1. Number 2, the mucopericardium with the skin flap, it is a very taut, so less chance to tear. Number 3 is you can expose the anterior nasal spinous in case of caudal dislocation. Number 4 is you can extend the rhinoplasty, that is lemon nasal area. These are the 4 advantages of Fourier's incision. Here I am going to do which incision? Hacks. So start from lower border.
Which one is easy in endoscopic surgery? Endoscopic septoplasty.
This only is the best. Yes, sir.
Mucosal clearance is a...
Yeah, clearance. So going up like that, vertical incision till you have to lift the soft angle. That is called soft angle above. You can lift. This is, yeah. Now, for these steps, we should have good assistant. Otherwise, we cannot do at all at the endoscope. So again, I go one more over the mucopericardium. That is by feel only. Elevator.
That is an important point, and a lot of juniors would like to know, when you put an incision, how do I know I'm not gone to the other side? Now that is, it comes by experience.
Picture is clear?
Yes.
So now mucopericardium, but nowadays they are calling subpericardium, not mucopericardium. That is a.
Are you using the suction elevator or a normal elevator?
Okay, suction elevator. Kuduma. This at all will come by the only experience because the people take more time to expose to this. So somebody can hold the head. See now you can see the. For this step, I used to edit my video so much because very tough to enter. You can confirm with our assistant whether I have gone through the pericardium or not. So now I go.
Siddiq sir.
Yes.
Just one more. I mean, this just again for the juniors in the audience.
Yeah, definitely.
I noticed you made the incision on the left side.
No, not at all. That is hair. That is a natural hair. See.
In the side incision போட்டீங்க?
Yeah, left side only. Yeah.
அதான் நான் சொன்னேன். அதான்.
Okay, thank you.
I noticed you made the incision on the left side, and there's a usual question with which the residents usually ask us, which side do you make the incision? I usually don't have an answer. I tell them I'm a right-hander, so I find the left easiest. So I always put on the left side. What is your opinion, and what's your?
Yeah, nowadays septoplasty SMR is gone, sir. Only septal correction where you should write. Because septal correction is.
No, sir. I think you have my question wrong.
Yeah. I got it. Now you only textbook only explain convex side or concave side. So better put on the left side for the right hand surgeon. Because whether concave or convex, you can operate very easily on the left side, sir. This is my answer.
Yes. So I think that would be for a right-handed surgeon. The left-handed side will be ergonomically easier.
Yeah.
And I could also appreciate your close vision. The endoscope, the camera system seems to be rather close to you.
Yeah. So little pulse rate is 62 only.
Siddiq, zoom குறைக்கணுமா? அந்த மாதிரி எது இருக்கா பாரு. Zoom.
ஆமா, அது ஃபர்ஸ்டே நான் கொஞ்சம்
குறைச்சிரு.
இது எப்படி குறைக்கணும்?
அதிகமா இப்ப கம்மி ஆயிடுச்சு. கரெக்ட் 2 தான் இருக்குது.
So septoplasty first incision, then expander, and closer. So this is called anterior tunneling. Section முடிச்சுக்கோங்க. This is called anterior tunneling. This is posterior tunneling. விடுங்க section. I think again Merosol will help here for us. Now go slowly. You can reach the bone, perpendicular plate of ethmoid bone.
Siddiq, section work பண்ணுதா?
இல்ல கொஞ்சம் பிளாக் பண்ணிருக்கேன். ஏன்னா இங்க சக் ஆகுது ரொம்ப. கொஞ்சம் நான் பிளாக் பண்ண. இப்போ ஓகே சார்?
இல்ல சக் பண்ணும்போது அது
Now okay sir?
Okay.
So this is bony part. This is cartilage part. You have to break this one for the septoplasty. So now this is inferior tunnel. Can you see? Inferior tunnel.
Yes.
All with a single point infiltration, sir. Everything will come.
No, you just said bony part, cartilaginous part. Just Aliti sheet, let the juniors know.
So this is a cartilage part. This is perpendicular plate of ethmoid.
Okay.
Now I will turn the suction tip like this and break the cartilage bony junction. You have to break like this. Can you see the difference here?
Yes.
Sir. Yes. Wait. 2 minutes. Patient is moving. So Can you start, sir? Section விடுங்க. Section விடுங்க. First, தலைவரே, section விடுங்க. Okay, sir, start பண்ணுவா. Okay, sir. Okay. Now I'm going to start. Yes, sir. 2 minutes, sir.
Meanwhile,
Black,
let me ask a question to Dr. Tirunagarasu, Rajshekhar, whoever wants to answer this. Before the surgery, do you always guarantee your patient that it will be all right completely, or do you have special words for them?
Black
Any pest surgery.
You have to say you will be completely all right. Otherwise, you will not come. If you half answer, you will not come.
I admire you, Rajshekhar. But what is the real scientific answer?
Real scientific answer depends on the God.
This is what all of us say. You complete
Yeah.
guarantee. All that.
See,
the truth is, nobody can ever say that.
Yeah. Even Balian Love, first page, it says, doctor dresses it, God heals it. God dressing the wound, surgeon dressing the wound, God heals it.
So, the feeling of the septum cartilage, when you do only, you can understand. So, when you hear, you forget, sir. When you see, you remember. But when you do, you understand, sir. That is things in surgery. You can see the difference between the cartilage and the bone. என்ன சார் ஆச்சு? ஒன்றும் இல்லை. Plate. So you remove the 4 mm height with the 4 centimeter of the between the over and the vomer part and the cartilage part. You remove this cartilage first in septoplasty. I think a little bleeding, so you cannot appreciate. Elevator.
You don't use Ballinger swale knife, which was you.
Yes, sir. That is for SMR, sir. I am doing the septoplasty, sir.
Yeah. Rajaram, you remember those days with the headlight, you used to do Ballinger swale knife? We remove
Yes.
big part of the cartilage and we show it to the patient. That's all. No.
The bigger the cartilage, the more the fees.
Yeah.
Bleeding. Section. Close பண்ணுங்க. So in septoplasty, you remove the mucopericardium one side and this side and mucopericardium of the opposite side. See, this is only septoplasty. And remove all the bony attachment. Can you see? Needle holder. So remove only bony part of the septum. Leave the cartilage bone. இது needle holder. ஒரு 2 minutes. ரொம்ப நேரம் பண்றோமா? Okay, thank you. Next step.
Okay, good surgery.
Not yet over. Rajshekhar.
No, sir. Next case they want to do. Section பண்ணுங்க. Yes.
He has done it right. Good demonstration.
Yes, sir. Thank you, sir. The section by the.
No, Rajshekhar, those days we were doing all this blindly.
Okay.
We were all very talented then.
Yeah, definitely. With the bullseye lamp, we did tonsillectomy.
Bullseye lamp விட இதுக்குள்ள என்ன நடக்குதுன்னு தெரியாம குத்து மதிப்பா பண்ணி நல்லா பண்ணுச்சு.
Now body septum, you can break it and remove.
சார் அப்பெல்லாம் டயர் கண்டிப்பா இருக்கும், யாருக்கு தெரியாது. எண்டோஸ்கோப்
தெரியுது.
Gopal sir, I can hear your voice.
Hello.
Rajaram sir.
Most
of the time, it made a tear. Unnoticed tear will be there.
But nothing happens, Mother
Nothing
Mama.
happens, sir, because
Nothing happens.
today afternoon they are going to
Sir,
take the Hadad
can
flap,
you
sir.
hear
So
me?
total
Shankar,
flap is
sir?
going to come out today. The pituitary case. So remove the bony part and leave the cartilage part. I think next case you can say, sir, because time is up. Sir, thank you very much for giving this
Hello?
opportunity.
Can
to
you hear
perform,
me,
sir.
sir? Shankar,
Sir, thank you, sir.
Shankar,
Thank
sir, can you hear me?
Thank you, Siddiq.
Yes, hello.
Yes, Sumita, please proceed.
We'll be proceeding with the next case, sir.
No, sir.
I thank Professor Rajshekhar and Tirna also for having shared the previous. Round of applause for Siddiq.
Thank you, sir.
Siddiq, கேக்குதா?
கேக்கு, sir. Thank you, sir.
நல்லா பண்ணீங்க. Very good.
Sir, thank you, sir.
Upcoming surgeon.
Good job.
Yeah. Sumita, you can proceed.
Yes, sir. So we are proceeding with the third case, sir.
Yeah, please, can you enlighten us regarding the case?
Yeah, 1 minute, sir. She's a 22-year-old,
Yeah, we are able.
22-year-old female. She presented with nasal obstruction both sides with mucoid nasal discharge and frequent sneezing and headache for 4 years, sir. On examination, there was septal deviation to the left with a spur on the left side and pale nasal mucosa and minimal mucoid discharge in the middle meatus. On nasal and previous. On diagnostic nasal endoscopy, there's deviated nasal septum to the left with a spur and mucoid discharge in the middle meatus with crowding of OMC, sir. Scan, I think Dr. Chandramouli will be explaining. He's the operating surgeon. So our pre-op diagnosis is DSL with chronic rhinosinusitis and planning to do FES, sir. So I'll just hand over to Dr. Chandramouli, sir, for scan.
Okay.
Excuse me, one minute, Dr. Sundar here. In between, can we do the book launching?
Sir, yeah, சொன்னீங்கன்னா 2 minutes break பண்ணிக்கலாம், sir.
Yeah, we can wait for 5 minutes. So
Yeah, we'll
ask Chandramouli to wait.
Yeah, scan our scan explain பண்ணிடட்டும், sir. அதுக்கப்புறம் we can
இல்ல இது முடிச்சிட்ட அப்புறமா scan so that it will be better. What do you
அப்படியா? Okay, so scan இப்போவா இல்ல book launch அப்புறமா?
See, once he is going to start, then probably if he explains, it will be better. We'll have a better orientation.
Okay, sir. அப்போ sir சுந்தர் கிருஷ்ணன் sir 10 minutes break sir book
Yeah.
launching.
10 minutes, yeah.
சரி. Okay, sir.
Sir, Professor Ratnasamy, sir, please come here in front. Yeah, the launch material.
Okay.
Good afternoon, everybody. I'm Dr. Kantamani. I welcome to all of you. And I think the purpose of the workshop is very well known to you. There's a lot of demand. Dr. Sundakrishnan has become synonymous with workshops, and we had a fabulous registration number of 130 a single day. You're all aware of this invitation. And yeah. I'll do a little intro before we go to the before the release of the book. This is our hospital logo. Our YouTube channel is also there. A short video tour of the hospital. It's a daycare, short daycare center. Eye examination room. A recovery room. A small room. OT complex. ENT operation theatre. Skull base is done here. Eye operation theatre. The surgeries are relayed out. The collection of mementos is countless. Just a glimpse. It's very difficult to accommodate the CVs of, Dr. Sundar Krishnan, and especially the chief guest, a great academician, Dr. Vijay Raghavan. Okay, the Vice Chancellor of Ramchandra Medical College. A big applause, sir. A welcome, sir. Yeah, before the big release, I'll be talking a little about Dr. Sundakrishnan. Many of you must be knowing about him. Okay. He's alma mater of Madras Medical College. It was his breath. He's MD of Krishna and ENT hospitals. His logbook is about 30,000 surgeries till date, and skull-based surgeries, 1,000 miscellaneous, and 700 of pituitary tumors. I don't have to elaborate on the other skull-based surgery like orbital, optic canal, and CSF rhinorrhea, etc. And it was a very, very difficult and challenging thing to get awarded in a surgical specialty of PhD, a doctorate from MGR Medical University. Dr. T.V. Krishna Rao flew down from Hyderabad just to congratulate him because he told there were only three or four PhDs prior to him. And surgical specialty, it is an impossible feat, he said. And the awards he has accomplished, I think all of you would have witnessed. He has been felicitated. I think a lot of credit goes to the ENDO-ORL for recognizing him. They fondly call him as father of endoscopic ear surgery in India. Best Teacher Award recently by Health Minister Ma Subramaniam. Lifetime Achievement Award, and a small testimonial by a patient who had rhino-orbitocerebral syndrome due to mucormycosis. This is the testimonial. It's a half-day procedure. That's what these patients,
வயசு வந்து 49. இவருக்கு வந்து பிளாக் ஃபங்கஸ் வந்திருக்குன்னு சில அறிகுறிகள் எல்லாம் தெரிஞ்சது. கண்ணு வலது கண்ணு வந்து நல்லா மூடி எடுத்தது. நாங்க கண்ணில் என்ன பாதிப்பு அப்படின்னு நினைச்சுன்னா கண் சம்பந்தப்பட்ட ஹாஸ்பிட்டலுக்கு நிறைய போய் பார்த்தோம். அப்போ அவதான் சொன்னா பிளாக் ஃபங்கஸ் அப்படின்னு சொல்லிட்டா. அப்புறம் போரூர்ல பெரிய ஹாஸ்பிட்டல் இருக்கு, அந்த ஹாஸ்பிட்டல்ல போய் ட்ரீட்மெண்ட் எடுக்கும், இல்லை ஜிஹெச் போங்க அப்படின்னு சொன்னா. நாங்க சரி ஜிஹெச் போனா ஜிஹெச் போல போரூர்ல பெரிய ஹாஸ்பிட்டலுக்கு போயிட்டோம். நாங்க அந்த ஹாஸ்பிட்டல்ல போய் ஃபர்ஸ்ட் மூக்குல ஆப்ரேஷன் பண்ண சைனஸ் இருக்கு, சதை வளர்ந்துருக்கு, மூளையில வரையும் பிளாக் ஃபங்கஸ் இருக்கு, நெத்தியில இருக்கு அப்படிலாம் சொன்னா. அதெல்லாம் கிளியர் பண்ணி ஆப்ரேஷன் பண்ணி 1 வாரம் இருந்தோம். அதுக்கப்புறம் திருப்பி 1 வீக் கழிச்சு ஒரு 3 டேஸ் கழிச்சு திருப்பி வந்தோம். வந்து 18 நாள் இருந்தோம். 12 இன்ஜெக்ஷன் போட்டா ஒரு இம்ப்ரூவ்மெண்ட்டும் இல்லை. அவருக்கு சாப்பிட மாட்டார், வைக்க மாட்டார், ஒரு மாதிரி டல்லா தான் இருந்தார். அப்போ தெரிஞ்சவர் ராமா டாக்டர்னு இருக்கார். அவர் மூலமா பர்கி ரோட்ல கிருஷ்ணா ஐஎன்டி ஹாஸ்பிட்டல்னு இருக்கு, அந்த சுந்தரகிருஷ்ணா டாக்டரை வந்து பார்த்தோம். நாங்க அவங்க வந்து எங்க ஆத்துக்காருக்கு நல்ல விதமா பார்த்து வச்சு ஆப்ரேஷன் பண்ணி 1/2 நாள்லயே நாங்க ஆத்துக்கு நடந்து போகக்கூடிய அளவுக்கு ரொம்ப இம்ப்ரூவ்மெண்ட் பண்ணி விட்டாங்க. மூளையில, மூக்குல, நெத்தியில எல்லாத்தையும் கிளியரா பண்ணி கண்ணு முதல்ல காந்தாமணி மேடம் அவங்க ஒய்ஃபு நல்லா பார்த்தாங்க. எல்லாமே நல்லா இம்ப்ரூவ் ஆகி இப்போ நல்லா இருக்கு. ரொம்ப தேங்க்ஸ் சொன்னோம் அவளுக்கு. நாங்க எவ்வளவு நன்றி சொன்னாலும் அது தகுதே இல்லை. என்ன சொல்றதுன்னு எனக்கு தெரியல. நாங்க இந்த நேரம் எங்க ஆத்துக்காரங்க இருக்கேன்னா மேடமும் காந்தாமணி மேடம் தான் இதுக்கு காரணம். அவளுக்கு தான் பெரிய தேங்க்ஸ் சொல்லணும். எவ்வளவு தேங்க்ஸ் சொன்னாலும் அது என்ன சொல்றதுன்னு தெரியல எனக்கு.
Actually, Dr. Sundakrishnan doesn't like to be publicized. In any group you join him, he will exit fast. And any person comes for interview also, he is shy. These people had specially requested that their testimonial be given, shared to all. And then the success story of Dr. Sundakrishnan, you all can read out. He's self-trained, he's not gone abroad. In fact, he got 3 gold medal awards he was to get, and he passed it on to his postgraduates. His habitat, he was never at home, was patient's head and neck. He has performed several never before challenging complex surgeries as early as in 90s by himself due to his zeal, patience, and sacrifices. Actually, many of the ENT doctors here are very reputed, renowned, sir. Dr. Vijayaraghavan, sir. Many of them are here. You are very privileged. Dr. M.N. Shankar is by your side. He has also contributed Yeah, the book release, what you're going to do, the foreword was given by him, and he's added endoscopic cochlear implant chapter to endoscopic ear surgery manual. That's the second edition, sir. And there are many more, like Dr. Siddharth Raj, Dr. Haila Sami, the surgical faculty, many more. Okay, I wouldn't need. Now coming to, not this. Now coming to the guest of honor, Dr. Vijay Raghavan. He is the Vice Chancellor of Sri Ramachandra Ramachandra Institute of Higher Education and Research, Chennai. Earlier, it was Ramachandra Medical College. Just see the line of degrees that he is having. In fact, I had to really, take lot of time to shorten his resume. Sir, it was sent as a shortened, updated. நான் உட்காந்துட்டு அதை ரொம்ப எடிட் பண்ணிட்டு இதுக்கு கொண்டு வந்திருக்கேன். அது வந்து it's a great privilege, sir, to have an academician as a chief guest, okay, rather than non-medical people. Vice Chancellor, then the brief resume, he's got more than 30 years of experience as a practicing orthopedic surgeon. We got acquainted with him at Apollo Hospitals. It's like a brother to me. He's developed special interest in joint replacement surgeries since 1978 and undergone special trainings in the United Kingdom. Dr. Jaya, his spouse, has helped him a lot, he used to say. He has also got doctorate and 19 publications in orthopedics in recognized journals and also presented scientific papers. Delivered 4 orations, special guest lectures in various state, zonal, national, and international level orthopedic conferences and programs. Now, requesting by the Vice Chancellor of Ramachandra Medical College and Institute to release the book. Dr. Sundarkrishnan to hand over the book, not here onto the stage. Please speak a few words, sir, and then we will go.
Good afternoon, everyone. At the outset, I must really thank Dr. Sundarkrishnan for considering me to do this honor. I know Dr. Sundarkrishnan and Dr. Kanta almost for 30 years. Although recently we have not had the chance to meet each other. We used to practice in the Apollo Medical Center. And I remember Kanta was always into private practice mode, but Sundar was an academician. He used to be working with GH, the erstwhile Madras Medical College. And we remember I used to come from Ramachandra to do the consultation there. And he used to just come 15 minutes earlier for his consultation. I was probably sometimes, both of us had the same consulting chamber. And he is a very hardworking person and he is a silent person. To get some words out of him is not that easy. But he has shown his talent by actually bringing out this excellent book. And writing is a special art. And I must confess that when he sent the copy of the book on WhatsApp and requested me to write the foreword, apart from, of course, the stalwart like Dr. Shankar, actually, I didn't have the time to finish it. I promised that I will do it. So, I mean, it takes time to even write a single page or 2 pages like that. And to have brought out a 68-page volume for the help of not only the postgraduates, the residents in ENT, it is probably useful even for an undergraduate to learn some of the modern concepts of how certain things can be treated. Very illustrative. See, you can write a book just theoretically quoting so many things, but I saw that there were so many pictures which I'm sure would have come out of his own experience of treating so many patients, was phenomenal. And that was another great thing I observed in this book. The foreword, of course, was excellent. He brought out, in fact, I do not understand ENT that well, but the foreword had given me the chance to understand what the book actually contained. And so it was an excellent effort. I think this is the way I was so happy to learn. At that time, when he was coming to Apollo, he was an assistant professor. Then I have learned that he has already raised himself to become a full-fledged professor. And he has lived up to this name. There are many professors who come up, but the contribution that you leave behind for younger people to develop is what should be appreciated. And that I'm sure will be there. I mean, this particular book will be in the hands of so many different people. Also for trained ENT surgeons in their younger stage, if they want to learn. And I still remember that also, that early stages he used to carry his sinoscope along with him when he used to come for practice, because ambulatory care has become the order of the day. I also had the pleasure, it has developed so well when they opened their Krishna hospital. I visited along with Jaya to go and see that place, and the phenomenal idea, the concept with which they have built it. I don't think they're actually requesting patients to stay there as inpatients for too long. It is meant to be office practice where a lot of procedures can be done and they can be discharged by evening. And that is the way he has developed. And I know Kanta was full-time into it, and probably Sundar has come into it full-time now. And I'm sure I wish them all success. And I have met their children. Now I understand that both of them are living abroad. To contribute to society, there are different ways. And one of these ways is to contribute through what knowledge that you have gained, skill that you have learned to impart to others. So I would formally congratulate Dr. Sundar Krishnan for an excellent effort. And I feel proud to actually release this book on this day. Thank you very much for the opportunity.
I think first we will Taiwan, I think. No. Tamil Taiwan. Formally releasing the book. Now coming to the would you like to find it, sir? Okay. Good dream. Dr. Tirnavkar, sir. He's trained abroad. Professor Madan Gopal. Yes. Doctor. Dr. Bharti Mohan, sir. Sir, நல்ல சிங்கர் ஸ்மியூல்ல திரும்பி சொல்ல போறேன். பாட சொல்ல போறேன். Professor Siddharth Raj, HOD, Otorhinolaryngology, HOD, sir. Karpaga Vinayaka, Medical College and Institute, sir. Very dear to Dr. Sundar Krishnan. If you want to see 1,000-watt smile for Sundar, Dr. Siddharth Varnam. Doctor? Dr. Akhila Sami, please come, sir. Very renowned, sir. Very active on social media. Dr. S. Rajshekar. Kandipa. S. Rajshekar. Professor Rao, Dr. Rajshekar Sundar. Professor Jyoti Ramalingam, sir. She will come to our house. Professor Muthuchitra. Professor Muthuchitra, madam. Thank you, sir. Thank you, sir. KMC, she's heading. Professor Nirmala, madam. Dr. Nirmala, please come, ma'am. Okay. Professor K. Balachandran. Dr. Vasu These are all set to be signed by sir. Thank you, sir.
Senior professors.
Very Dr. Ratana Sami, very senior, sir. Very okay. Good afternoon, sir. Ahila Vasudev. Dr. Vasudevan has come all the way from Puducherry. Vikram Kumar. Professor Dr. Tamilarasan. Dr. Tamilarasan, sir. Vikram
Professor Samanaselvan.
Samanaselvan எனக்கு தெரியும். Professor Dr. Saravanaselvan. ஒரு books கொண்டு வாசிக்கிறோம். Major Nirmal Kumar. Sir, you will get, I think then it is time for lunch.
Yeah.
Yes, sir. Just you will be able to eat properly, I think, then because of this. Just we will wait for. Professor Talapati Ramkumar, please come forward.
Professor Leena Rajam.
Books பேரு சார் எழுதல பேரு சார் கூட எழுதுவாங்க புக் இதெல்லாம் பர்சனலி
கொடுங்க சார் நான் திருப்பி கொடுக்குறேன்
ரெண்டு பேருமே எங்க சொல்றது Professor Talapati, I think you'll be chairing, right?
Yes, sir. Professor Leena Rajam, madam.
Professor Leena, doctor, please come over.
Madam is also there.
Madam is also sick. She's in Pediatric Institute.
Dr. M. Vivek.
Dr. M. Vivek, ரெண்டு பேருமே sign பண்ணு. Dr. M. Vivek.
Mahesh Kumari, madam. Dr. Mahesh Kumari.
Okay. Okay. Dr. Mahesh Kumari. அவ்வளவுதான். Dr. Vikram. Dr. Karthike.
Karthika, madam.
Karthika. I hope the photographs are going on. எடுக்கிறீங்களா? கரெக்டா எடுக்கிறீங்களா சார்? இந்த சைடு வந்துடுங்க. You have to send to them. Video clip பண்ணிடுவீங்க இல்லையா? Dr. Vikram. Sir, he is very good in what to say, in conducting quiz and all that. And he is part of Krishna family. MMC க்கு பெரிய இது leader. அது அப்படியே fan of. Thank you so much. It was very nice. I hope your photographs were taken properly.
Yes, they have taken.
Okay. They have taken.
This Photoshop is possible.
Hello, Dr. Pradeep, Dr. Rajaram, Mauli. Can you connect me to the theater?
Yes, Sundar.
Yeah, you can start, sir. The ceremony is over.
Yeah. Okay.
May I introduce Dr. Chandramouli, the faculty surgeon, is a senior assistant professor in upgraded Institute of Otolaryngology, Madras Medical College, and positions held ex-secretary, AOI, Chennai chapter. Over to you, Dr. Mouli, for demonstration.
Yeah. Hello, can you hear me, madam?
Yes, you are very audible. Thank you.
Hello? Am I audible?
Hello, ma'am, Dr. Chandramouli sir is audible? Hello?
Dr. Talapati.
Hello?
Mauli,
Sir, am I audible, sir?
very much audible here.
Oh, we have already started the case, sir.
We are not having the picture here.
In a minute, sir.
Audition theater picture போடுங்க.
Hello?
Yes.
Can you see the scans?
Come a little closer to the. Okay, that's it.
One minute, Dr. Chandramouli. So this session will be chaired by Professor Bharati Mohan and Professor Muthu Chitra. Can they come to the front? Bharati Mohan, முன்னாடி வந்துரு. Professor Bharati Mohan and Professor Muthu Chitra are part of the MMC team. Professor Muthu Chitra is from Professor of ENT, head of the Department of ENT in Kilpauk Medical College. And Professor Bharati Mohan is known to everybody, the man behind so many cochlear implants in the state. And he is a professor of ENT in Madras Medical College. We thank them for chairing the session. Over to Chandramouli. Chandramouli?
Yes, sir.
Start Pannappa.
Very good morning to everybody. This patient is 22 years old, complains of nasal obstruction. You see the scan. So I will give you the crux of the scan. This patient has an underdeveloped frontal sinus. This is the first picture. You can see the nasal bones. The frontal sinus is not very much well developed. So the next picture, you can see there is a septation inside the frontal sinus, and you can see the rheumatization of the interfrontal cell. Now this is the ascending verse of the maxilla, and moving on backside, you have the agar cells, and most of the frontal recess is normal in picture. So you have the bulla. There is pathology in bilateral maxillary sinus, and also there is haziness in the anterior ethmoids. So as you moved on, you can see the lamellar concha. So you have the concha on either side. So this is the cribriform plate, medial and lateral lamella. The lamellar concha gets attached there, and we have some amount of disease in the anterior ethmoidal cells. So as we move behind, you can see
the origin of the superior turbinate. So this is the level of the basal lamella. Again, there is some amount of haziness in the level of the basal lamella. And moving on, this is the posterior ethmoids. Posterior ethmoids seem to be normal, but there is hematization of the septum that is attached to the skull base. And then moving behind, you can see the sphenoid sinus. There is a small septation that runs to the lateral wall of the left side, lateral wall of the sphenoid sinus. And sphenoid looks healthier. So we will move on to the case. This patient, we have already done a septoplasty. Just to say,
Mauli.
Yes, sir.
Mauli. Yeah,
Yes,
on the scan, do you comment on the depth of the orbital? Depth of the olfactory.
See, can you see, sir? This is the medial lamella, this is the lateral lamella.
Okay.
This is the olfactory fossa.
Yeah.
The olfactory fossa doesn't seem too deep. So the chances of injury in the skull base in this case is very less.
Very less. Yeah. Okay.
Okay. So we'll move on to the case. Can I get the endoscopic picture?
Yes, yes.
So what we have done is we have just removed the septal spur. Which was in the left nasal cavity. Just to save time, we did not show that.
What is your plan, Mauli? Because the frontal and sphenoid seem to be normal.
Yeah, frontal sinus is not pneumatized well, sir.
Yeah.
Sphenoid looks normal.
Okay.
The more of the pathology in both the maxillary sinus as well as the anterior ethmoids.
Anterior ethmoids.
Okay. So in this case, we have not infiltrated in any of the mucosa except the septum, which we have done already. So we usually keep a adrenal pack. See, you can see how well it is decongested.
Okay.
The only thing you have to give time for these procedures. So the more time you spend on pre-operative preparation will save a lot of time when you do a surgery. Can you appreciate how much decongestion is there?
Yes, yes, we have given you adequate time.
Yes, sir. That is the reason. So when you have more time, the surgery also will be faster.
Okay.
So you can see the free ball probe.
Will you restrict yourself to the radiological disease or you will proceed a standard surgical procedure addressing all the sinuses?
See, usually in functional endoscopic sinus surgery, you look into the pathology and take away the pathology and leave all the other sinuses mucosalized.
Okay.
Otherwise, you do a complete FES. So there is no in between. Either you do completely or do away with the pathology and come back.
Okay. What's your plan? How will you normally approach?
My plan is to do completely.
Okay, okay.
So this is the free border of the uncinate process. This is the bulla. I have the middle terminate by this side.
Okay.
Now my plan is to do an uncinectomy. Back with.
Mauli.
Yes, sir.
All surgeons seem to address left side first.
Yes, sir. Because this case I have done incision of the septum in the left side.
Okay.
So I want to complete the surgery before it bleeds in this side.
Okay.
So I'll do this side. And it is also convenient to do the left side than the right.
Okay.
So I take the back bite and then I just turn it down so that it faces down just superior to the inferior terminate. I don't take the back bite away. I cut 1 to 3 cuts and then take away the backbiter.
Okay.
Ball bro. Once you do that, you can have a good uncinectomy done, and then I out fracture the horizontal part of the uncinate. Can you see?
You're able to see accessory osteum, isn't it?
Yes, yes. This is the accessory osteum. This is the accessory osteum which you are seeing. This is a normal osteum which is seen.
Okay.
So even if you see the scan, you can see that this uncinate process is thicker.
Yeah.
Because of the mucosal edema that is present in the uncinate process.
Okay. Okay.
So now I am going to connect the accessory osteum as well as the natural osteum.
Okay.
Debrider, please. Debrider. We have a striker debrider. Just a minute, we are arranging for the debrider. உள்ள போச்சா பாருங்க எவ்வளவு உள்ள செக்ஷன் இதுல இருக்கா ஆசிலேஷன்ல இருக்கு செக்ஷன் தலைன் கம்மி பண்ணுப்பா என்ன கம்மி பண்ணுங்க டிப்ரேடர் இல்ல
ஃபார்வர்ட்ல வேணும் ஆசிலேஷன் வேணும் ஆசிலேஷன்
இதுல இருக்கு just a minute sir
oscillation 3000 rpm 3000
oscillation பர்ல இருக்கு
ஒரு நிமிஷம் அப்படியே
oscillation எடுத்துருங்க
oscillation வேணாமா ஃபார்வர்ட்ல இருக்கு ஓகே
okay
1000 rpm 3000 rpm
so we have the striker debrider. Increase பண்ணுங்க
ஜாஸ்தி
டிப்ரேடர் வேலை செய்யல ஸ்பீட் ஏத்துங்க
4000 rpm
I don't think the debrider is working. So meanwhile we will do with the forceps. Okay. Can I get the straight Beckersley?
3 mm
The debrider is not ready.
4 mm
okay short hand
3 mm
Can I get a true cut? Always try to connect the accessory osteum with the natural osteum. True cut. So whenever you want to make a bigger osteum, just widen it in the back side rather than going in front and injuring the nasal lacrimal duct. Section. So the maxillary sinus looks pretty normal, not like what you this CT
Molly,
scan. So CT scan we saw a lot of haziness.
Madam wants to talk to you.
Yes.
Mowgli, what is the pathology you see inside the sinus?
Right now, I don't see much of pathology in the sinus, madam. But because this is a dynamic disease, whenever the patient is having symptoms, when you take a radiological picture, you have haziness and block of the infundibulum, everything. And once you treat the disease with proper medication, all the findings which you see in the radiology.
Molly, right now,
Yes, sir.
beside me, All India Rhinology Society active member is here, Dr. Agilasamy, Professor Agilasamy.
Yes, sir.
That's
So
why
I have to mind my words.
you are being watched by All India Rhinology Society active member Agilasamy.
All through. Sir, welcome, sir.
Come on.
Thank you, thank you.
Hello. Hello. Hello.
Siddiq, Saleh.
Sir, here I want to add one point, sir, to the Chandramouli. Whether disease is there or not in the maxillary sinus, it's not a problem now. But you have to clear the pre-chamber of the maxillary sinus. That is ethmoid infundibulum. The previous scan, patient had some disease in the sinuses. That's okay. But it can be cured by medically also. But for the recurrent problem, so recurrent sinusitis, those people, they will get sinusitis, somebody will treat with the medicine. Again and again, it comes to you, we will do the pre-chamber clearing the disease in the ethmoid infundibulum. Ethmoidal infundibulum is lateral boundary of the maxillary ostium, and medial boundary of the hiatus femoris. So here only all the four sinuses will drain, like lateral sinuses, anterior ethmoidal sinuses, and frontal sinuses, and maxillary. So this area should be cleared. That is an idea of the Mr. Linker.
Can you see the vertical part of the uncinate?
Yes.
This is the remnant bone of the vertical part of the uncinate.
Can you show us where it gets attached exactly?
It is getting attached to the lamina, sir.
Lamina propria.
Now,
that means frontal sinus drains into the meatus, not in the infundibulum.
Yes, sir.
Am I correct?
Yes. Absolutely.
Picture is clear, sir?
Yeah, clear.
Thank you, sir.
So once you take away the vertical part of uncinate completely, you can have just an end-on view between the middle turbinate as well as the lamina. Now, how do I open the bulla?
Okay.
Septal suction unit.
The bulla is already a little.
Yeah, that is because of pack which we have kept, sir.
Pack.
Decongestion pack, whatever we kept.
Destabilized it is, that's what.
Yeah. So this is the bulla.
Okay.
I just make a small window in the bulla.
Okay.
To see how deep it is, just to avoid inadvertent injury to any of the vital structures. So I just make a window.
Yeah.
See how much depth is the air cells.
Only what is the endoscope you are using?
Just 0-degree Stryker endoscope.
Stryker.
4K.
4K definition.
Yes.
And what's can it show us the model of the camera? What is the number of the camera?
1688.
1688.
1688.
1688. Okay. Is it the topmost?
This is the latest right now.
Latest.
This is the HD camera, isn't it?
Agilasamy wants to ask.
Moli,
sir.
So far you haven't had much disease. Still, you will go for a full house.
It depends on when you have an evidence of radiological disease once.
Because I have a different concept.
Okay.
And my close friend Janiram, we both have a same concept that one cell behind. Our concept is one cell behind. If the disease stops,
okay,
after that one cell behind, we stop dissection.
Okay.
Okay, go ahead.
Also, Mauli, even the CT didn't show any disease in frontal and sphenoid sinus, right?
Yes,
so
sir.
do you
Yes,
want to
madam.
proceed with that, or you will complete with posterior ethmoids?
Sometimes surprisingly you have a disease when you open up the posterior cells, madam. So we'll just see whether to
then.
start with the anterior ethmoids or do away with the posterior ethmoid also. Right.
Sir? Sir, ask the PGs to ask some basic questions, sir, at this level, at this point.
Okay. Postgraduates in the audience can ask questions. But one senior postgraduate is asking for basal lamella. With instrument. Point it out with the instrument. Mauli.
Yes, sir.
One senior postgraduate is asking about basal lamella.
Yes, sir.
His name is MKR.
MKR, sir. Sir, good morning, sir. A very good morning, sir.
Good morning, sir. Chandramouli Chuma. Just joking. You are doing a nice job, Chandramouli. Good.
Yes, sir.
Proceed.
See, this is the middle turbinate. The
Okay.
middle turbinate turns laterally and then gets attached to the lamina.
Okay.
So this separates the anterior and the posterior ethmoids.
Okay, Ramali.
Can I have septal suction elevator? Different way வேலை செய்யணும்.
Mauli,
sir,
when you search for frontal recess after your uncinectomy and middle meatal antrostomy or after ethmoidectomies?
You are asking whether we'll do an intact bulla or?
Yes, intact bulla.
Most of the time I do after completing all the anterior and posterior work, sir.
Okay.
Can you see the basal lamella?
Yes, very well seen.
So I'm just fracturing the basal lamella.
Okay.
You can see a lot of cells.
Yes.
I don't think this is a normal mucosa.
Looks little. The secretions are there, na?
Yes, sir. See, usually this mucosa which is not diseased, it starts bleeding when you try to pull it.
Okay.
So I don't think that this is a normal mucosa. I always go by whatever Ahilasamy sir told.
Yeah.
Don't take away the normal mucosa. So you try to be little conservative. That is why it is called functional endoscopic sinus surgery. So you want a mucosalized cavity inside, because if you take away all the mucosa, there are chances for crusting, chances for recurrent symptoms again even after doing this procedure. So one more thing, whenever you take the air cell, don't give too much of force.
Okay.
Just try to use your tip of the Beckersley and then try to remove all the cells one by one.
Okay.
Especially when you have entered the basal lamella, there is no urgency because this is the place where you have to be more careful.
Okay. Okay.
The most common sinus which goes wrong whenever you do a functional endoscopic sinus surgery is the posterior ethmoids. So most of the time we are very conservative when you open up the sphenoid because we are little afraid of the structures there.
Okay.
But whenever you are operating the posterior ethmoids, we are not that much careful. So that is the area where you are liable to break the skull base. The debride is not working, man. Where blade போடுங்கல்ல. Action. Once I know the depth of the bulla, I can go away by taking the inferior wall of the bulla. I hope the picture is clear.
Sir, it's very clear. Go on, sir. You're doing a good job.
Action. So once you open the basal lamella and go to the posterior ethmoid, you can visualize the superior turbinate. Can you see?
Superior turbinate.
Superior turbinate.
Where?
So this is the middle turbinate and this is the superior turbinate. Can you see?
Okay. Can you lateralize and show us? Okay.
Yeah. Suction elevator. I just lateralize. Can you see the?
Yeah. When you were reading the CT,
yes, sir.
Is there any situation of post?
Can you see the sphenoethmoidal recess?
Yes.
This is the sphenoethmoidal recess.
Okay.
I just widened it.
Just go in. Just you're able to go in. Yeah. Good. Super.
Okay.
Yeah.
Okay.
Even carotid bulge is there.
Yes, sir. Now, what I do is, whenever you want to take away the posterior ethmoids, just get the landmark of the sphenoid sinus first. Right. This one. So I try to make it bigger by debriding at the lower level of the anterior face of the sphenoid.
That area, one small vein will come, Mauli.
Yes, sir. You have the septal branch of the sphenopalatine artery.
Yeah, small vein will come sometimes. That gives a lot of problems.
Lot of bleeding. Now, once you know where is the sphenoid, our job becomes very easy. Now, the chances of knowing the skull base becomes easier. So this is the sphenoid. So there is other way to open up the sphenoid is, once you have done a complete posterior ethmoidectomy, go to the medial most part at the level of the superior level of the maxilla. You just draw a line. This is called the maxillary line. Just this line will be corresponding to the sphenoid ostium if you are removing from the posterior ethmoid. Or sometimes if the sphenoethmoidal recess opening is very visible, then you can go for medial opening of the sphenoid. So this is the sphenoid ostium. Now once you know the sphenoid ostium, whatever is anterior to the anterior face of the sphenoid will be the ethmoidal cells, posterior ethmoidal cells. 45. Beckersley? Suction? Can I have suction?
Yes, cella also visible. Cella is visible little. Cella,
Yes, sir. Yes, sir.
That's a cella. Yeah. Optic now pulse is seen.
Now once I am very sure where is the skull base, my job becomes easier by taking away all the small cells that are attached to the skull base. Can I have the debrider? Suction ரொம்ப இருக்கு. So I am taking away part of the superior turbinate. Can you see?
Yeah.
Because whenever you open up the sphenoid sinus and leave this superior turbinate, most of the time there is a sinus block. So the inferior part usually I take away and make it as. Now can you see the lamina papillae?
Yeah.
Show me with the ball probe. Show me with the ball probe. So you're showing with the debrider.
Yes, sir.
Show me with the ball probe for a better understanding for the postgraduates.
So this is the lamina papillae.
Yes,
from anterior to posterior.
Okay, right.
Just superior to the maxilla.
Very good. Good. Yeah. So I think postgraduate will understand.
Can I have the debrider?
Okay. Yeah.
Mauli,
sir,
having opened sphenoid ostium to a larger extent,
yes,
can
sir.
you trace the lateral wall or the sinuses?
I'll
from
do it, sir.
Lamina papillae to the optic nerve.
I'll do it in a minute.
Rajshekhar? Dr. Rajshekhar?
Yes, sir. Yes, Rajaram.
You see that this case is so beautifully done. Hardly any bleeding.
Okay.
Okay, isn't this something not very usual? What do you think is the criteria for such lovely surgery? You can answer it.
No, your voice is not clear, Rajaram.
Why do you think this case has come out so beautifully? There's hardly any bleeding.
Yeah. Why?
Yes, I would like the audience to interact. I'd like the audience to interact. One is, it's not an infective case. Number two is the anesthetic part. Number three, this is beautiful, long, it took a long time to decongest the area. Any other things?
Yeah.
Pre-medication or something like that, pre-medication or preparation of the patient before the surgery.
What's heart rate now?
Heart rate is 65, sir.
Oh, that's the reason. Yeah, better. More than hypertension anesthesia, heart rate is very less. Capillary bleeding will not be there.
Yes, sir.
That's a point. Anybody else?
The proper preparation of the patient is.
Yeah, proper preparation.
I think Chandramohan has got a lot of time to prepare the case. Before,
Yes,
so before that, Dr. Siddiq was doing surgery, no? That
Yes,
time
sir,
he prepared well.
I had a lot of time to pack. Once I packed in the OP, and then after intubation, again I had a packing. Intraoperative also I had a packing. So 3 times I have packed this.
It's a dream
Yes.
to have such a patient. Pretty well such a- So good.
Can you see the skull base?
Yeah, good, very good. Good, super. Skull
Can I
base,
get
yeah.
Can I
Yes,
get an
sir.
angle scope?
It's actually almost floor of the cribrium plate, no? That's.
I'll just in a minute I'll show you with an angle endoscope, sir. 45. 45, huh? One more cell is there. Can you see?
Yes.
Just trying to remove all the cells which are anterior. I'm going to out fracture this. Can you see the frontal?
Yes, yeah.
It's
I'm
getting
just uncapping the Agarnacea cell. Can you see?
Yes.
Yeah. Bubble is coming. Yeah. Yeah, bubble is coming.
Different. Can I get an angle scope? In a minute, I'll change to the angle scope. This is
Already 2-3 minutes gone, pa.
Regarding the surgical field, sir,
Yes.
there was a Bossard grading system, sir. In that, they tell that to get a very good field, you have to pack the 3 packs before surgery. Packing between the septum and the middle terminate. Second packing in the hiatus seminolaris superiorus. Third packing in hiatus seminolaris inferior. That's all. So 3 packing is you have to do. Second point, 3-point infiltration. But nowadays they are not doing. The first point just above the axle of the middle terminate. Second point, infiltration just behind the posterior end of the middle terminate. Third point is greater pointed canal.
right now I am using a 30-degree.
To see the frontal sinus, no?
Yes, sir.
Are you using the angled debrider or
Yes, sir.
Angle debrider, yeah.
angle debrider? Okay.
Yes, sir.
Good. Yeah.
Can you see the frontal?
Yeah. Good. Yeah.
Because it's not well pneumatized frontal. If you see the scan, you can appreciate. Sir, you can see the bossing of the posterior.
To Suresh Kumar, sir. Mauli?
Yes, sir.
You are getting one more audience.
Good morning, sir. Suresh Kumar, sir.
NSK.
Good morning, Mauli. Very happy to see you all. Right.
This is the frontal. You have the.
Mauli.
Yes, sir.
Madam is asking for trans elimination, and another one I am seeing the anterior ethmoid artery. Both you just point it out.
Point it with an instrument.
Can I have the lights off? 45.
Lights off, please.
Good
afternoon, sir. Great, sir.
70, 45.
70.
70.
Outside. Good. Super.
Camera.
நல்லா தெரியுதுப்பா.
நல்லா தெரியுதா சார்?
Good. Super.
Sir, well seen, sir. நல்லா இருக்கு.
Okay, sir. Now this is the frontal.
Anterior ethmoid artery also we can show in this level.
Anterior ethmoid artery light போட்டுடலாம்ப்பா.
Section.
Endoscopic picture.
45. I'm just working anterior to the anterior ethmoidal artery. Can I get the ball pro?
Good afternoon, sir. Professor Suresh Kumar, sir.
Good afternoon, Sudhik.
வணக்கம் sir.
வணக்கம்.
ரொம்ப தைரியம் தானே உனக்கு?
சார் ஸ்கிரீன்ல பார்த்தோன்னே குட் ஆஃப்டர்நூன் சொல்லணும்னு தோணுச்சு.
பார்த்தேன், அட்டென்ஷன் இல்லை, பார்த்தேன்.
Thank you, sir, coming.
Thank you. Yes.
சரி, மொத்த பேரும் இப்படி வந்துட்டீங்களே.
So you are showing the anterior ethmoidal artery, is it?
Yes, sir.
Yes, sir.
That's it.
Okay.
Okay, yeah.
Anterior ethmoidal artery.
Yeah.
Okay.
So there's no mesentery, no? It's directly attached to the skull base, no?
ஆமா sir.
No mesentery.
Only 15% people will have mesentery, sir.
Okay.
So this 70-degree has an advantage of seeing all the sinuses.
It's a 70 or 30, 45 or 30. What's exactly?
What I am using is 70.
70 years. 70 also it is striker.
Yes, sir.
Oh.
We are in the luxury of seeing all the latest gadgets.
Surgeon is also young.
Sir?
Surgeon is also young, latest.
Not dye, sir. Not so young.
அப்படியா? Fluorescent dye அப்பா?
See, all of us here are eligible bachelors.
See, with 70-degree, in one look, sorry, it's merging. You are able to rotate and see the frontal, sphenoid as well as the maxilla. Can I have this 0? We'll just have an end-on view with the 0 degree and finish off with this side.
Well demonstrated.
Thank you, sir.
So congratulations, sir. Very well done.
Thank you, madam.
Very
All
good.
the teaching of the teachers, all of the audience who are there, all are my teachers, madam.
You should definitely has to thank us because otherwise you would have been in Kanyakumari.
45. So this is the view with the 0 degree. You have the maxilla, the sphenoid here, right in front is the skull base, and then moving anteriorly, I can see the frontal.
Can you show us the frontal beaks? Medial, anterior, lateral.
Ball pro. This sinus is not well developed, sir. So this is the frontal upturn part, which is seen here.
Okay.
Medially, you have.
Okay.
In the scan, you had a pneumatization in the frontal. I hope you remember, sir.
Yeah, yes. There are 2 or 3 septors are seen. No?
Yes, sir.
Now we are using 0, no?
Yes, sir. 0 degree.
Okay.
Now we'll move on to the other side, sir.
Okay.
Anything else you have to see, sir?
No, you go to the other side, but do the uncinectomy with incision technique, not with the backbiter. Okay.
Yes, sir. Can I have a small pack?
None of the postgraduates want to ask questions?
Sir?
None of the postgraduates want to ask questions? Irukangala?
I have already warned them not to ask, sir.
Oh, you are warned them.
Sir, one postgraduate Satyanarayana wants to ask a question.
Yes.
Satya.
Satya.
Yes, sir. Good morning, sir.
Morning.
Sir, kindly show the anterior ethmoidal artery, sir, in the.
Hey, இப்பதான் வரியா?
Yes, sir.
Patient.
பாத்தீங்களா? இதுக்காக தான் அவங்களை பேசவே விடுறது.
Just a minute, patient is coming out. Tubeless secretion இருக்கு. Satya's question was the right question in the wrong time. Really? Ball proof. Sickle. In sickle.
Mauli.
Sir.
Okay. You are. Where will you exactly put the incision, Mauli? Before that, you will confirm.
Yeah, I have to confirm whether it should be medialized, sir.
Okay.
Otherwise, the chance of injury to the lamina is more.
Okay.
I've already medialized with the ball probe.
Okay.
And then this is the inferior turbinate.
Right.
So just superior to the inferior turbinate,
Okay.
you incise parallel to the lamina.
Okay.
Patient okay, va?
Okay.
Ball probe. போட்டுக்கலாம். செக்ஷன் போடணுமா?
Incision.
Yes, sir.
எல்லாரும் சாப்பிட போயிட்டாங்களாப்பா?
சார் இங்கதான் சார் சீனியர்ஸ் எல்லாம் இங்கதான் சார் இருக்காங்க.
I appreciate the seniors. Very good.
ப்ரொஜெக்ஷன் அங்கேயே இருக்கா? இல்ல.
ராஜாராம் சார்,
Yes.
பாதி பேர் சாப்பிட்டு இருக்காங்க, பாதி பேர் சாப்பிட்டுட்டு வந்துட்டாங்க.
அப்படியா?
நீங்க என்ன சாப்பிடலையா?
இதெல்லாம் சாப்பிட்டா தான் உண்டு.
Section.
Okay. I'll ask you a question. Ailasami. When you are doing a surgery,
சொல்லுங்க சார்.
உள்ளுக்குள்ள பார்க்கும்போது do you get the feeling ஐயோ இந்த கேஸ் ஆபரேட் பண்ணா அட்ரோபிக் ரைனைட்டிஸ் வரதுக்கு ஒரு வாய்ப்பு இருக்குங்கிற ஒரு சந்தேகம் என்னைக்காவது தோணி இருக்கா?
இல்ல சார், அட்ரோபிக் ரைனைட்டிஸ் இஸ் a different disease altogether.
பார்த்தாலே இதுல கொஞ்சம் ரொம்ப ஓவரா மியூகோசா எடுத்தோம்னா we stand a big risk அப்படிங்கிற மாதிரி எப்பவாவது தோணி இருக்காங்க?
இல்ல சார், என்ன ஒண்ணு வந்து ஒரு காலத்துல I was very radical. I had done more than 1,000 total inferior turbinectomies. None of them have developed any atropic things. But still, nowadays, I am a little conservative. I do my technique of tunneling turbinoplasty technique. But otherwise, and moreover, in face, I preserve most of the mucosas. You can watch all my videos. Youngsters are here. They can watch all my videos in YouTube. Hardly any raw bone anywhere. When you preserve mucosa everywhere, you don't get scarring, synechitis, crusting, everything. And the atropic rhinitis is a different entity altogether.
Different state.
ராஜாராம் சார். ஹலோ.
சொல்லுங்க.
அதான் அட்ரோபிக் ரைனைட்டிஸ் routinely debride or avals with normal cold steel instruments. Comparing with using lot of diathermy.
Okay.
So we use diathermy, more chance for
more chance of
atropic rhinitis.
Not atropic rhinitis, atropic changes. Atropic rhinitis is caused by this bacteria called what is Klebsiella. Yes, Klebsiella. So here you get an atropic changes if you use a lot of terminate everything removal and cautery, mainly cautery that damage all the mucosa. I usually tell in all my workshops, no fire inside the nose.
Okay. Have you seen anybody doing cases getting atrophic rhinitis? I have a feeling atrophic rhinitis cases are coming down nowadays. Is it the right feeling?
Sir, you are confusing between empty nose syndrome and atrophic rhinitis, or atrophic rhinitis?
Empty nose syndrome is
atrophic rhinitis. I haven't seen in my practice so far, sir. Post-operatively, I have seen atrophic changes, not atrophic rhinitis. Atrophic changes means there may be sometimes crusting and everything. This atrophic rhinitis is that very foul-smelling crust and everything, greenish crust and everything. That is a different disease, sir.
No, but one of the etiology of atrophic rhinitis is also trauma. Yeah, surgical trauma.
No, I don't think so. It's a disease. I haven't seen it.
You give importance to the bacterial infection and the
Exactly. It is a bacterial Klebsiella. What is that? Klebsiella Osenia.
Osenia. The மாதிரி இன்னும் 4 இருக்கு. Forgot all those things.
Yes.
One more way of removing the bulla is take the ball. You can anteriorly outfracture the bulla. If you have a recess there,
okay,
just use the ball probe, go behind the bulla, and then outfracture it anteriorly.
Yeah, so some use even the J curate also for this step.
Yes, sir.
But when you teach youngsters, I don't advise this stuff because you don't see the tip of the instrument when you are doing this stuff.
Yeah, definitely, sir.
So always we have to teach the youngsters.
No, you told all the youngsters are in the lunch. Only the elders are there here.
That I didn't tell somebody else. A lot of youngsters are here. More than 40 people are here.
Okay, sir.
So I told one batch has finished lunch and
okay, sir, okay.
And come back.
They will come back, yeah. அப்படியே போயிட்டாங்க.
Sir, முடிவு sir. 10 minutes. பண்ணிடலாம் sir.
We are in the post-eighth man also, no? Now we are post-eighth man, isn't it?
This is the basal lamella, sir.
Which one?
Which one?
This is the middle turbinate.
Okay.
So just remove the anterior ethmoid. See, if you have a doubt whether you are in the anterior or posterior ethmoid, just put the suction inside the maxilla and see the posterior wall of the maxilla. See, can you see the posterior wall of maxilla?
Yeah.
There behind.
Yes.
So this fairly gives an idea of whether we are dealing with the anterior or the posterior ethmoid. See, now without fear I can open the
okay.
basal lamella because my suction tells me how depth I am. So if you are in the, you have to assess the posterior wall of the maxilla.
Okay.
Your skull base will be in the coronal section of the skull base. So when you have a doubt whether you are dealing with the basal lamella or you already opened the posterior ethmoid.
Okay.
You just have a look at the posterior wall of the maxilla, then you will have an idea of where you are.
Good point, Molly.
But recently Narendran, he went to US, sir. What I have learned from him is he says people for ordinary face also they are doing image guidance.
Image guidance.
Yeah, they do surgery just like playing a video game.
No, it's not a video game. People who don't know proper anatomy, they use. That's what I say.
No, it's
even in
if you know the anatomy where you want to use, no need.
Even in Stanford, they are using it, sir.
Stanford, Pittsburgh,
whatever place. If you know anatomy, you don't recur. That's all. See, it's like navigation coming from MMC to Hotel Radisson Blu. If you know the way where you want to switch on the navigation, Google navigation.
Yes, suction. Yeah, whenever there is a problem, especially when you are dealing with tumors or extensive diseases.
Is it mandatory, Mauli? For example, facial monitor is a must for mastoid surgeries like that.
Must.
Is it a mandatory navigation system?
It depends, sir.
Is it in their system?
Yeah. For insurance,
For
whatever they claim for insurance, they. So we'll move on to the next case, sir. For want of time.
Okay.
Next case will be revision stapes surgery done by Professor GSK, sir. Now, Professor GSK will take over and talk something about the patient.
Mauli, fantastic demonstration.
Thank you, sir. Thank you, sir.
Good demonstration, Mauli.
Congrats.
Thank you, sir. Thank you.
Congrats.
See,
straight.
Johnny Raman, he has 2 or 3 navigations, but he hardly uses for any phase, not even skull base also. He does all skull base daily, 2-3 cases. He never does because he says it wastes my time.
Hello.
Mic off. Mic off.
Hello, sir. Can you hear me?
Hello. Yeah.
Sir, we'll be proceeding with the next case, sir.
Okay, madam.
Yeah, the 48-year-old male who presented with hard of hearing both sides, right more than left, for the past 5 years. He has undergone a right middle ear exploration and stapedectomy 4 years back, but I think there was no improvement of hearing after surgery. On examination, tympanic membrane clinically normal on both sides with intact cone of light. Tuning fork test was negative on both sides and Weber not lateralized and ABC not reduced. Next. So this is his pure tone audiometry, which shows both sides moderate to severe mixed hearing loss. Next. Yeah, this is the scan picture of the patient, which Dr. Sundar Krishnan will be explaining. So our clinical diagnosis is bilateral autosclerosis, and we are proceeding with right-sided revision stapedectomy under local.
Focus on
the camera. Outside camera on.
Hello.
Yeah, hello, sir.
I will just going to read the CT scan.
Sir, before that, as already right is being done and there is a persistence of conductive deafness, sir. Why you want to again choose the same side? Anyway, you leave that side and go on to the other side.
If you
choose the right side, what are the criteria to choose the same?
Cochlear reserve is good.
Okay, sir.
And you can see the scan. If you see the scan, this is the coronal section of the ear. So this is the right ear showing the sputum, malleus, and insert. Are you able to see the picture?
Yes, sir, we are able to see the picture.
Yeah. So this is the angle of head of malleus, the incus. And to go further down, you can see the processes here. The processes which is slipped from the incus, I think. And you can see it is displaced. Okay. The most common complication of recurrence of hearing loss in stapedectomy is displacement of the piston. So in this case, it is. Are you seeing the picture?
Yes, sir. We are seeing the picture. Small announcement, sir.
But if possible, it will zoom in. Yeah. When you are explaining some particular cuts, please zoom in the cuts.
It's upside down.
Upside down.
A small announcement. This session will be chaired by Professor Ahila Sami and Professor Talabadi Ramkumar.
So in this case, mostly we expect a slip process. So the scan is done. Usually I don't do a scan for stapedectomy routinely, but since it's a revision, we like to know the what the process is there displaced or the long process intact. So here you can see the long process and you see the this fish type of process is which has been moved around here. And look on the right side match is clear, whereas the left match side is zero. So most especially what I expect is slip processes and this is the coronal, the axle section. You can see the process is being displaced here. So apart from this, I don't think we need more information from the CT.
1
Probably
minute for
they
it.
might look for the cochlear aqueduct. It's very patent.
From the OT.
Okay, now can I go and start the case?
Yeah, please. Can I introduce Dr. Professor Talapati Ramkumar, designation Professor of ENT at KGH, Chennai. Special interest in endoscopic ear surgery, anterior skull base surgery, and
extra
Haila Sami, we have already introduced.
instrument. என்னோட செட் இல்லாம வேற என்ன நடத்தும் இல்ல வேற என்ன எடுத்தோம்னு கேக்குறேன் சிக்கல் அது 3 மாத்திரம் எடுத்துருமா 27 28 இருக்குமா ரைட் tooth. இது கொடுங்க பெக்கஸ்ல ஏதாவது கொடுங்க டில்லி கொடுங்க லைட்டிங் கேடிங்க லைட் தூரம் அடிங்க ரைட் சார் அதை எடுத்து திரும்பி போடலாம்னு சொல்லி வச்சிருந்தேன் இந்த லக்கு தான்
ஒரு இது ஃபில் பண்ணாம இங்க வெஸ்டர்ன் லாங்குவேஜ் எந்த கை on 18. 18. இன்ஜெக்ஷன் கொஞ்சம் போட போறேன் என்ன
This is not related to the present surgery.
Hello.
Ah.
Are you able to hear me?
Yes, yes, you are audible.
So I'm going to infiltrate now.
Not
Patient is
audible
under
enough.
sedation.
It's not audible. Clarity is not-
I'm using an insulin needle.
Clarity is not enough. Volume, volume. Audio quality.
Pardon?
Audio, yeah, now you are audible.
Sir, what is the pre-medication that you are given for this patient, sir? Can you please elaborate?
Midazolam, glycopyrrolate, ketamine கொடுத்துருக்கீங்களா? So glycopyrrolate and midazolam infiltration.
So do you use a 26G needle for infiltration in the canal or
Yeah,
17?
26 insulin.
Okay, sir.
Can you please introduce who is chairing the session?
So I am Dr. Talapati Ramkumar, sir. Good afternoon, sir.
Hello.
Good afternoon. And
Hello, sir. You are able to hear me. This is Dr. Shankar. Professor Talapati Ramkumar from KGH. He's a professor of ENT there.
you at the center there.
KGH and Professor Ahila Sami.
Ahila.
No need to introduce.
Did you see the CT scan of the display?
Sir, that was not shown.
located,
If you can show it again, we'll be happy, sir.
Maybe the slipped process alone, you can zoom in and show it.
Because I noticed that some introductions were going on while the most important part of that CT scan was being discussed. It's nice. The thing is, maybe you will have a doubt whether it is really dislocated or any other pathology. It's a very interesting case. I'm sure most of the audience should be seated there. I don't know.
Sir, can you focus on the CT scan, sir?
Yeah, we're doing in the other theater.
Okay, sir. Sir, we want the endo picture, sir. Meanwhile, can see. Yes, sir.
Yeah.
Yeah, yes, sir.
Do you have the picture?
Yeah, we got the picture, sir.
Yeah, great. Sumita, get that thing, CT scan again.
Sir, do you routinely apply this stitch to make the canal straighter or?
Tarabachi.
I use, pardon?
Tarabachi is stitch. Tarabachi stitch.
Stitch. Tarabachi stitch, you mean?
Stitch.
I don't use it. I usually use the endoscope just to retract here in the soft tissue.
Yes, yes.
So that the ear canal comes into view.
Sir, what is your opinion about the endoscope holder, sir, for ear surgery?
It should be useful, but nothing like this. No, you can just move your hand like this, cotton ball.
They want to see
Move your endoscope so that you can 2 millimeters, so you can get a view of entire canal, whatever aspect you want to examine. I feel for short procedures, the endoscope holder is not not so advantageous, I feel. Maybe for mastoid and other procedures will be useful.
What is the endoscope that you are using, sir? It's a 4 millimeter sinuscope or 3 mm?
4 mm nasal endoscope.
Great, sir. What is your thought process about using a smaller diameter endoscope, sir?
Like I told you earlier in the morning, this gives better illumination.
Yes, sir.
And wide angle vision is better, panoramic view. And the instrumentation is easy. As you see, because of the length is good, the instruments can be worked around it.
Yes, sir. For every 1 millimeter increase in the diameter of the endoscope, there is 10% increase in illumination actually.
Yes.
So what you say is absolutely right.
Yes.
2.7 or 3 millimeter endoscope with the suboptimal camera is not going to serve the purpose.
Yeah.
But 4 mm scope is good.
Since he's been operated earlier, infiltration, I think, has caused some blebs there.
What is the infiltration that you use, sir? Is it a routine
Usually,
1 and 2 lakh adrenaline or you increase the
usually
concentration?
5 ml of xylocaine, 5 ml of dislot and 5 drops of Ritalin. Fresh mixed.
Okay, sir.
Yes. Yeah.
Talapati?
Yes, sir.
Talapati, this is a novel technique of reading the CT scan. The ceiling light is there and I am putting it here. He has ever done it before in that thing.
During this COVID pandemic, we used to ask our patients to take a picture like this only, sir.
Okay. Can you see that? Dislocated. Can you see this spot here?
Sir, you are not audible very loudly, sir.
Okay, can you see the CT scan?
Yes, sir.
Look at this. And then look at this again. It's fallen on the. There's another CT scan. One more CT scan. Is it clear now? Is it clear now?
Much better, sir.
Can you see that white spot there?
Yes, sir.
That's what the end on view. And then there's another CT scan. Then you will see it on lying on the floor.
So what is the cut, sir? 1 millimeter cut, sir?
Whatever. Is this the one? Yes. What I'm பார்த்தேன். காணோம். Yeah. You can see it here. That's a piston. Yeah, can you see? I think that is the one. It's in a different position altogether. That's all. I wonder if you can see it. Is this effective enough?
Okay, sir.
Yeah, much better, sir.
This is the best we can do, right?
You can go to the endoscopy pictures, sir.
Yes. Endoscopy.
Roses.
2018 it was operated. Now it's around 4 years. It's okay.
I'm just making the canal incisions. Are you able to hear me?
You are loud and clear, sir.
Yeah, I'm just making the canal incision. This is around the 1 o'clock position. I'm including a bit of the skin here. Outer canal skin.
Any specific reason for including that?
Yeah, because this patient has been operated, the periosteum will not be intact, and the chances of more tear is there. It is.
So in revision cases, it's better to go slightly laterally and elevate the.
Yes.
Already some epithelium has peeled off, sir.
That's right. So that's why I'm including the skin so that we have a good flap.
Earlier this morning,
A little bit bloody than the last case.
Pardon me?
A little bit bloody than the last
Yeah,
case
yeah,
you
yeah,
demonstrated.
yeah. It will improve, don't worry.
Maybe you could have used that RF here too.
That's what I thought of initially.
Colorado is right. I don't know. He said it's like that.
Because of the previous surgery, there will be scar tissues there. So you expect some amount of difficulty in elevating this. Some
What is the
cases it's
size
quite
of
easy.
the suction tip that's being used by your assistant, sir?
Freehand technique.
No, the size of the suction tip, is
Oh,
it size 18?
Cotton ball. Chinner suction tip. Suction size ke around. Inner size.
Somewhat bigger, actually.
Suction.
So the cotton ball that you use is soaked with plain adrenaline, or it's
Yeah, xylocaine, 4% xylocaine with adrenaline.
4% xylocaine. Okay, sir.
So here just tilt your endoscope to see all areas where you're going to operate.
Yes, sir.
I'm coming closer to the annulus. Is the picture quality okay?
Yeah, it's very good, sir.
Only thing a little reddish hue. Otherwise, it is very good, sir.
That is because of the bleeding there.
Yes, yes.
So a little bit about the canal preparation, sir.
Canal preparation, nothing, just thorough wash. Thorough wash, good suctioning.
So any role for trimming this hair, use of any hair removal cream or
Normally, I don't use it. Is there any hair removal cream which you suggest?
No, not like that, sir. I'm just asking you because see this hair, it sometimes picks up this blood clot and it is
Yeah,
fogging.
some patients it's difficult. Otherwise, most of them it's not necessary because the endoscope, you just bypass that.
But when it bypasses, sir, many times it fogs the scope, sir. I routinely in my practice use wheat cream to take out the hair. But when I operate in workshops and everything outside, wheat is an ointment, hair removal ointment. Wheat. You apply for some 5 minutes and you just wipe it with a cotton. That I do it in the OPD when the patient gets admitted. Or the previous day when they come for a visit, I clean it. But when I go for workshop outside, I don't have that luxury. So I it with hair. But what I do is I have the micro scissor, that iris scissor. With that, I trim the hair, then I operate.
Yeah, each one has got their own technique.
Yes, yes.
Any other hair removal you can suggest? I'm trying to
all techniques are based on your teaching, sir. So you are the original innovator. So we want to know what you are doing because we have all come to learn from you, relearn, unlearn, and refine our practice.
Relearn.
Because when we were doing our post-graduation, Professor Sundar Krishnan sir was the one person who was doing this endoscopic ear surgery for the juniors who don't know about how it evolved. At the time, there was no microscope that was available. Professor Sundar Krishnan sir actually organized a trip to this Erode, and there we were able to get a sponsor from that JKK Muniraja group and get a microscope. But sir carried along, and he is the one who innovated this endoscopic ear surgery, and he has taken it to the next level. Everybody else, I should say, got inspired, and people have modified and refined their own methods, but we should always go back to the original person who did this and take his words, get his opinion, and follow what he does.
Those days, I don't know whether anybody remembers.
So if not for him, our first 2 years of MS life would have been like doing everything blind. He was the one who exposed all these uncovered or hidden areas. So endoscope not only threw light on this so-called hidden areas in the middle ear, it also made people renew their interest in the field of ENT.
Ailasami?
Yes, sir.
There was a time when removing the hair was very difficult, and then when you shorten the hair, they stand up very firmly. So what I remember those days, what they did was they just apply an ointment in the ear and make all the hair lie down very docile. So it doesn't come in the way actually.
Oh, what you do, sir?
Just put an ointment, any ointment.
Oil.
Ointment.
Okay.
Any cream. And push the hair out as much as possible. They don't get into your way. That is the way it started long, long ago. Now things have changed a lot. Now people hardly ever even remove the gibbery hair.
I think there are some machines available which are probes. You can remove hair from the nostrils, the ear. I think I've seen it in the net. So you can see, I'm just lifting the animals.
Yes. Sir, where do you like to enter into the middle ear, sir?
At this point here. So this is where it is safe for us to enter. So that you can't injure the ossicles, and as well as the jugular bulb also if it is very high. So you made an entry into the middle ear.
So the point of entry is exactly at the point where we usually drill for this otosclerosis, right, sir?
Yeah.
Yes, sir.
So you can see the round window coming to you there.
Yes, sir. Very nicely it's seen, sir.
சின்னதான போடுங்க. So you can see the process there, the wire. Can you see that?
It's not that very clear, sir. It's because of the, I think, blood. Yes, sir. Now we are able to see.
A lot of adhesion. You can see the stapedial tendon there. I think
where this primary surgery was done, sir?
US. Lot of adhesions there. Wash good. I'll just wash and clear the blood.
So fish or shook nut prosthesis?
They said it's a fish prosthesis.
So what is the one that you are trying going to place, sir?
Our Teflon piston.
Teflon piston.
You can see the ring now.
Very nicely seen, sir.
Close ups good.
Would you be doing the otosclerotic drilling, the so-called scooping of that this thing, or this is enough, sir?
No, I have to make an assessment after elevating flap nicely.
Okay, sir.
There are a lot of scar tissues here.
How long ago the previous surgery was done, sir?
2018.
It's only 4 years. So what could be the reason for so much addition, sir? Extensive use of gel foam or?
I don't know. Maybe too much handling.
Do you think there is any role for laser in such patients, sir?
Yeah, either in good hands, it might be useful. See, I think that is the chorda which has been adherent there. I don't know, the tape is.
I think process is intact. Looks intact.
Yeah, I have to elevate some more and see. So that is the handle of Marius.
It's in the incus, but I think it is out of the foot plate, maybe.
Could be. I have to. You can see the addition between the stapes, I mean the incus and the tympanic membrane, which I am cutting.
Probably, no.
I just cure it a little bit so I get a better view. Cure it.
How often do you get a new curate, sir?
I've been using the several years. I usually prefer to buy from Kalelkar. They are the best one. They prepare the best curates. So this is what I bought for several years before. I use it for mastoid surgery, stapes. Maybe once in 2 years or 3 years, I might have to change it.
Would you like to use a drill here, sir?
Yeah, I can use a drill, definitely. But for stapes, I prefer
curating.
Curate, because you can be precise and then not much of bone removal is necessary. So this is sufficient enough.
So regarding this endoscopic stapedectomy, is it right to say that the bone removal for this stapes is of the same amount as that of microscope, or we curate less?
It depends on the surgeon. For me, it should be have not only exposure, there should be enough space for instrumentation. So
Yes, sir.
I make an adequate enough drilling to see the foot plate actually, the facial nerve, and so that we can have enough space to introduce instruments and the piston. If you have previously, I used to do a little bit of curating.
Yes, sir.
But nowadays I do more than that, so that it becomes easier to insert the piston.
Correct.
So you were seeing that a lot of bleeding was there initially. Now there's not much bleeding, which is better. So you need patience. That's it.
So would it be right to say that the overhang was not curated enough that resulted in failure in this surgery, sir?
Could be.
But they have put the piston. Then why are you bothering?
No, but
I
I think
when they are able to put the piston,
they wouldn't have seen the lower end, sir.
It's not enough. That's what.
but they could put it finally what you want.
No, visualization also.
Yeah, it's must. But they were able to do it.
You don't have to cure that, and you can.
மேம் வந்து 10 ஏன்டி சார் ரொம்ப அவங்க கிட்ட வந்து பண்ணீங்கன்னா நீங்க தான் வந்து
Sundarkrishnan sir.
Yes.
Nowadays I use chisel and mallet for this step, that bony overhang removal. I have a design 1 mm and 2 mm chisel.
It is a bit dangerous, I feel. I've seen people using a curate, bone, what to say, backbiting curate. Like
Ratnam sir used to do it once
yes,
upon a
yes.
time.
He used to use the
just like Kerrison punch.
nasolacrimal duct opening thing, but you'll get a facial love because of it. And yours also, I think it's
So
very
he used to use it with caution.
Your hand should be steady, that's all.
No, they can easily dislocate the incus.
Sir, I have seen people with curate also dislocating incus, sir.
You've seen?
You would have also known. It's all as madam is
Sir, can
telling.
you take the endoscope a little bit closer and show us where the lower end of the piston is, sir?
There are a lot of scar tissue here.
Yes,
I
sir.
think we have to remove that. I'll remove a little bit of this overhang.
Exactly. We are able to see the stapedius, we are able to see the facial now, we are able to see the cauda is not there.
Cauda remnant only is there.
Oh, no, I think they were sacrificed.
There's something, I think Talabadi has got a point. No, the vision is not as good as after curating. So it's possible that they might not have seen the lower end of the whatever the processes they use and missed it. இப்ப இவ்வளவு curate பண்ணதுக்கு அப்புறம் தான் ஓரளவுக்கு தெரியும். Or maybe they curated and the bone has regrown at that point.
See, if you notice here, you can see the pyramid here.
Yes, sir.
The stapedial tendon is intact. There is some scar tissue which is adherent to the facial nerve canal. This is the facial canal.
Yes, sir.
Scar tissue. So what I will do is cut the stapedial tendon and remove the scar tissue. I think the fenestra is there. That fenestra might be.
Piston is also not crimped.
Probably they have not completely cut the stapedius tendons.
Yeah.
They have completely cut into the competition.
No.
Professor Suresh Kumar has come, sir.
Welcome, Dr. Suresh.
சாப்பிட்டு வந்துட்டார்.
I thought you will not come, Dr. Suresh.
Yes, sir. Sir,
very glad, happy.
Thank you, sir. Very nice to see your effort. In a very short time, made it possible.
என்ன இது இல்ல கவுண்ட் இருக்குமா ஸ்ட்ரைட் So I'm cutting the stapedial tendon. So you have to remove a little bit of bone, I think. Hurts this. Pick kuda. Straight.
Can anybody guess why this patient had a conductive loss? Everything seems to be all right except for the additions. You think that it is not in the fenestra? Anyone want to make a guess? Ailasami?
Yes.
Hello.
What do you think is the cause for the conductive deafness in this patient? Everything seems to be okay here, except for the additions.
Maybe that may be the cause, but Sundarkrishnan sir told in the morning that patient didn't hear from post-operative period itself.
Yeah.
That means
What do you think is the mistake now?
question may not be properly in the fenestra. Maybe we have to close up look.
Okay, that's one possibility. Talabadi would like to hazard a guess.
Sir, that is very much there, but the
crimping
is also not right, sir.
But it's still in position only, so no problem.
But I have a feeling it is there.
Pain
maybe. Let us see. After that movement, pata theriyum.
They wouldn't have perforated properly. The main problem would have been that perforation wouldn't have, fenestration would have been improper. They wouldn't, either it is far advanced or they have not done the fenestration properly.
Sir, would you like to decongest that area and proceed, sir?
Yeah, just remove this Sinike, wash it, and then see. You can see the stapes tendon being cut.
Yes, sir. Yes, sir. We can see the pyramid also.
Pyramid. Cotton ball.
Fission sonar.
Anybody who gets the right answer, I'll ask madam to give 50,000 rupees as prize.
Sumita.
Sir, fission sonar. Fission processes. Sir?
Talabadi, 50,000 rupees for the man who guesses correct. I can ask madam to give it.
They can
Sir,
see
the organizers can only make the registration free, sir. This is too much actually.
Okay, I will give you. What is it? What is the cause for conductive deafness in this?
It's not in the fenestra, sir. Either they wouldn't have made the fenestra properly or it's not in the
I think they
fenestra.
made a fenestra. They have just put a hook and it's not even.
They have
connected
just put a
properly.
hook. Most of the time it happens where the fenestra is not properly done and the perilimb wouldn't have come. If the perilimb doesn't come,
right
definitely
angle,
it's
right
not
angle.
going to be a conductive.
Sumita has already got the 50,000.
Conductive.
Sir, actually, hello? Hello, I'm audible?
Yeah,
Yes,
you are
yes.
very much audible, Siddiq.
Sir, there are, in Scotland, they're given, sir,
It's outside.
4 causes for conductive hearing loss after staphytotomy procedure.
No,
The
it's
first
there.
cause is lateralization of the
It is
distal.
outside. It's outside.
No, no.
It's definitely outside.
No, no.
So it's outside. Fenestration is there.
Pick right angle pick.
It's a hybrid process. Is part of it is Teflon, the other part is wire, I think.
இது டெஃப்லான் இல்ல இது வந்து
So one part is Teflon.
இது
The
வந்து
one that is crimped to the incus is wire.
இது வந்து fish.
No, this is Robinson's
They told
prosthesis.
the fish இல்ல.
But Robinson's prosthesis is below Teflon, above.
So I just showed it. You can see the lower end of the piston there.
Yes, sir.
It is displaced.
At least this fellow is lucky that the wire processes did not erode the incus.
This is Robinson's prosthesis. Where Teflon is below and above it is wire. That's called Robinson's.
So I removed it. Now we'll just inspect the section.
இதெல்லாம் அந்த டெஃப்லான் வச்சிருக்கோம். ஓட்ட போட்டிருக்காங்க
So a lot of fibrosis is still there, sir.
Yeah.
I think during the procedure there would have been bleeding.
Good. Angle. See, a lot of adhesions there. Probably part of the stapes is also there. Okay.
We can see the various endosteum.
I'll remove this granulation.
Endosteum, the anterior crus is
Alligator.
gone, the posterior crus is there.
You have to be careful, scissors. Scissors.
You can use a scissors, sir.
Because it might strip off the scissors. சேர் ஏதாவது தள்ளலாம் இல்லை இல்லை அப்படியே இருக்காது அதை மூவ் பண்ணாம
Yes, sir. Sir, there are 4 causes for conductive hearing loss followed by stepidotomy. First one is lateralization of processes. Second is medialization of the processes. Third one, necrosis of the long process incus. The fourth point is loosening, fitting of the process over the incus. These are the 4 causes for conductive hearing loss. 2 causes for yes.
Yes, sir. Proceed.
The other practical things are not making the fenestra, incudostepedial, sorry, malleoincudal joint instability, fibrosis, so many other things.
Okay,
Siddiq sir, what they meant by medialization of the piston,
you
sir?
can see the fenestra is partially being made here, covered with granulations. Pain இருக்கா? The bar handbar. So I'm just going to widen it with the handbar.
Sir, GSK sir.
Yeah.
Could this be some fascia that is put over the whole window, sir?
You may be correct. That can cause.
Because whatever fibrosis we are talking about doesn't look like extended fibrosis, sir. Looks like some fascia that was put over the.
No, I think they put some fat, some earlobe fat.
Okay.
Would you like to use a smaller gauge suction tip here, sir?
தலையாட்டாதீங்க சின்னது பண்ணு. I can feel the fenestra as well.
Okay, sir.
I'm just widening it. In the cotton ball,
Sir, the people against endoscopic stapedectomy, they tell that if you land up with complications, it will be difficult to manage with one hand. What is your
which complication you are talking about?
So, perilymph leak,
perilymph gush.
Gush.
Yeah, I've managed it endoscopically.
Yes, sir.
I've had 1 or 2 cases. This is not a big deal. You need just experience. You can see the fenestra there, and probably there's a fat there. Are you able to see the fenestra here? Small one.
Yes, sir. Very small fenestra is seen.
But whether the perilymph is coming or not, sir.
Right angle pick. So I'm just going to clear it and have a better view of the fenestra. See, this is the region of the thalatadinga. This is the region of the fenestra.
Yes.
Is picture is clear, sir?
Picture is clear, sir.
Yeah, because we can appreciate fenestra here. That's what I'm asking.
No, it's not very clear here because of the blood. I think the red out is there.
Oh, okay.
Wash good.
Are you using saline or ringer lactate for washing, sir?
My sister is giving saline.
Okay, sir.
The fenestra, I think it is very small.
Very small, sir. Probably 0.4.
Yeah.
That is also an important cause for conductive deafness. Larger piston and a smaller fenestra.
Talabadi sir,
Yes, sir.
probably ringer lactic solution, we can use it in the functional endoscopy sinus surgery. It will prevent and invade the infection, it seems, and compared to the normal saline, the study has been done. About medialization of processes, you asked, no?
Yeah.
That is, after fenestra, that piston will be placed in the fossa
Right angle pick.
anterior fenestra. That is called medialization.
Right angle pick.
You mean to say that the piston will be deeper into the vestibule? Do you mean that as medialization or?
No. It won't go into the fenestra.
Okay.
Instead of that, it will go into the fossa antifenestrum, where the atherosclerosis is commonly found. No?
Yeah,
In
that's
that place,
called postula antifenestrum.
Is
that
that fistula
what-
antifenestrum? Yeah, that
Can
right.
Postula antifenestrum. Posterior is called fistula anti.
And now fenestra, can you see, sir?
See, that is the fenestra. So I'm just widening it.
Sir, GSK sir, you have to be a little bit louder, sir.
Sir, we are not able to hear you clearly, sir.
Okay. Now?
Better, sir.
Okay, I'm just widening the fenestra. It is not sufficient.
Okay, sir.
It is just very small. There are a lot of this probably.
Lot of additions still, sir.
Addition is there, but
You can probably raise a flap or something like that to remove that. That one, sir. திருப்பியும் போய்
Barbar. Yes, I'm just widening it. Just widening it, I can feel it, that it is widened. So this is a 0.6 mm handbar, which I'm using 0.6. So I'm going to be using a 0.5 mm piston in diameter. Gel foam.
I would like to ask the audience, all those who have operated on stapedectomy, revision stapedectomy, I think this amount of granulation tissue is quite common in all cases of the dislocation. Am I right? This amount is not really too much. Anybody commenting?
I have operated on
Sundar Krishnan? இந்த அளவுக்கு granulation tissue is present in almost all dislocation cases. Processes dislocation cases.
It depends on the reaction of the patient to the foreign body, like Teflon. Good pistons, I think, cause less reaction. But I've seen earlier in my days when we used to do staphylotomies in GH, where pistons are 20 rupees piston, which is available opposite to the college. It was not at all good. So that I found the patient persisting with deafness after surgery, even though the surgery went well. So when opened, we can see granulations completely filling. But now, recently, after using better pistons, I don't find block. I don't find any granulation. Probably putting the fat or other things inside the middle gel foam can cause. That's why I don't use gel foam at all. I, in fact, avoid using fat also.
How do you seal the piston then?
See, this is a tight seal actually. I make a saline open. I make a 0.5 millimeter opening, 0.6 millimeter. I use a 0.5 mm diameter piston. So that's sufficient. It snugly fits in. It allows the function and I think if I remove this granulation tissue, forceps, there is no chance of leak, and the blood surrounding it causes the sealant.
Put blood there, one drop of blood, or
It is already there.
Already present.
It is already there.
So you can use that radio frequency to.
Yes, sir.
Excuse me.
Please.
Somebody asked some question.
No.
No, sir, regarding that removal of the granulation, probably if you have that your radio frequency thin needle, maybe.
Radio frequency, yeah, but I don't want to use that there.
Since you
Maybe a laser could help better.
Yeah, we are not laser surgeons. So you can see the palestra now.
Yes, now we are able to see.
Okay. So I'll just if the bug goes inside freely, that means we are done with the opening. It is going inside freely, no?
Yes.
Now I think it's time for the piston.
Isn't it still small?
See, my 6 millimeter burr is going freely.
Yes, sir.
Did the patient have giddiness, sir?
He didn't have any giddiness.
Oh.
So once you do the stepidotomy, do you give dexamethasone intravenously to the patient, sir?
What for?
I'm just asking you, sir, because people believe that it prevents that serous labyrinthitis because dexamethasone has also got a good anti-emetic activity.
Right angle picture.
Prevent the labyrinth from going for a shock.
Anything done gently and meticulously, you don't have to give all these things.
Okay,
only if you don't have give respect to the tissues, you have these difficulties. In that case, you will need mannitol and all whatnot. Okay.
Yes, sir. Got it, sir. So what is your routine post-operative protocol for stapes patients, sir?
Nothing. Just antibiotic, antihistamines, 4.75 good.
When do you discharge your patients, sir?
The same day.
Same day.
Yeah. I keep it for 4 hours observation, then send off. So post-operative, if the patient have giddiness, I ask them to take Stugeron SOS. Otherwise, no other I mean, the usual precautions will be there, but no other medicines is necessary.
So
regarding
yes, sir. Yes. So basically, you insert a piston that is snugly fitting into that fenestra, and the fenestra size is just enough to accommodate the piston.
Yes, it goes
without any gel foam or fat.
Yes, it slides in and out freely. That's it. There's not much gap around it for the perilimp to leak. Even if it is there, it will be arrested by the blood which is collected there. It will cause a good sealant. I never use gel foam. I probably use some fat sometimes. Regarding perilimp fistula, you had asked me whether it's an handicap with endoscope. Well,
Yes, sir.
I would say you have to master this technique, then it is easy. Because the same thing you are doing in the microscope, you are doing it in the endoscope. Only both ends, one hand is occupied. But you have an assistant who will keep the suction around, remove the perilymph is there so that I can place a graft and put a piston. So this happened to me twice. I managed it with the endoscope itself. I never went for it.
Okay, sir.
என்ன பண்றீங்க piston? So I feel 4.75 piston will be adequate. the length.
So do you measure, sir?
I usually don't measure, but I
Okay.
can see this with this pick itself. Probably 4.75 will be adequate.
So, sir, have you got any experience with any other type of piston other than the Teflon piston that we use?
Yeah, no. Only I use Teflon pistons.
Okay,
Because
sir.
other pistons are not available. I'm not familiar with that. See, the advantage of the endoscope in stepidotomy or stapedectomy is the incus is in sharp focus as well as in the fenestra. The same field. So you don't have to adjust the anything. You just have to put it inside because the same field is very easy. In a microscope, it is slightly difficult. I have done enough stepidotomies with the microscope also, but I find this as easier than microscope. I feel it. Probably most of you have done this, and I think, what is your opinion?
Sir, you being the preeminent endoscopic ear surgeon and accomplished endoscopic skull-based surgeon, how do you compare this endoscopic ear surgery with skull-based surgery, sir? Do you think that both are same thing, or you need to adopt?
See, ear surgery is fantastic. It is. It needs a lot of skill, and the results are good. So you have is very gratifying on the table post-operatively. But the skull base, you are saving the life. Sorry. Pillar. I like both, to say, skull base as well as this.
No, sir. People who do this endoscopic skull base, they have a critical view of endoscopic stapedectomy. They say that it is not correct. So that's why I'm asking you, because you are a master in both. You are the right person to answer this.
No, I don't understand why they say that. Once I presented this in ISO.
Yes, sir.
There was this portman was there. Portman, I think he's junior portman.
Yes, sir.
I asked him, what do you think about endoscopic stapedectomy? So he told, I tried. It's very difficult.
So thing is, house ear clinic also, they have started to do endoscopic ear surgery, and I've seen 1 or 2 videos of endoscopic stapedectomy also. So there is no question about the role of endoscopes in ear surgery. It is firm, it's well established, and there is no doubt should be in anybody's mind about using endoscope for middle ear surgeries, sir.
Middle ear surgeries, endoscope is the best, I feel. If you go to the master also, if in experience chance, you can do it. But middle ear as such, I think any PG, if you ask them, they say that endoscope, they find it very comfortable than the microscope. What is your say? I don't know.
No, sir, absolutely. We agree with you. The endoscope has made us revisit the canal as a route of entry for our surgeries. So we are able to see everything in one single view without a hand coming into the view and obstructing the field.
Correct.
So there shouldn't be any doubt in anybody's mind about the use of endoscope for middle ear surgeries. So this should be the norm. Endoscope should be used for diseases of the middle ear.
Yes. Good clearance is achievable. Good results
Because
guaranteed.
there is no concept of hidden areas. The minute you take an endoscope and put it in, the first structure we are going to see are these critical areas, and sinus tympani is no longer hidden.
That's right. You think the fistula is too long? No, we made it sufficiently.
Not open, sir. It's a bit long and it's not open.
Hello.
open பண்ணிட்டு then probably.
இல்ல, it is better to put a lengthier fenestra, especially in revision.
Yes, sir. This case we can put in a
Yeah,
line.
because I find that gives better results. And yeah, especially in this case where it is slipped.
Definitely additions would have been there in the vestibule as well.
This fenestra is not made accurately in alignment with the incus. தலைகளை கொடுத்துருக்கியா இப்படி கொடுக்கணும் anteriorly. When I make a fenestra, I make it so that it is in alignment with the incus.
Yes, sir. Excellent, sir.
Yeah. Suction. I'll just check. It's in the foot play. I mean, the fenestra. Applying suction. Yeah, it is inside. Now I'll use a picker to just check whether it is angle. So I'll just move it around.
That bending test?
No, see, we'll see. I'm moving it around. It is snugly fitting inside that.
Yes, sir.
Okay. Now I'll just check the hearing. Sir, unga per enna?
Yes, sir.
எப்படி கேக்குது? நான் சொல்ல திருப்பி சொல்றீங்களா?
நல்லா கேக்குது.
நான் நம்பர் சொல்றேன், அது சொல்லுங்க. 20. சொல்லுங்க, திருப்பி சொல்லுங்க. 20, 25, 32, 40. Fantastic. His hearing is improved.
Excellent, sir. Superb, sir.
Yeah. Forceps, cribbing.
Wonderful demonstration of revision stapes. It's a very tough case. We did it with elegance and poise.
I think it is closed already. I'm not going to crimp it because it can cause necrosis again.
Yes.
It is yeah, in another few minutes. Dumbelator, gel foam.
Sir, how many cases have you done on this?
Revision. Revision, yeah, I've done maybe 20 cases. More than that, I don't remember. Dumbelator.
Suppose this had a incus dislocation. How would it change your?
Yeah, in those cases I do a forceps, malleable vestibulopix.
Do you use any different piston, sir, or
the same piston, lengthier piston? That's all.
Okay, sir.
Dumbelator, yeah.
Nice to have seen such a nice case, done with absolute confidence and.
As we can all see, there is no tear in the canal skin. So what sir told of going a little bit laterally and including the skin is right. Because this skin was very thin in this patient.
Yeah, it was adherent, so it was difficult elevating.
Sundarkrishnan sir,
yeah.
Regarding one question you asked, that which is better, the microscopic or endoscopic? I too started with microscope initially, but after that, when I started endoscopy, that was very, very comfortable. I think you will remember my first stapedectomy chance you gave me in MS third year when I was doing.
I remember.
I struggled for 30 minutes to put a piston.
Me and Siddharth Raj.
You are Dr. Siddharth Raj sir should put the piston.
Yes.
You told you will not put. I had to put and come whether it is 30 minutes or 1 hour. Then finally I put it.
Yeah, I remember it was like it was yesterday.
Thank you, sir. Thank you, sir.
So it depends.
It's all your blessings, sir.
You are a hardworking fellow, Jalfam. I
Thank you,
remember
sir.
your PG days, so you deserved that.
Thank you, sir.
So only in doing stapes surgery for the beginners, I'll tell you, you should be very confident. There should be no doubt in your mind. You think you're going to do good for the patient and stick on to that and be confident. That is the important thing in stapes surgery. Never doubt yourself. When you have some doubts creep in your mind, definitely you might do some mistakes.
One more question to you, Sundar.
Yeah.
Have you ever, how many cases have you done roughly without removing the posterior superior wall? I mean,
Scotum.
Yes.
No, I removed a part of
Always.
it. Yes, always.
Have you ever done it without removing it?
Always.
Ailasami, have you
Sir,
done it?
with endoscope, you can see very well without removing the bone. But when you are going to put the piston, that time you will get the difficulty. So, bone overhang curate is a must always.
Yes.
Okay. Now, what do you say about this case where the scutum has not been removed?
It had been a little removed. Maybe, as you pointed out, it would have regrown. The bone would have regrown, reformed, or may not be adequate. But I think should be they would have done some job. Otherwise, they could not put the piston on the incus.
So, what is the answer for the 50,000 rupee question, sir?
Money has already been Sunita. She answered everything. And I want to ask the audience as a little long short question. Can you do a stapedectomy on an anterior approach? The incision in the posterior quadrant. Sundar Krishnan, you also. Can you do a stapedectomy by making an incision anteriorly instead of posterior? Somebody has done it here.
Posterior in the sense post-oral. Post-auricular or?
Without removing curating the bone. There is one person who has done
Sri Ramamurthy.
incision.
Sri Ramamurthy. Sorry, incision is posterior, but he comes, sits anteriorly to the patient and then does the stapedectomy.
No. This is anterior incision itself. It was presented many years ago, and quite a lot of people actually laughed at it. But I think it has been done, frankly. Have you ever heard of this incident? An anterior incision and then going. His thing is, I don't have to cure at bones. I can see everything from the anterior. That is the way he answered the question. I'm wondering if it was ever right.
Sir, this may not be relevant for stapedectomy, but Nirmal Patel, who is having a ear surgery group in Sydney, he stands in front and he does visualize the sinus tympani in deeply pneumatized sinus tympanis, which they call it as type 3 sinus tympanis, but it is there, but with the endoscope.
Yeah, that they used to do with the microscope. Also that they used to stand on the opposite side and operate to see the sinus tympani. But Nirmal Patel, I think he's doing endoscope.
But I don't think they will be able to put the piston from that side, sir. It's not possible. I don't know.
No, I don't think so. See, the stapediectomy endoscopic, I think the first ever stapediectomy with endoscope I have done. I think nobody has published it. I published it along with Sumita early in 2000 itself. At that time, it was not known that can be through the endoscope, you can do a stapediectomy. I think this is the best way to do it. Okay, I finished the case. Thank you very much.
Thank you, sir.
Thank you so much, sir. Excellent demonstration. Thank you, sir.
Thank you, sir.
Thank you, sir. What is the next case, Sumita?
Next case will be a pituitary microadenoma. So Mauli will be starting the case. I'll be joining him. It's plastic.
Hello, audible? Yes, hello?
Yes, sir. Audible.
Now, fifth case of today, post lunch section. 27 years male present with inability to see on both sides of the past 2 years, which was progress to current state. Hello? The previous slide, please. As such, END completion, nothing significant. Neuro-ophthalmic examination, eye movement, people, see a color vision and visual activity fundus were normal. Next slide. So this is bilateral hemianopia. In this case presented, we got ophthalmic opinion also. Next. CT scans finding. Now the Professor Sundarkrishnan sir is going to start the case. Before that, our neurosurgeon is here. He will explain about the CT scans.
Hello, I am Dr. Jyoti Kumar, neurosurgeon. Hello, sir, audible?
Yes, sir.
Hello? Hello?
It's clear. Hello, the earlier one was clear. Hello?
Sir, are you able to audible?
Yes, we are able to hear.
Yes, sir. I am Dr. Jyoti Kumar, neurosurgeon. The MRI shows there is a cellular and a supracellular space occupying lesion with partially cystic and partially solid tumor compressing the optic nerve and optic apparatus.
So kindly put a pointer there.
Classical case of pituitary adenoma. Second possibility is maybe a craniopharyngioma because there is a solid and cystic part is there. Mostly supracellular extension is there. So another possibility is a craniopharyngioma.
Dr. Jyoti Kumar, thank you.
Okay,
We
ma'am.
had also thought, I'm a neuro-ophthalmologist. So
Fine,
we all, yeah. So Dr. Sundarkrishnan and myself, both of us thought like that there is a possibility of craniopharyngioma. Right, sir? Thank you, sir. That is what I'm telling. என்னென்ன சொல்லணும் அவருக்கு பத்தி நீங்க சொல்லுங்க இல்ல நான் சொல்லட்டுமா
நீ பேர் யாரு
requesting Dr. Suresh Kumar to chair this session. You are the one, sir. No, I'm introducing you. Welcome, Dr. Suresh Kumar. As you all know, he is professor and unit chief at the prestigious Madras Medical College, Upgraded Institute of Otorhinal Literature. Yeah, he will give us a very good live interaction. Thank you, Dr. Suresh. Professor Suresh Kumar is actually... Thank you. ரொம்ப நல்ல சூப்பரா பண்ணீங்க made it interesting.
So in the meantime, there is a quiz for the young ENT surgeons and the postgraduates, right? So what will be the prize is that the book will be given as a prize for the winner and only one book for each individual, right? It's all, the question is being given by the Dr. Kantamani madam. It's all related to the surgery of ENT, and it is very interesting. And she wanted that everyone should know about the complications and the diagnosis and the management, right? Okay. So one person, the person who is standing first, raises the hand, has to tell the answer. If it is correct, I'll let you know the answer, right? Okay. First question. Post-phase patient develops eye pain, lid swelling, painful eye movements few days later. What is the diagnosis? Yes, please. Sorry, Letro, Balwa? Wonderful. Orbital cellulitis is the correct answer. May I know name? Sorry? Vishnu from? Vishnu from SRM is the winner of this question. So,
yeah, the important thing is you should catch it early and then it will not progress to this extent, what I had shown, the last picture. Okay, painful ocular movements is a clue. It can happen due to, next question.
Okay, the same question. What is the cause? Who is going to answer this question? Please raise your hand. How do you get an orbital cellulitis post-phase? Very easy.
I can hear the answers, please. Very good. Please answer.
Please.
Now,
wonderful. Breach of lamina papricia.
Very.
Yes, please give a good round of applause. So please come forward and said at the end of the round, we'll be giving you the book. Okay. Next.
Papricia spelling is wrong. Okay.
Next one. The same thing. What are the precautions advised to the patients? If there is a breach of the lamina papricia, what precautions? Wonderful. Correct.
Very good.
Avoid activities that increases the intraorbital pressure, especially the forceful sneezing. Okay, we'll go to the next question. How do you manage it? Anyone? It's a book
Yeah,
is the
Only who gets up and answers loudly.
Yes.
That person will get.
I will also give the mic. Postgraduates, it's all day-to-day activities you are seeing in your ward, not day-to-day activities. Please.
Conservative management with IV antibiotics and soft anti-inflammatory and topical steroids.
Wonderful. That's the answer. We got it.
And topical steroids need not be given, doctor. Okay. Anyway, depending upon the
That's
severity,
also.
you can manage with
Monosulfur.
oral antibiotics or IV, depending upon the same. Because you're catching it early, oral will suffice, but broad spectrum, double antibiotic.
Wonderful. So we'll go on to the next quiz question. So post general
Sir,
anesthesia for
you
ENT
basically ask-
surgery, patient complaints of watering, redness, and photophobia. What is the diagnosis? Anyone? Any postgraduate? Please get up confidently. It's very, very common.
Relevant, very relevant. Just relevant questions, no theoretical questions here.
So these questions were given by the ophthalmologist, madam, by itself.
Hello?
Yes.
Was not
Answer.
interested.
Who? You answer. Yeah, Ramya Bharati from Madras Medical College. Answer. Exposure characteristics. Wonderful. Next, how do you manage it? Anyone?
Yes. Doctor, get up.
Yeah, please get up. I think so. You got the prize, no?
No, you can't answer.
You got the no.
think you
Please. One book only. Wonderful.
Now, first is eye taping, eye ointment and taping, and later on you can give both eye ointment and lubricants.
Wonderful.
Good, very good.
Yeah. Name. Your name, please. Dr. Raghuram from SRM.
Actually, I think your friend helped.
Okay. This is a very, very interesting case. Madam wanted to put this case in the quiz. Patient complaining of voice change and within hours develops diplopia and descending polyneuropathy. That's the clue. What is your diagnosis?
No, not related to any surgery. Clinically presenting to us. He went to the ENT department, like Dr. Sundarkrishnan. Then he came to me. He was a constable. Previous night, he developed voice change. The subsequent morning, he developed diplopia. It's a very important case. Kindly think and answer. All the questions are like that. And this, very, very important. Anybody, even senior, can answer. No. That's a possibility, but no.
The RF use பண்ணிருமா?
But yeah.
Any other similar to that?
மௌலி RF
Which type? Which type?
நீ அந்த flap incision போடுறது அடுத்து அந்த இது
There is another
பர்ற
type.
எடுத்து விடுங்க.
Reverse.
Wonderful, Dr. Albina, but you will not get it.
Sorry, I shouldn't have told. Why I'm telling you this question is very important is you have to send him by ambulance to the neuro emergency center. They can develop respiratory paralysis. It'll be life-saving. Just recognize these cases. Subarachnoid hemorrhage presenting as headaches. All these patients have to be moved by ambulance, not by investigation.
Okay, but Dr. Albina, I'll give you a copy. Because it's because that that was a compliment copy from Professor GSK sir. So this thing is a quiz question. You definitely deserve this because it's one of the tough. When Madam told this question, even I was amazed. She told that this has to be brought into the forum and this knowledge has to be shared. So, what is the next course of action?
I answered already.
Thiru?
I answered already. Okay. That's what treatment. Yeah, very good, very good. How expensive is it? Any idea? Now it's come down. When this patient, okay. Otherwise, it is it costed 7 lakhs to the patient. No,
Okay, next question. In seventh nerve palsy, what are the two most important prophylactic instructions to be given apart from steroids, physio, and lubricants? Two. So who is going to stand up and answer? Postgraduates. So you're given steroids, lubricants, and physiotherapy. So this is a very practical question. This is from the ophthalmology side, and we have to know this. Yes, please, Dr. Sudarshan. Madam, eye padding. No. Madam wants the exact.
No iPad. Next.
Bipolar.
Huh?
Regular bipolar.
That if it is prolonged, if it is combined with anesthesia, fifth nerve involvement,
Right cell incision.
temporary or permanent.
In the one coming.
It is something like off the beat. We can
Okay.
show it.
Spur இருக்குல்ல, it's a spur இருக்கு.
Closed eye with the fingers while washing the face and wear protective glasses. So this was what Madam wanted to stress.
Yeah, exactly. Like this.
So Madam is demonstrating. Madam, please stand up and demonstrate, Madam.
Yeah, like this. Oh, often you'll see Bell's palsy. I think they come to neuro and ENT people, and you'll diagnose, and then they refer to us. And mostly they have mild lack of thermus. Rarely, if it is due to CP angle tumor or something, then it is very important, whichever case it is, even if it is a comatose patient, if there is exposure, please ask the nurses also or the patient to do like this and then do the cleansing. Keeping the eye clean is very important, or if cornea gets infected, that's it. You know, cornea is avascular.
Madam, with your permission, shall we give the distribute the praises?
Yeah, yeah.
Yes, ma'am. So first I call upon Dr. Vishnu SR from SRM. You bring the sir, Professor sir. Sir, Shankar sir. Please come, sir. Come. Photo. Bring that book.
Few books you can sign. Few books let him sign on that.
Yeah?
Let him sign.
Sir, நீங்க sign போட்டுருங்க sir.
Sir, you sign and give, sir.
Yes, sir. Next, Dr. Ramanathan from Madras Medical College. Dr. Aravind from Madras Medical College. Dr. Ramya Bharti from Madras Medical College. Dr. Raghuram from SRM Medical College.
நான் கம்மி பண்றேன்.
Dr. Devi, madam, please come forward. A complimentary copy for you.
She's also part of Krishna and India hospitals.
And Dr. Balaji, please come forward. From yes.
We're getting from all our stalwarts.
Yes.
Next generation, நீங்க தான் எல்லாரும்.
Thank you, madam. Thank you, sir. Albina, madam, நான் கொடுத்துறேன்.
ஐயோ, sorry, madam. வாங்க, madam.
Madam,
Madam.
உங்க chief கிட்ட வாங்க.
MN Shankar sir ஓட. இவர் சார் நிக்க வச்சு.
Sorry for Albina, madam. Today morning also I missed Albina, madam. Please come forward, madam. Because that was the one difficult question answered today.
She answered beautifully, including the cost.
Yes, ma'am.
Sir is my assistant professor and I am the student of sir. So I managed to answer. And he is sir is my chief.
That incision board, yeah.
Thank you, madam.
இங்க பா அந்த ஸ்பினாய்டு கீழ அப்படியா சரி.
We see this separate night period also. We will say like
அது ஸ்பர் கீழே போட்டா ஸ்பர் கீழே அப்படியே எக்ஸ்டெண்ட் பண்ணிக்கலாம். அப்படியே நான் பின்னாடி போயிடும். அப்போ ஸ்பர் எடுத்தா ரூம் கிடைக்கும். என்ன எண்டோஸ்கோப் 4K-வா? இந்த 4K-வா? 15 blade.
கையில வச்சுக்கோங்க.
We have created for 20 years here. That's what we do. But we have not documented everything. Sir, children like. But he won't give time, sir. He won't give time. Emotionally, it's not good. For 20 years, including Sunday.
ஃப்ளோர் வரைக்கும் போகலாம், டெர்மினேட் கீழே வரைக்கும் போகலாம். பெரிய ஃபிளாப் இருக்கும்.
ரிஸ்க் ஃபிளாப்னா
ரெஸ்கியூ ஃபிளாப் ரிசர்வ் ஃபிளாப் விட ரிசர்வ் ஃபிளாப் வந்து சும்மா இன்செக்ஷன் போட்டு கொஞ்சம் தள்ளி விட்டுக்கலாம். தேவைன்னா எடுத்து யூஸ் பண்ணிக்கலாம். ரிவர்ஸ் ஃபிளாப்னா போஸ்ட் ஆஃப் செப்டம் இருக்குல்ல, அது அந்த சைட்ல இருந்து குளுக்கோஸ் எடுத்து ஸ்டிச் பண்ணோம்.
அடர் ஃபிளாப்னா டோட்டலா மெடிக்கல் பேஸ்.
ஆமா, நேசோ செப்டல் பிரான்ச். Hello. Hello. Shankar.
Yes, sir.
Are you able to hear me?
Yes, sir.
Hello.
Yes, sir. We are able to hear you.
Okay, okay. Dr. Mowli is elevating the Adat's flap.
Yes, sir.
See, there's a deviation of the septum towards the right side.
Yes, sir.
See, a surgeon like me, you would like to use the right side of the nasal cavity to the major part of the work. The assistant will be doing the suctioning and other things in the other nostril. So what we are planning is to elevate the nasoseptal flap, remove part of the spur and cartilage so that we have enough room to introduce endoscope and instruments to the right nasal cavity.
Only it's a bit dark, so can you do some white balancing or washing?
The picture here is good. I think the audiovisual people have to adjust it there.
Oh, actually, last case it was nice, sir.
Yes, can you
Yes,
inform the
again.
audiovisual solla. Picture and dark.
Oh. ரொம்ப dark இந்த light off. This can be brighter. Others contrast கம்மியா அது மேல இருக்குது ஆஃப் பண்ணிட்டு இது நல்லா இன்க்ரீஸ் பண்ணு a bit more. It's a lot better.
Is the picture clear now?
Ah, yes, sir. Better, sir.
Better, okay.
Chandramoli,
Sir?
Tell us something about the flap.
This is a flap which is based on the septal valve of the sphenopathology. So I've elevated because there is already a spur here. I've elevated this flap in the right side.
Which side is the mass more present? Left side or right side of the sphenoid?
It's in
It's
the
almost central.
Almost central. So there's deviation of septum to the right. Which side are you preferring to pass your endoscope? Right side or left side?
like I told earlier, we would like to use the right side because easier for the endoscopic surgeon to operate on the right side rather than the left. So we'll try to create more room on the right side by removing the spur.
Yes, sir.
Okay, and then if it's not correctable, then you go to the left side.
Okay.
Either way, it has to be done.
No, why I asked was whether you are going to apply any four-handed technique.
Yeah, we have to going to do the forehand technique. So left side is already roomy. Right side will make some more room and then proceed with the surgery.
Okay. So this flap is based for the students on the sphenopalatine artery. So
yeah, septal.
Somewhere near the body of the sphenoid is where it will.
Yes,
take
one incision will be just in the lower lip of the sphenoidal ostium. The other on the coena, just in the upper lip of the coena, so it can preserve the blood supply. So he's gone up to the coena there.
Basic use flap. This is a workhorse of all
yes
skull-based surgeries. Anybody knows about other flaps?
We can, other flaps, you want to know what it is?
No, I'm asking the PG, sir.
Okay.
Anybody? Other flaps which can be used for cranial base?
That's it.
So you're removing the spur alone.
Yes, sir.
And what about the posterior septictomy?
Yeah, that'll, we have to do that.
Now it is clear, sir.
The picture is clear now?
Picture is clear.
Okay, good.
They need some arrangements here.
So you can see how meticulously he's dissecting the bloodless field. Can you make it out?
Sir?
Meticulously how he's elevating
Yes, sir. Yes, sir.
Yes,
sir. He's a very good surgeon.
Yes. ఎండోస్కోప్ భయపడుతుందా పడుతున్నాడు அதை விட்டுலாம் நம்ம இங்கேதான் மேலே தான் போகிறோம். ஃப்ளாப் நேசப்பரிங்ஸ் எடுத்து போயிடும், கட் பண்ணி டிசெக்ட் பண்ணி எடுத்தோம். எலிவேட்
Oh.
All the nerves, everything will be traversed.
knife.
Other flaps.
The
Sir will enumerate about the other flaps.
There are a lot of flaps available inside the nasal cavity itself. This is one of it. Now you can extend this flap down up to the inferior turbinate. Entire floor of the nasal cavity can be included in that.
Okay, sir.
Or else you can include the inferior turbinate also. Inferior turbinate also, which and the nasoseptal flap together. And if you want, you can do a middle turbinate lateral wall flaps. These are all handy, especially in revision cases where it is where you don't have the nasoseptal flap as such, and pericranial flaps, which can be harvested by opening the making incision in the skull and bringing out through the upper part of the nasal cavity, and it can be placed. There is a very healthy alternative, pericranial flap. Unfortunately, we are not much used to the pericranial flaps, but I think it is very easy to do that. My neurosurgery colleague will explain about it.
Yes, sir. This
please
nasal
proceed.
flaps are very easy to get as a pedicle, but pericranial flap is a little bit difficult. And as a pedicle flap, we will not able to do it by pericranial.
The picture is a bit dark, sir.
No, picture Sarilia. Nothing.
Chandramouli, can you explain as to what you're doing? Hello? 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 Chandramouli?
Yes, sir.
Yes.
Chandramouli?
Yes,
Can you
yes.
Tell me as to where you are. Now you are in the rostrum of the sphenoid for the benefit of the PGs, just to orient them as to where the flap is going. It's going just lateral to the body of the sphenoid. Isn't it, sir?
Yeah, you can see the
we can see.
anterior wall of the sphenoid coming into view.
And the corona?
Pardon? The corona.
Corona.
See, that's the corona then.
This is the corona.
Yeah.
I'm just parking this flap inside the canal.
Yes. So the septal branch of the sphenopalatine artery is supplying this flap.
The table on the record, the height of the. இல்ல ஹைட்டா இருக்கு நீ இங்கதான் போகணும் இப்போ ஹெட் அண்ட் சரி பண்ண ஸ்ட்ரைட் ஹெட் அண்ட் ஸ்ட்ரைட் முத்து ஹெட்ரிங் எடுத்து ஹெட்ரிங் எடுத்து
எடுக்கிறோமா
I usually don't use the head up position and don't tilt the head also because I like to see the I would like to see the skull base.
Okay, sir. So you prefer to put the head down or head up, sir?
Straight.
Or just straight?
With no headring.
Okay. So it will be fairly straight.
Yes. Ordinary elevator. Ordinary elevator. Can see the superior terminate here.
Yes, sir.
Okay. Action bora.
That's not suction cautery, sir. Sorry, suction.
No, I'm just doing elevator. Just
elevator.
Just a normal section.
no. Ordinary elevator. Action. Clear photo. Elevator. So as soon as I identify the osseum,
yes, sir,
we'll widen it and remove the
think it is
posterior end of septum.
starting to come. The bubbles actually show that the sphenoid ostium is close by.
My elevator is inside the ostium.
Yes, sir.
See the air bubble coming out.
Sir, it's a bit dark, sir.
Is it okay now? Light. Is it? Please adjust. Light.
You can give a wash probably.
Yeah, I'll do it. Wash.
The sphenoid ostium is seen.
can see the sphenoid loss.
Yes, sir.
What new now? Modi, va. Moli, இந்த பக்கம் வரையா இந்த பக்கம் வரையா
Light can be increased, sir. Light can be increased. It's a bit dark.
Nice.
இல்லையே லாஸ்ட் கேஸ் சரியா ஏருக்கு நல்லா ஏருக்கு கொஞ்சம் நல்லா you have to do color balance இல்ல அத LED இங்க வர அவுட்புட் பண்ணு கேஸ் கரெக்ட்டா வந்தது போன கேஸ் ஏருக்கு நல்லா வராது விக்ரம் ஏருக்கு
டிப்ரேடர் ரெடி பண்ணுங்க ஹெரிசன் பஞ்ச் ரெடி
கேசஸ் பண்ணாங்க சார் இங்கே அங்கே அதுக்கப்புறம்
ஹெரிசன் ஹெரிசன்
இது இந்த பிரைட்னஸ் ஃபுல்லா இருக்கு ரெடி பண்ணுமா
டிப்ரேடர் மோட்டார் எல்லாம் ரெடி பண்ணுங்க
ரொம்ப டார்க்கா இருக்கு இது ஒண்ணுமே
I'm
தெரியல.
just widening the sphenoid ostium.
Yes, sir.
Okay, this is the home run part. Now I'll do a posterior subtectomy.
Yes, sir.
Better. Deliver. Flux of it. If I'm doing this work fast, okay, you can see they have opened the
Yes, sir. Yes, sir.
other side. Lux,
Yes,
lux.
sir.
That's the intersphenoid septum. Section. Now I would consider a good sphenoidotomy when you see the lateral of the sphenoid in both either sides.
How far do you go laterally?
That's what lateral wall of the sphenoid should be visible. Brother. The optic canal, everything can be viewed. Yeah. So through the right nasal cavity itself, you should visualize the lateral wall of sphenoid both sides, the planum, transplanum, the clival recess.
Yes, sir.
All in one picture. That I would consider as adequate. Sometimes you might have to remove the posterior model cells also.
Okay, sir.
Okay. Now you can see the lateral wall as such.
Yes, sir.
Right side, Carison.
Inferior limits, sir.
The color or color upturned. Inferior limit, the clavicle recess has to be seen. What are you doing? You can't picture. motor ready for it. Wash.
So you can give a wash, sir.
Yeah, just now. Not endoscope huh? Straight for black. Brother. பண்ணலாம். Wash கொடுத்தாரு.
The scope is getting fogged frequently, sir.
Yeah. Release. This is the gauze kept on the other side, which I am removing.
Okay, sir.
One more is there. Release. You can see the other side of the superior turbinate here.
Ah, yes, sir.
There
You'll
is
be removing that, sir.
Not necessary.
Okay.
எனக்கு பிக்சர் மாறி வருதுங்க. கலர் மாறுது தம்பி. வாஷ் கொடுங்க. So you can see the plane of sphenoidal here.
Ah, yes, sir.
Okay. This is the optic canal. On the right side is the left side. This is the median wash better. So obviously this is the shortest route to the sphenoid and preferable route.
Okay, sir.
So earlier when I started my skull-based carrier, we used to do transeptal route.
Okay, sir.
Now the advancement, the instruments and the
Previously,
flaps.
we used to do SMR and then through the septum, they used to go there. Now,
is the picture clear?
Ah, yes, sir. It's very clear. But there's no sphenoidal bulge, so.
Yeah, you have to remove this, then you will see it. Yeah, the bulge. Upturn percepts. Upturn. This is mucosa which I am stripping out.
Okay, sir. Generally, the sphenoidal mucosa bleeds a lot.
Yes. Okay. Drill at this now. You can see the sphenoid bulge here, huh?
Ah, yes, sir.
Debrider. Third bed. ஆமா. இல்ல இது ஒரு சிஸ்ட் மாதிரி இருந்தது இல்ல ஸ்கேன்ல. இது ஆல் எரோஷன் மாதிரி இல்ல. இது என்ன பர் இஸ் நாட் கட்டிங். பர் சரியில்லை. தேர்ட் டிப் கெரிசன் பஞ்ச். கெரிசன் பஞ்ச். Clean.
ஒரு gloves போடுமா?
கர்வ் டிப் வச்சிருக்கீங்களா? கர்வ்டு. சீக்கிரமா பண்ண டைம் இல்லை. பர்கர் எடுங்க. கர்வ் டிப் கொடு. கர்வ் டிப் மட்டும் கொடுங்க. You saw in the scan there is a small cyst in this region. That's what I'm doing. இது சரியாவே இல்லையா டிபரேட்டர்? எந்த டிபரேட்டர்?
I thought it is a tumor invasion.
No, it is not tumor invasion. It is not. The scan you can see bone partition there.
Yes.
So that is a clival recess. Can you see that clival recess?
Yes, sir.
So this is the carotid there.
Moving the septum
The right
also.
side. Block.
Suction is not working, sir.
இந்த மாதிரி எப்படி பாஸ் பண்ணுங்க? லென்த்தி போறடா. இது அங்க யூஸ் போமா உள்ள. ட்ரை பண்ணுங்க. irrigation attachment.
You're not getting the endoscopic pictures.
Now?
Now we have got it. Some venous ooze there.
Yeah, we settled down. Irrigation potacha. So I'm just removing this homework. So I get, see, all is about instrumentation also, yes.
Yes, sir.
We have to get our instruments inside. Relay suction இருக்குங்களா? Suction attach பண்ண. Suction attach பண்ண முடியாதுல்ல? இருக்கு. அந்த சர்வல் தம்பிங்க. This is the cell here. Lux Buddha. Bar. Isn't it section? Section.
Picture is not clear, sir. Yeah, there's a lot of.
Release.
Probably somebody can put the suction on the opposite side because we have opening there also.
Elevator. Harrison. Harrison upturn. Is the picture okay there?
Ah, yes, sir. How far do you remove to make the septictomy, sir?
Like I told you, you have to see all the four walls of the sphenoidal sinus, posterior wall. Wash. You can see the left lateral wall.
Ah, yes, sir.
Okay, this is the right lateral wall.
Yes, sir. Notice fairly, I mean,
yeah.
clear.
Diamond bar, little sir. Diamond bar. Two cut for the straight. Diamond bar. Where's the 15 centimeters. The suction board. Irrigation போதா இந்த பக்கம் போடுதா So this is the carotid artery here.
Ah, yes, sir. Do
Okay,
you have a
this-
Doppler for?
Doppler, I don't, unfortunately,
No,
don't. I'm just drilling the intersinus septum.
Yes, sir.
Since the macroadenoma, sometimes you might have to incise the superior intercavernous sinus.
Okay.
To get the tumor down.
Since this has got supracellular extension, do
Yeah.
you plan any extra procedures on this, sir?
That's what I told. You have to
above.
incise the superior intercavernous sinus and maybe get the incision down there on.
Okay.
If it has got intracranial invasion, then you have to incise the dura. என்ன length இது?
What burr are you using, sir? Is
We
it
are doing a diamond bar with the lengthy one.
what size burr, sir?
This is around 3.5. Yeah. அதே இவ்வளவுதான் இருக்கு. இருக்கிறதே லென்த் தானே. Chisel கொடுங்க. hammer chisel. Chisel hammer. Maybe there is a small defect here. You can see
yes,
that?
sir. Yes, yes, sir.
Yes, coming to the Dura. Chisel hammer. Chisel hammer. இந்த 4 பேர் இருந்துட்டு என்ன பண்ணீங்க? So I'm removing most of the warmer here.
Yes, sir.
So get yardie. Right. Get enough space. Good. Right, black. நல்லா வெங்காயம் எடுத்து கொடுங்க. இங்க clean underscore. ரெடி பண்ணாச்சு. போல்ட் ஆயிட்டானா? நாளை காணும். இங்க எங்க கேஸ் நடக்குதா? என்னாச்சு?
Sir, in case, hello, sir.
Pardon?
In case there is no bulge of the posterior wall of the sphenoid.
Yeah.
So how do you go about in such case?
Yes, that is the most important, especially in children. You will find it difficult. Then you have to trace the carotid, drill out the carotid.
Okay.
Thin down the carotid and then either side and go in between. Lux, you know? What? Unfortunately, we are not having very good birds. Otherwise, our job will be easier.
Yes, sir. Do you prefer a cutting burr than a?
Yeah, I prefer a coarse diamond burr.
Okay.
Coarse diamond cuts as well as doesn't damage the tissue. So this is cellar here with anterior wall which I'm thinning down. Already there's a defect here, this side.
Yes, sir, we can see it.
Now you can see the carotid is here, optic canal, median carotid optic recess. This is our lateral one. So go in the centers, be straight. Paint as arrow to avoid all vital structures. Question. Second bone glass. Section. Last one. இங்க ஒரு கலர் ஒரு மாதிரி இருக்குது. இங்க ஒரு கலர் ஒரு மாதிரி இருக்குது. So this is the clival recess.
Yes, sir.
Okay, the carotid here. So have to this side carotid is here. So we have to remove this part of the bone here.
Okay.
Bend down at least. Bottle போக மாட்டோம். நம்ம ஆர்டினரி மோட்டர் ஆர்டினரி மோட்டர் மைக்ரோ மோட்டர் ஹேண்ட் பீஸ் வேற இருக்கும் பாரு. தர இதோட லென்த் இருக்குமா? இதோட லென்த் இருக்கு. இப்படி
இதோட லென்த் இருக்காமா?
இதோட லென்த் இருக்கு. Irrigation. Yes, good. So this is a diamond course bar. You have the right instrument, it is easy.
Okay, sir.
Venugopal, very good.
You can see the dura coming, shining through the bone there.
Okay, sir.
Further, I'm thinning out the bone or the sella. So better to make a wide, have a wide access as much as possible so that you have a good tumor removal.
Okay, sir. So,
This is the lower part of the sella.
yes, sir.
I'm exposing. You have to extend the like a eggshell.
Okay, sir.
The bone to expose the dura.
Okay, sir.
Okay.
Hello, sir.
Yes, ma'am.
Shankar sir, am I audible?
Madam, Dr. Tamil isn't here. Shankar sir has gone for a
Sir, we have simultaneously started
Yeah,
our
yeah.
last case of left tympanoplasty, sir. Actually, you'll be getting a picture in picture.
Yeah,
with it.
we are getting that. We are
So,
getting.
yeah, Professor Venugopal sir has started.
Okay.
The case of 50-year-old male who presented with left ear mucoid discharge, block and tinnitus for the past 4 months. So he also gave a history of trauma to the left ear 5 months back. And on examination, there was mucoid discharge with a posterior quadrant perforation, sir. Right ear was normal.
Okay, ma'am.
Next slide. Yeah, this is TFT, which was negative, Rini negative on the left with Weber lateralized to the left ear. Next.
Okay.
And this is a PTA which showed mild to moderate conductive hearing loss on the left. Next.
With high frequency sloping.
Yeah, high frequency sloping, sir. This is a HRCT. I think Venugopal sir will explain that, sir. So here we are, this is a case of then left COM with posterior quadrant perforation. Sir is planning tympanoplasty and is now ready to take a tragal cartilage, sir. So you can get that picture within the screen, picture in picture, sir. So he's
Okay,
going to harvest the tragal cartilage.
Okay, ma'am. Okay.
Thank you.
Thank you.
Okay, it's better you started the case, other case. This will take another 15, maximum 20 minutes or half an hour to finish. So I thin down the bone here, the antipart is cella.
Okay, sir.
Okay. So further I'm going superiorly to get more exposure. Rest with us.
Good afternoon, sir. This is Naren here, sir.
Dr. Naren.
Sir, thank you so much,
Welcome,
sir.
welcome. You are a bit late.
Thank you, sir. So
Wash.
happy to meet you here, sir.
Wash. Wash. I don't know. பண்ணுமா இந்த பாக்கெட்ல I can feel bone is thinned down.
Okay, sir.
Good afternoon, all.
Good afternoon, Venugopal, sir.
Good afternoon, Tamilarasan.
Yes, sir.
Just simultaneously, I'm also starting a case of left ear cartilage tympanoplasty.
Okay, sir.
Patient is having central perforation involving the posterior half of the tympanic membrane.
Okay, sir. So under GA or local anesthesia, sir?
It's under local anesthesia.
Okay, sir.
IV sedation.
Okay, sir.
And I'm going to use only tragal cartilage with perichondrium without using the temporal fascia.
Okay, sir. You're harvesting perichondrium on both sides, sir?
No, I'm harvesting perichondrium on one side.
Okay, sir.
Are you able to see the cartilage being harvested?
Yes, sir. We are getting the picture in picture.
Yeah.
Good afternoon, sir. This is Naren, sir.
Good afternoon, Naren. So,
Sir, what
happy
about the
meeting here
anesthesia
also.
agent, sir?
Huh?
What about the anesthesia, sir? Local anesthesia, what was the drug using there, sir?
Yeah, pre-medication given
Okay, sir.
with IV midazolam. And then the local infiltration, I usually prefer 10 ml 2%, 10 ml distilled water
Okay, you
with
can
half a
see,
cc of adrenaline.
Okay, Mike Leo.
Why temporal fascia, sir, not using any specific reason, sir?
Not a question of
Reason.
not
After.
it's not that I do not prefer the temporal
After.
fascia. That is avoids an incision and you are getting equivocal results with cartilage and perichondrium itself. So
Maybe-
avoid one more incision for the patient. Tooth process.
Sir, Sundarkrishnan, sir, now the dura is exposed, sir?
Yeah. You can see the Durazil. I'm just making the opening little bit large.
Okay, sir.
So you can use a kerosene punch. That's you have to be careful.
You can shift over to Sir's case. After I have elevated the flap,
Dura
we can come back here.
with the kerosene punch. Like
Okay,
this,
sir. Okay, sir.
Okay.
so that you don't injure it.
Sir, extending only superiorly, sir.
No, now at present I'm doing that.
Okay, sir.
I will extend it even laterally. Inferiorly, I think the upper.
Already the defect in there in field.
Yes. The Savlon will put it. अच्छा இது மூணு சிப் எனக்கு 11 blade long handle ரெடி பண்ணுங்க செக்ஷன் straight forceps left hand பண்ணுங்க
The eggshell gray cracked bone is being removed, sir.
Pardon?
The eggshell cracked bone is being removed now, sir. Over the sphenoid.
Yeah. அங்க போடு பாக்ஸ் ஏமா ஏதோ போர்சப்ஸ் கேட்டா என்ன பண்றீங்க ரைட் கூட the elevator கூட the long elevator கூட. So that is the tumor is coming out.
Okay, sir.
இது இன்னொன்று இருக்குமாமா யாருமே access பண்ணுங்க எவ்வளவோ கிளாரிட்டி இல்லைல்ல yes the dura is breached here can you make out
The inferior part, sir.
ஆமா வெர்காஸ் நல்லா க்ளீன் பண்ண டிப்பு 11 blade லென்த்தியா வச்சிருக்கீங்களா டிப்பு நல்லா க்ளீன் பண்ணிருக்கேன் elevator இந்த செக்ஷன் அந்த செக்ஷன் ரெண்டு செக்ஷன் மாத்திக்கோமா செக்ஷன் போட்டு எடுத்து விட்டுருங்க கரிசன் கொடுங்க ஆப்ஷன் அவனுக்கு சஸ்பெண்ட் பண்ணுப்பா. இங்க போன. There you go, wash the mooding now. Good. Knife blade எடுத்து வச்சுங்க. இந்த 2 செக்ஷன் எடுங்க. 2 செக்ஷன் வச்சுங்க. You always keep the camera head straight.
Okay,
So
sir.
always in the midline.
Okay, sir.
11 blade.
So the dural incision will be a cruciate or a U-shaped flap, sir?
I'm going to do a U shape. Okay. Blade. இன்னும் கொஞ்சம் room. I'm incising in dura.
Yes, sir. Yes,
U shaped as I told you, including the already breached area.
Okay, sir. Okay.
Okay.
The tumor bulges out.
Yeah. Elevator. Rosens, long rosens. Long rosens.
What about intercavernous, sir? Superior intercavernous, whether it will be cauterized, sir, for this case?
If necessary, we'll do that. I'm evaluating dura superiorly. I think Narendra has freshly come from States. You might be having a lot of questions.
Never to you, sir.
You are more qualified than, yeah. You can see the tumor mass there.
Yes, sir.
Clean, clean. So in all this type of microadenomas, what you have to do is start tumor removal from below. Okay. So
Yes,
that the diaphragm doesn't come in the way. Forceps, biopsy forceps. But goes biopsy forceps. Now I'll just take a biopsy. No, biopsy. I think it is a suckable tumor. What do you think?
Sir, in this MRI, it was a solid and cystic areas. No, sir?
I am removing the tumor below. No?
Okay.
Initially, so that the diaphragm doesn't collapse. எனக்கு இது கொடுங்க ரோசன்ஸ் நான் எலிவேட்டர் கூட So this is the supraclavial part which I'm dissecting now from the dura.
Okay, sir.
Yeah, the structure. Black is straight. Here was a butterfly. Don't correct it. Okay, now I'll extend the incision above. Is that correct? No, knife. Correct. So while doing that, you have to be very careful.
Okay, sir.
So you don't injure the diaphragm. Incorrect. Incorrect. Yes, the more tumor is coming out, curate பண்ணக்கூடிய சாப்பிடலாம். Biopsy enough material வந்திருக்கா? Earlier, forceps. Forceps. ஏன் அவ்வளோ எடுத்து கொடுத்துறேன்? கரைஞ்சிருச்சா? வந்திருக்கா? Curate. Since it's not suckable, I'm using the curate.
Ring curate, sir.
Yeah. Section. இதுக்கு நடுவில் போடு. சர்ஜி செல் எடுத்து வச்சுங்க. சர்ஜி செல் எடுத்து வச்சுங்க. பயாப்சி வந்திருக்குல்ல, அவ்வளோதான் வரும் அது. பண்ண சொல். சாலிடாக தான் இருக்குது. யூரிட்ல வருமானம். One advantage of endoscopy, you can go inside the cell itself and inspect.
Okay, sir.
So complete tumor removal is there or not. You can see the upper part of the tumor. Okay, I'm removed the lower part now.
Okay, sir.
இதை கொஞ்சம் உள்ள போ வழி விடுங்க. இல்ல அது சக்ஷன்
உள்ள போட்டு
கொஞ்சம் நான் உள்ள போன பிறகு சக்ஷன் இருக்கும். So I'm trying to remove it more laterally towards the cavernous sinus region.
Okay, sir.
இப்போ போடு சக்ஷன். அரக்கு கிரட் வர சக்ஷன் கிரட் வர காமி. Humerus partially debugged. Huh?
Yes, sir.
So that is the posterior part there. Can you see that?
Yes, sir. Yes.
Posterior part, and the diaphragm is coming slowly down.
Yes, sir.
So you should usually descend like a balloon.
Okay, sir.
But only you can see the part of the diaphragm there. Yeah.
Yes, sir. Yes, sir.
Balloon Mari I am removing laterally.
Yes, sir.
The carotid recess, cavernocarotid recess. Wash. இந்த சின்ன மரம் செல்ல சலாய அட்ரினலின் ஸ்டாப் பண்ணிக்கிறேன். சின்ன பீஸ் இந்த ஸ்லைட்லி கர்வ் செக்ஷன் கூட டவுன் கட்டிங் ஃபோர்செப்ஸ் கூட கரிசன். So I will widen the cella here floor.
Okay, sir.
I put my instruments better inside. So you can see the diaphragm coming down. So for complete tumor removal, it should come down even further.
Okay, sir.
Okay, I will just down cutting kuduma. Kerisen. The repair and the confusion na. Okay, I think the intercavernous sinus. You're right. So this part, anterior part has to be debugged completely.
Okay, sir.
So that the optic curve. You can see the tumor coming out.
From the lateral parts.
Yeah, lateral cavernous.
Carotid cavernous.
Right, carotid cavernous. From just this all tumor here. In the section. Mm-hmm.
Hello.
Yes, sir. Venugopal.
Yes, Dr. Tamilasan. I have harvested the tragal cartilage with perichondrium.
Yes, sir.
And I have freshened the edges of the perforation. You can see there is a perforation involving the antero-inferior and the posterior-inferior quadrants.
Yes, sir. Yes, sir.
Freshen the perforation edges of the perforation. You can see the middle mucosa is not edematous.
Okay,
Patient is also free of discharge for the past 2 months.
Okay, sir.
Now he is making the incision to elevate the tympanomeatal flap.
Okay, sir.
Actually extend it from around the 1 o'clock position till the 6 o'clock position.
Okay, sir.
Laterally I extend it till near the skin, so that it's a little thicker, more laterally, because it's a little thicker. I want it to be a little thicker. I do not want the flap to tear.
Okay, sir.
Correct. Mm.
So the canal seems to be a little narrow, sir, for you.
Yes, you are exactly correct. There was also a lot of hair on the lateral aspect. Actually, I have shaved the hair.
Yes, sir.
And the canal is a little narrower, and there is also an anterior bulge you can see.
Yes, sir. The rosen completely blocks the middle ear.
Exactly.
Carotid cavernous.
Just elevating. I have given an infiltration. I give a single point infiltration only, which accesses all the 4 quadrants till the point that it lifts the annulus and the infiltration seeps into the middle ear.
The cystic part of.
Yes, sir. That cystic part will be drained, sir.
Recently, we.
I don't think it's a tumor there.
Okay, sir.
So we can leave it. What do you say, Dr. Jodhika?
Yes, sir, almost completely removed. I like to say that after cutting the dura, one thing is you should not use any sharp instrument. You use always 2 instruments. One is ring curate, another one is section. Mostly the tumor will come by section only. If you use any sharp instrument or any punch, inadvertently you injure the carotid. I encountered 2 cases carotid injury during removal.
Okay, sir.
Not use any sharp instruments or any biopsy forceps inside the dura.
Okay, sir.
So that is definitely the cystic part of the stella there.
Okay, sir.
Suggestion. So this surgery cell I'm inserting into the cell of one for hemostasis, and with that inside we can dissect part of the tumors. Another thing is put a marrow cell. இவரு நான் உள்ள வைக்கிற ஒரு எழுத்துன்னு போறாரு.
So now you're packing surgery cell, sir?
Yeah.
So the patient had a optic asthma compression, sir, pre-operatively.
Yes, yes.
Yes, sir.
That is the
Bitemporal hemianopia is there.
that is the reason you're operating to decompress.
Yes, sir. The optic asthma is above this cellar, sir.
He's been having this for the past 2 years. He was not relaxing.
Okay, sir.
I think the ophthalmologist there in the.
Okay, sir, I'll give it to madam.
She'll explain.
Is a very young male who presented in the IOP with complaints of inability to see on the sides, on the left side, left half, right side, right half. Yeah. Bitemporal hemianopia. And even the board, it was the same. Couldn't see the left half and the right half. Color vision was normal. Vision was 6 parts. Eye movements were normal. Pupillary reaction, normal. Fundus also was normal. So though we have given guarded visual prognosis, we're a little optimistic because the fundus was normal.
Thank you, ma'am. Thank you.
Endocrinology also nobody.
காட்டன் பால் வந்து சோக் பண்ணி கொடுக்கணும். காட்டன் பால் கொடுத்துருக்கேம்மா. மருந்து போடணுமா? இல்ல.
See, the diaphragm is completely coming down.
Yes, sir.
See a bit of tumor here.
The cystic part, sir.
Flag knife, flag curate.
அந்த இதை விட half the size தான் இருக்கணும்.
So you still feel macroadenoma or craniopharyngioma, sir?
It is a macroadenoma.
Okay, sir. But the hormones were normal, madam said.
Yeah, normal. Usually macroadenoma is hormones will be normal. It's a non-secreting tumor.
Okay, sir.
Microadenomas are most elevated. Slightly curved section.
What is the reason for cystic?
எனக்கு என்ன கேட்டாங்க? இல்ல இன்னும் அதுக்கு முன்னாடி என்னமோ கேட்டேன். So I'm using a flag curate. This is useful when you are dissecting in the cavernous region.
Blunt curate, sir?
Yeah.
Okay.
So cavernous region, you can use this safely. Suction. Position.
Annulus இங்க கீழே வந்துடுச்சு. காடாவும் மேல இங்க பாருங்க. இது வந்து காடா. இங்க இருக்கிறது annulus. ஓகே. எது? ஆமா. இல்ல.
A little bit of tumor is left here.
இல்ல. அது மிடில் இதுதான்.
We're using a slightly curved suction tip. So you can see that is the cystic part.
Okay, sir. Okay. It is now being opened, sir?
No. I'm leaving it.
Pushing, compressing it, sir?
Yes.
Okay, sir.
So I'm removing the tumor around that. See that?
Yes, sir. Yes, sir. The soft white part, pale grayish.
Okay, now we can see it is clear. Okay.
Yes, sir. Yes, sir. Yes, sir.
With Dr. Narendra, what is your opinion? Naren, has he gone for?
No, sir. I'm here, sir. Yeah, sir. It's clear, sir. Sir, can we see a little inside, sir, with the endoscope? The view, sir.
Yeah.
Dr. Kruba is also here.
Hello, sir.
Hi.
Sir, can you add a small note on hemostasis if there is a bleeding from cavernous sinus? Sir?
Nothing. Be patient. Put some surgical. Wait for some time. Compression. That's enough. A little bit of humor.
The right side, right lateral, sir.
Yeah. That is the carotid cavernous recess. The carotid will be here.
Okay, sir.
Maybe I'll show you the pulsations.
Arachnoid, carotid pulsation.
Carotid. So this part has to be removed as much as possible to completely decompress the supracellular part. So I'm doing patiently and slowly so that the cavernous sinus will not be injured. Now you can see the dura of the cavernous sinus here.
Yes, sir.
Yes, sir.
This is the dura.
Yes, sir.
Okay, little bit of tumor is sticking to us. You see pulsation, then that might be the end of tumor removal.
Yes, sir. Sir, what is the role in lumbar puncture in your cases, sir, for this type of cases? Lumbar drain?
Lumbar drain, I don't think is necessary. If you want to bring the supracellular part down, during surgery you can ask the anesthetist to do a Valsalva or else lumbar puncture and push them. Yeah. Surgery. கையில் எலிவேட்டர் தான் வச்சிருக்கேன் தள்ளி விடுறேன். So we almost finished. Okay. தள்ளி விடுறேன்.
இப்போ இதுல செக்ஷன் போட்டு எடுத்துருவோம்.
இன்னொன்னு கொடுமா.
What is the plan in reconstruction, sir? Fat will be used.
You want me to use flat? Yeah, because the idea is give me such. The idea is to decompress the object now. So we removed and debugged it. So it will come down to the normal position.
Okay.
If you put more fat, I don't think so. What do you say, sir?
Sir, if there is any CSF leak, obviously we go for fat, graft, and fascia. Otherwise, not necessary. I think. Reconstructing with the flap is enough.
Yeah, that what the flap you harvested will
Okay,
do
sir.
it. Now this is the final stage. I'm just going to use this blunt.
Another thing is, if you fill up the filla with the fat, in MRI will be like a tumor.
Yeah.
Yes, sir.
See, I am using surgical to just remove the remnants and as well as for hemostasis. Somebody has asked for hemostasis. In this way. Not insect பண்ணிட்டு எப்படி வந்துச்சான்னு ஃபுல்லா வந்துச்சான்னு பர்ஃபெக்ட் வாஷ் பண்ணு
அந்த இடத்துல நல்ல எடிமா டெவலப் ஆயிருக்கு. ஆமா.
Okay, you can see the dorsum cella there.
Yes, sir.
Most of the tumor has come out.
Light உள்ளே போகும் சார்.
I'm just leaving the surgical there, and Dr. Mauri will place the graft. Gel form.
Okay, sir.
Okay, you can see that. You will Valsala பண்ணு. Valsala. Valsala. So we'll do Valsala, see any CSF
leak.
Correct.
Okay, there's nothing.
Okay, sir.
Gel pump.
Alice handle தான். அது மேல இருக்கு.
Okay, that's it. We'll go to Dr. Venu's case.
Sir, thank you, sir.
Yeah.
Give a big hand.
Sir, thanks for teaching us. Thanks for the opportunity. And
Yeah,
we
welcome. The
thanking
idea-
for lifelong for you.
The idea of doing such workshop is to teach people so that they can do good work.
Yes, sir. Yes, sir.
I hope you
Always.
have benefited
Yes, sir. Yes, sir.
the workshop. More
Yes,
help.
sir.
More helpful. Rajiv is already tissue. Rajiv, tissue.
Sundar?
Yeah.
Vasudevan.
Solo, sir.
Very nice work, fantastic work.
Thank
the
you.
workshop, it is not, it is on either end of the spectrum. When we started with the normal anatomy of the, nasal cavity and almost a normal CT scan, there is a class on anatomy. Then I thought it's going to be very fundamental. Now we have very high funda case coming up, and it's both extreme and both are necessary.
Yeah.
So when we started with endoscopic sinus surgery, attending workshops since 1994, the composition of the workshop has been changing. So those days there are all big cases, lot of cases, and lot of teaching. And slowly what happened, it's all demonstration and less teaching. So I thought there should be more teaching, especially for the beginners. We assume that certain things are known to everybody, but we should not assume that. In every workshop, we should start from the basics, and then it will be useful for somebody or other.
Yeah,
So this
you
is
should
really a
also
good concept.
thank our fellow surgeons who have done a perfectly beautiful job of demonstrating.
Yeah. Fantastic. Yes. That's really.
Give them a big hand.
Hello, Dr. Tamilsan.
Yes, sir. Yes, sir. We are following your case. The picture in picture can be transferred to the Venugopal sir case.
Okay.
Sundar,
Yeah.
there's another concept which I've always been advocating the past so many years, that we should try to pull down our cases and do together. So that is one way of learning and one way of doing the right thing. So I, in fact, suggest to the juniors that they should try to make use of this type of resource and try to get together and you can learning also first-hand learning, and it will be really a hands-on training. So I in fact suggest to the juniors that they can in fact take their cases to Sundar Krishnan and be there and learn. It's a great opportunity because in our days I remember everything was kept as a secret. So no one used to teach so openly. So this is really a great gesture for the juniors. So people should make use of it.
Subtle flap better.
Sir, Venugopal sir, you are trimming the cartilage, sir.
Yes, yes, I'm trimming the cartilage. You can see that.
Both side perichondrium on.
No, there's perichondrium on one side.
Okay, sir.
You can see that there is absence of perichondrium on one side. I keep the perichondrium facing the lateral aspect.
Yes, sir.
Saline. Now I'll just reposition the flap. Okay, here I have made the incision. I have elevated a tympanomeatal flap.
Okay. Okay, sir.
Yeah, you are able to see the eustachian tubal orifice opening nicely.
Yes, sir.
Just a minute, I'll just put the suction and show you. The patient in the box. Actually, it's actually a little narrower canal. You can see a hump also.
Yes,
so there
sir,
was some difficulty in elevating the annulus, but you can see that the annulus is seen underneath if I put the suction.
Yes, sir. Yes, sir.
Okay. Suction close. Okay.
Sir, you slice the cartilage or thin it out, sir?
Yeah, I have not exactly thinned out, but taken a thinnest portion of the tragal cartilage. I have harvested a bigger cartilage and used the thinnest portion. I have not actually spliced it, but.
Same way, you will keep the cartilage flap, then put gel foam, or gel foam won't be put, sir?
Actually, I do not keep gel foam anywhere inside the middle ear.
Okay,
Whether I put temporal fascia graft alone or a cartilage, in either way, I do not keep gel foam inside the middle ear. Even if I put only temporal fascia also.
This cartilage will go under the malleus or over the malleus, sir?
The cartilage goes underneath the malleus.
Okay, sir.
What is the status of the ossicular chain?
The ossicular chain is intact, sir.
Movement
at 35 dB hearing loss.
You're able to.
Yes, sir.
Right reflex.
Raise the flap such that we are able to see the anterior rim of the perforation is seen, sir.
Okay, sir.
We are able.
Why gel foam is not being used? Any reason?
No, sir. I find that there is more chances of infection if we leave the gel foam inside. And the results have been very good without using the gel foam itself, sir. So I don't find the need to use the gel foam here, sir. Cartilage.
Sir, you looked into the adductor, sir. The patient in CT had a soft tissue thickening, acute otitis media findings were there.
No, the patient had mastoiditis. It was not acute otitis media.
Okay.
The patient had fluid inside the mastoid access system, but the mastoid access system was not sclerosed.
Okay,
the
sir.
adductus was not blocked.
Okay, sir.
There was some fluid or haziness inside the clouding of the mastoid access system.
Okay, sir.
But patient did not have any discharge for the past 2 months.
Okay, sir.
So, and the adductus was not blocked on the CT scan findings also.
Okay, sir. You made any slit for the malleus, sir? Or
No. I will make a slit. I'm just seeing if this size is big or fits in. Yes, exactly. Yeah, it looks a little bigger, so I'll just trim it before putting it up. ஒரு இது scissor கொடுமா?
Actually, must ask the PGs to ask doubts. The postgraduates should ask the
A cartilage slicer is not necessary.
No, sir, it is not necessary, sir. If you splice the cartilage, sometimes it leads to warping, sir. So that is why we do not use that cartilage splicer, sir. And this does not produce any disturbance to the hearing, sir. No, suction பிடிச்சுக்கணும். Suction. ஒரு நிமிஷம். சக்ஷனோட சவுண்ட் சொல்றாரா?
They are getting overwhelming. Got to do it. No, sir, it is going on.
Vikram only.
When the eye operation they did at the time. I OP at the time. I examination at the time. I started subjective at the time. Or with the pituitary எல்லாமே
போட்டிருக்கு சார்.
ENT were single specialty. Recently, where French doctors were there.
ENT hospital US la irukku. ENT. But you should not have the OT. OT deadly.
ஆட்டாதீங்க.
So whenever there is a ENT case, you should see. நான் எப்படி இருப்பேன்ட்டு actually different theater. இந்த theater எப்படி clean பண்ணோம் பாருங்க.
வலிக்கு ஊசி போட்டுட்டாங்க, வலி இருக்காது இனிமே. ஆட்டாதீங்க.
இந்த பொண்ணு இல்ல, she is an ophthalmic technician assistant.
என்ன பண்ணுது?
Ophthalmic scrub nurse. இங்க இருக்கிற பொண்ணு வந்து எலக்கியா.
ஹலோ.
Yes, sir. Venugopal, sir.
Dr. Tamil, you can see
yes,
that
sir. Covered entirely up to the anterior.
Up to the anterior rim, and you can see the perichondrium jetting out of the perforation. The small slit which I made accommodated the handle of malleus.
Super, sir.
Just a minute, I'll just show you one more time. Yeah, now I think it's much more clear. And since it's the perichondrium with the cartilage, the chances of lateralization is much less.
Yes, sir. Yes.
Hello.
Okay, Tamil?
Yes, sir. Nice one, sir. Thank you, sir. Thank you.
Thank you. Thank you. I thank
So-
Dr. Sundarkishan sir for and Kantamani madam for giving me this opportunity to showcase this in their conference. Thank you, sir. Thank you for the wonderful opportunities.
Hello.
Yes, sir. You're
Hi.
on the screen, sir. We can change it to a bigger screen, sir. Yours.
Yeah. It almost come to end our workshop. A short workshop, but I think most of you would have benefited from this. Is it so?
Yes, sir.
Yeah.
Oh, sir.
So I would like to thank everybody who attended, the delegates. More importantly, the patient and Almighty God for everything have gone very smoothly. I would like to thank the sponsors, major sponsors, the Sun Pharma people, the other sponsors like Gladstone, Dinoc, Serval, and yeah, for Striker, given material support, and also they are in future they are going to give us some amount. I hope so. I would like to thank our colleague, especially Siddiq, Venu, and Mauli for being here and enlightening the people with their skills and knowledge. I think it would have been a tremendous information you gained through this workshop. And I would like to thank all my staff also who have worked day and night to make this surgical workshop a success. Are you able to hear me?
Yes, sir. We are not
Yes.
seeing the picture, but we are able to hear you, sir.
Yeah, they're reloading it.
Okay, sir.
So all of my staff have been here day and night. I mean, for the past 2 weeks they have been on job. Especially, I think none of them have slept yesterday. And huge thanks for them, and I need an applause also for them. I would like to thank also my better half who's been the organizing committee. Organizing committee and conducting the things over there along with Vikram. And the book release was done today, which is also a highlight of this workshop. I hope all of you will be benefit by reading that book.
Ointment pack.
I would like to thank the audiovisual people who have been doing a great job. Okay.
Co-faculty, surgical faculty.
Yeah, of course, the patients are the important thing, and I also thank them being very cooperative and helpful. I think we have come to the conclusion. If they are asking you to vacate the hall,
Yes,
Yes, sir.
please go ahead.
Thank you, sir.
Bye then. Thank
Bye,
you,
sir.
Vasudevan. Thank you.
Thank you, sir. Thank you.
Sivant, thank you very much. Our anesthetists also have done a terrific job. Dr. Rajkumar, Shivan, our Muthu, the OT assistant, our Pradeep, who have been along with us, OT staff, the anesthetist. I'd like to thank also Dr. Sumita and Jayanti who have been here coordinating in the operation theatre. And hope I have not left out anybody. Thank you very much.
Thank you, sir. Thank you, sir.
ஒரு ஸ்ட்ரிப் மட்டும் வந்து ஒரு ஃபிங்கர் லென்த் கட் பண்ணா போதும்.
அவங்கலாம் எத்தனை மணிக்கு வருவாங்க?
நடராஜன் முடிஞ்சது சரியா? நல்லா இருக்கீங்க சரியா?
இன்னும் கொஞ்சம் ஆயின்மெண்ட் வாங்கிக்கோமா. ஆயின்மெண்ட் இன்னும் கொஞ்சம் வாங்கி தடவிக்கோ. ஏன் அதுல பாதிக்கு ஆயின்மெண்ட் தடவிக்கோ. உங்களை பாக்குறது.
இருங்க கையை தூக்காதீங்க.
இல்ல பேக் வைக்கணும்.
இருங்க ஒரு நிமிஷம்.
ஆமா ரெண்டு சைடு.
பேர் என்ன? பேர் என்ன?
டீப் sedation. அந்த ஆப்போசிட் சைடுல போதும். இன்னொரு சைடு இல்லம்மா, இதுல இருக்கிறத மொத்தமா இன்னொரு சைடுக்கும் தடவிக்கோமா. அவ்வளவுதான் பண்ணுவோம். ஆர்டி ஃபோர்செப்ஸ் கொடுமா. ஆர்டி ஃபோர்செப்ஸ் கொடு. ஏதோ ஒண்ணுமா பரவாயில்ல.
இந்த ஒரு பஞ்சு வச்சிரு பாருங்க. பஞ்சு வச்சுக்கலாம். நல்ல வேளை முன்னாடி நம்ம
சிசர் கட் பண்ணுமா.
ஃபியூச்சர் போட்டோம் பஸ்.
ஆமா பஸ். ஆமா அதுவும் கரெக்டா வெளியில வரும்போதுதான் இதானாரு. இங்க கட். பாத்து. சரி. இன்ஸ்ட்ருமெண்ட் வாஷ் பண்ணி கொடுத்துறியம்மா. நான்